Okay. Good morning, everybody. I think everybody has a seat. Good morning. It is with great pleasure that I welcome all of you on behalf of Médecins Sans Frontières, MSF, or Doctors Without Borders, to this MSF Scientific Day South Asia. I am Martin Sloot, and I am the General Director of the MSF India office. I want to provide a special welcome to the chairs, to the presenters, and our international guests from the region. A special welcome as well to our keynote speaker today, who is Dr. Soumya Swaminathan, and she's the Director General of the Indian Council of Medical Research. Since we are live streaming this conference, a warm welcome to all our online guests from the region and literally from all over the world. We welcome the MSF staff and members from MSF South Asia Regional Association who are viewing today's proceedings in our field projects in Mumbai, in Manipur, in Srinagar, Nagaland, Bhadrachalam, but also in Sri Lanka, in Myanmar, in Bangladesh, Pakistan, Nepal, Uzbekistan, Russia, and many other locations. MSF is an international, as you know, medical humanitarian organization which provides assistance to vulnerable populations living in difficult and resource-limited settings. In India, MSF has been working since 1999, providing medical treatment to thousands of patients in Bihar and Chhattisgarh, Jammu and Kashmir, Maharashtra, Telangana, West Bengal, Delhi and Manipur. In our field projects, we are often faced with situations where effective and proven medical interventions are lacking. It is here that MSF sees the opportunity to improve medical care by conducting operational research and sharing this information. This has driven MSF to become an important contributor in public health research and has ensured that we spend our resources and allocate them at field level and offices. We have set up our own ethics review board, a fund for innovation, a public repository for all the research we do, and we regularly contribute to major scientific conferences. In addition to this, MSF is hosting also days like this, MSF Scientific Day South Asia. Operational research in MSF is focused on descriptive studies, often cohort studies or cross-sectional. The research aims at not just identifying the constraints and challenges of implementing each program's medical activities, but also in finding solutions which are patient-centric, practical, and relevant. As an organization that is constantly seeking to improve the quality, relevance, and extent of its assistance, operational research helps MSF in its pursuit of medical innovation while alleviating the suffering of its patients in a more concrete manner. For MSF, as a global medical humanitarian organization, the South Indian perspective is obviously invaluable. This year is the second year, and I hope many more years will come, that we are organizing this conference also from Delhi as a partner event from the 2 days which were already held last week in London, and a third event with the same name which will be held on the 9th of June in South Africa, Johannesburg. The aim of today is to exchange medical research relevant to and to build engagement with you, the medical community, in not only India, but in whole South Asia as a whole, in order to broaden the overall scope and impact of the research. Our vision is to connect audiences, stimulate analysis, and initiate debate on the state of healthcare in South Asia to further improve our medical activities for the patients. We hope, therefore, that the discussions today will continue beyond the end of this conference alone. Our call for abstracts for this day went across MSF, but also partner organizations and institutions, research institutions, with whom MSF is already collaborating and hopes to engage more. We received submissions from across South Asia, as well as internationally, and today, and you can see that in the booklet, we have presentations from Myanmar, from Pakistan, from Nepal, and India. But we will also showcasing research done in Uzbekistan, Iran, and South Sudan, whose findings, although not originating from the region, are, we consider, very much relevant to the South Asian context as well. I wish you all a very stimulating day, and I look forward to an active participation in the presentations and discussions. Now I would like to introduce the chair of the day, and the chair of the day is Dr. Uni Karunakara. Dr. Uni Karunakara has been a humanitarian worker and a public health professional for 2 decades, with extensive experience in the delivery of health care to neglected populations affected by conflict, disasters, and epidemics in Africa, Asia, and America. He was the medical director for MSF's campaign for access to essential medicines, and he was also our international president from 2010 to 2013. Uni serves on the board of directors of DNDI, which is the Drugs for Neglected Diseases Initiative, in India, and he also serves on the board of MSF Holland. In 2001, he helped found Vivo, an organization that works toward overcoming and preventing traumatic stress and its consequences. Currently, he's a senior fellow of the Jackson Institute for Global Affairs at Yale University and a visiting professor at Kasturba Medical College at Manipal University. Uni, may I invite you to come? Thanks.
Welcome, everybody. So I want to join Martin in welcoming you all to the Scientific Day here in Delhi. It's going to be a very hot day, so I recommend that you stay in and follow all of the sessions. I'm going to stick to time. I think my job is to make sure that all of the sessions start on time and finish on time. So before we do that, a few housekeeping messages that I want to go through. Now, as you can see from the program, I hope everybody has one of these. So the programs are laid out. We will have one session on HIV-TB this morning, and just before lunch, we will have the keynote address by Dr. Soumya this morning, Soumya Swaminathan. And we'll have lunch break, and then we have 2 sessions and another really interesting presentation on 3D printing in the afternoon. And we'll aim to finish latest by 5:30. Now we have, I'm sure all of you have this USB stick with you. It must be in your bag, in your packet. And this USB stick contains a lot of information. So the 2016 edition of the research book, and it's updated this month, you will have more than 70 research papers in this book. And there's an e-book, and there's also much more information about MSF, the projects that we have in the country, and also in the region. So I really urge you to use the USB stick and explore the contents. It's better than having a big, heavy book to take home with you. So the USB stick. Now, few housekeeping messages before we get started. First, I'm going to keep time, so I hope everybody will respect the presenters, make sure that you're seated on time, and we have a tight schedule, so we should respect that. Second, please make sure that when you ask questions, use your microphones, use the microphone, state your name, state your affiliation, because it's not just the people in the room, there are people following online, so it's also, they know who you are. So that's, please use the microphones. Next, we have a videographer, we have a photographer. They will, you'll see them with cameras walking around. They may take your photographs. But more importantly, as Martin pointed out, this is going to be telecast live, and there are people following from all over the world. Martin, I don't quite remember whether you told the audience that this is one of 3 days, 3 scientific days that we have. Last week we had the scientific day in London. Today we have it here, and next week we have a scientific day in Johannesburg. So there are people from all of these places watching the proceedings today. Now, the conference materials are available online. There will be a full video that'll be available. It's being live streamed, but also it'll be available for you guys to watch later in the day as well. It is very important. This is the second scientific day that we have in Delhi. It's very important for us to know what you think of the day, how you what you think of the presentations. So it is important that you fill out the evaluation forms at the end of the day. So please, it is a very important feedback that we really would like to have it. So please don't forget to fill the evaluation forms. All right. Now, I want everybody to take your phones out of your pocket, please, and switch it off. I mean, put it on flight mode or turn the ringer off. Absolutely important. Please take it out and do it as I do it. All right? So that's showing respect for the presenters. And if you want to use the phone, please go outside and use it. Now, there is a Wi-Fi. There's Wi-Fi in the room. The codes are available if people need it. So please ask the ushers if you need Wi-Fi codes. Now, if you tweet, if you are the tweeting kind, then please feel free to do so and use the hashtag MSF SCI, SCI, SA. That's for South Asia. So please use the hashtag, and then people can follow much easier. No food and drink allowed in the auditorium. You can bring in water. That's the only drink that you can bring in. It's the rule of the IIC. So no violating that, please. No coffee, no tea in the room. The toilets out through the door, and you go 1 flight stairs. That's where the toilets are. And the last thing I wanted to point out was the fire exits. So it's to your left and to your back. All right, I think that's it. I think that's it for me. I'm going to introduce the first session. So the first session is on HIV/AIDS. And I would like to introduce Professor Rohit Sareen. Dr. Sareen is one of the leading technical experts on TB in India today and has made significant contributions to the field in TB prevention and control in India. He's the director of the National Institute of TB and Respiratory Diseases, an autonomous institute functioning under the aegis of the Ministry of Health and Family Welfare. Until 2016, he was the chair of the WHO's Regional Green Light Committee for Multi-Drug Resistant TB in the Southeast Asia region, and remains, even though he's not the chair anymore, he remains a member of that committee. So I welcome you, and you will introduce the other participants of the panel. Thank you.
Thank you, Uni, and very warm welcome to all the August audience. I see very, very senior people here, and I see enthusiastic young crowd as well, eager to go into the scientific world. At the outset, I'd like to, I would say, congratulate the MSF South Asia division here under the leadership of Martin and his team for organizing this most important global event. This is the second time they are doing this activity, and the experiences of the first time are still fresh with us, and I would really appreciate the way that entire program went. And I'll also like to thank them for, making me part of their team in this effort. The morning session, we will have 4 speakers, and the session is probably I would put it one of the most important sessions, because it deals with an issue which is a burning problem not only within India but within this region. And we are now, yes, friends, talking about tuberculosis and HIV both. And we have presenters who will share their experiences and their researches in these areas. And we have not only the experience from India, but also from other countries, wherein it would be good learning for all of us. So the first speaker for the day is Andrea Inserti. Andrea is a medical doctor from Rome, and he holds a master's degree in international health policy from the London School of Economics. Andrea, welcome to the dais. And he has been working with the MSF in different settings and positions. Most of his work has been in Southern African region. And recently, he has also now moved on into Myanmar, and he was with other international organizations like the WHO. He's worked with them for some time. And he will be, sharing his experiences on long-term clinical, immunological, and virological characteristics of HIV-infected patients on retroviral therapy in southern Myanmar. So the floor is yours, Andrea. You know the rules. The presenting time is about 12 minutes, and then for clarifications, we would have another few minutes, and then we move on to the next presenter. I'm sure that with your experience, you will be able to stick to time. Thank you.
So, thank you so much, everyone. Good morning. The first things about this study came into my mind. It's a song that say, "In this great future, we cannot forget the past." It's a quite famous song, and it's exactly the principle on why we look at this study. HIV has been changing so much in the last 10 years in terms of drugs availability, monotherapy, triple therapy, viral load, point of care, CD4 count. But we felt that it was nice and probably a good exercise for us to have a look about what is our achievement in 10 years' times, what has been done, what is the main outcome, and what could be a good lesson learned for the future of our operation as well. So we decided to have the best way to do that could be probably a description of what is clinical, immunological, and virological characteristic of the HIV cohort patient in Myanmar, where we are working with MSF Swiss. Very briefly about Myanmar, it's a concentrated epidemics, as most of the country in southeast region, and highest prevalence it's in people injecting drugs, men having sex with men, and female sex worker. In the general population, it's just 0.5. MSF has been working next year will be 25 years in Myanmar, but since 2004 it's collaborating with the MOH and especially with the National AIDS Program. There are two sections. There is MSF Switzerland and MSF Holland. The colleague from MSF Holland will present later on. While we, as OCG, we are focused mostly in the southern region, in Tanitari division especially, that is on the border with Thailand. And specifically, we have a clinic in Dawei where we are treating HIV, TB, and recently also hepatitis C, and any kind of co-infection. So when we decided to have this rationale, we also noticed that there was not much literature available, especially in the long-term outcomes of ART project in low-middle income country, obviously, and especially even less in Myanmar. So as I said, we thought that actually describing the clinical, immunological, and virological through WHO staging, CD4 count, and viral load would have given us some kind of information and direction about outcome, but also way forward. For the one that are not familiar with the MSF family, we use a baseline characteristic from Fuchsia database. Fuchsia database is software where you have most of the information related with HIV and TB patient. We decided to get people from August 2004-2006 until September 2015, and we obviously received the ethical approval from both MSF board and Ministry of Health in Myanmar. The numbers are what normally give the best answer to everything, and in this case we have 615 people identified in this range of times, of which almost 70% are still active in care or alive in care. And as you can notice, we have a big prevalence, big average of death, number of deaths. Later on we will explain much better why there is some specific reason why it's so high. From the 68%, 418 patients are still in care, and but 385 they decide to participate in the study. Not all of them, because obviously we request the patient consensus. So in terms of profile, as you can see, there is no big difference in men and women. 10-11% is not a big discrepancy, I would say. And especially we are talking about adults. 20 to 49 years is the vast majority of our patients. The difference between men and female came when we are looking at number of deaths and loss of follow-up. It's almost male are accountable for almost 70% of the all deaths, and the loss of follow-up, from which we can expect and included probably also some death. This chart probably clarify a bit better why we have this 25%. As you can notice at WHO staging, most of the active care, when they arrived, they were at stage 3 and 4. This means they arrive late at our clinic. That means that they access healthcare when they were very sick. And this is also reflecting in number of deaths. 88% of the deaths happen when people were on this stage. This is, again, explained a bit better, because even if you have a very good doctor, even if you have the drugs available, that is not always the case. Manage this kind of patient, it's extremely complicated. The same is for loss of follow-up. Again, as before, I think it's possible that around these 28 cases, 80% there is some death that has been not recorded. And as late presenter profile, we have also the CD4 that is less than 100 for 31% of the cohort. So I think we have a clear idea about how is the profile. Adult, probably male, has more problem. Last year, colleague Janet also identified fishermen as key population, especially for the context of the way, and late presenter, people are arriving very late. Sorry, the last point I included as kind of limitation of the study, because for almost 36% of the patients we didn't have information. That was the time of 2004. I hope and I'm sure that in 10 years we improve a bit the M&E system, but it's still relevant to mention. So what are the good news? The great important news for me is 96.8% of patients have undetectable viral load. This is an amazing result. It's in line with WHO guideline of 90-90-90 target, but especially I think it's very important, not for MSF specifically, but mostly for the life of the patient. It's clearly demonstrate how it's possible to run a project in the low middle income country on an HIV program and having a significant impact on the life of the patient. The same it's about CD4 count. 548 cell, it's comparing with the beginning, it's a great achievement. Second line is not that high, but obviously still underline the fact that for the future we still need to consider second and probably third line will become more and more important in our project. And what surprised me more, to be honest, is the mutation of resistance. We have just 4 cases of mutation in 10 years' time in such a big cohort. I think it's a good result. The bad news, on the other hand, is mortality. Of that 25% that we saw at the beginning, 53% die in the first year. Again, it's a logical consequence of the late presenter profile that we discussed before, but definitely it's something that we need to address. At that time, again, in 2004, probably there was not awareness, discrimination, and stigmatization was an issue to access healthcare. The situation at the moment is getting a bit better, but we are not really improved that much. But definitely it's something that we need to keep in consideration when we are designing an HIV intervention. Just for the description, not surprisingly and unfortunately, TB still remain very high comorbidity. It's almost 40% of our patients have high burden. And I want to stress also hepatitis C, especially in Myanmar. It's a context where prevalence is pretty high, and in our cohort it's more than 12%. We have the chance as well to treat now, fortunately, the disease. So to conclude this part, I think it's very good. We can be happy or satisfied with 96% of undetectable viral load. We definitely need to work more on mortality rate, especially in the first year. And comorbidities still remain a problem in the service that we need to move more and more to the integrated service. And especially comorbidities, we decided to get just quickly more detail on cryptococcal meningitis. Still in the same context, still in the same clinic, still the same team. Working on that. Why cryptococcal meningitis specifically? Because there is high mortality, because number of cases in Southeast Asia it's pretty high. It's the second highest after Southern African region. We're talking about under 35,000 cases per year according to CDC. And of course from Myanmar we don't have much or no data. The analysis was more or less conducted in the same way. It's retrospective using fuchsia and also patient file to see the characteristic of this population. Although it's slightly different because we counted in terms of procedure, we counted from November till November 2004 till November 2015, the profile is more or less the same. As again, with not big surprise, we have WHO staging 3 and 4 and 90%, CD4 count lower than 100 at 85%, and mostly male. We have the chance also to make diagnosis both in serum and in cerebrospinal fluid. These are the results, very simple. I try to keep it as simple as possible. As you see, 80% it's between transfer out and death and loss of follow-up. And then you see there are 2 pieces of cake that looks exactly the same. It's number of dead and people active in care. I swear it's not a mistake. We counted 3 times with epidemiologists, but it's exactly the same number. This means that mortality is still very high for this disease, and we need to address this problem in our HIV cohort. What we try to do is to improve the treatment first. Diagnosis is more or less okay, but in March 2014, we introduced amphotericin B together with fluconazole. Since now, only 9 patients, fortunately. They've been treated with no side effect. We know that there is a lot of resistance in using amphotericin in clinic, but we have experience that it's possible to manage also at very in remote area. So the conclusion is like we finally be able to show some result in the high mortality of cryptococcal. There is again high mortality in our cohort, and we look forward to have an implementation of amphotericin B also in lower service in clinic. I want to thank the team, the whole team working, and the HIV patient in Myanmar. Thank you.
Thank you, Andrea. I would say a very good presentation, and I have to thank you for sticking to the time also. And just for clarifications, we are going to have a discussion session at the end of all the 4 presentations. But in case there are any clarifications right now or any burning question, we can take it. Yes, ma'am. Kindly introduce yourself. And could we have the mic here, please?
I'm from MSF also, MSF Holland, and I'm Tengi, HIV/TB advisor working in Myanmar. So really impressed for your presentation and really interested of the virologue antidetable 98%, which is really attract for me to ask some clarification. So do you already done the routine viral load, or is this based on targeted viral load or routine viral load?
We recently started routine viral load. Before we didn't have the machine, and before was just target viral load. For the study was done on purpose, obviously, that target population was submitted to. But for routine activities, we are now implementing the routine viral load, and looking forward to implement more.
Thank you.
No problem.
Any more clarifications? Yes, ma'am, on the second row.
I'm Chandra, Professor of Obstetrics and Gynecology. I just was interested to know the time frame between the initiation of therapy and your result of 96% with no viral load. So what was the time interval between that? When you detected and then started the treatment,
when we
and
do
what was the
when
you did the repeat test and there was a negative viral load, what was the time frame?
So the patient was started in 2004, most of them, and then when we get the review, we also get through the viral load. We specifically for the target population.
Yeah, but what was the time when you review that interval? What was the interval?
I'm not sure I get your question. I mean, the time in...
I think what she's asking, Andre, is that you see, most of your patients, when they came into your study, were actually with severe disease and presumably a high viral load.
Yeah.
And then you put them on treatment and they became negative viral load or viral load not detectable. Now, what is the time gap between these two? From the time they got detected and put on treatment till they became negative viral?
Okay. This, unfortunately, I cannot reply to this question because I was not there at the time of which they're doing.
Okay.
Sorry.
But anyway, but a very interesting question because...
that's very important, it can give us
in general, again, the methods of the study was exactly to target and to relook at the patient file as well from that time when they started in 2004. And then when we get the review to ask them specific viral load to see the undetectable viral load. It was not routine viral load, so it was target viral load. So probably time being is pretty large, I would say.
Right, thank you. Thank you for your questions. And with this, I would say that we can wait for the next questions at the discussion time.
Thank you.
Right, and thank you, Andre, for a lovely presentation. And I would now like to invite the next presenter, Julie Fontaine. And Julie has a Master's of Science in Epidemiology and is a graduate from the Canadian Field Epidemiology Program. She has worked for the Canadian government since 2008, before starting her international work. And she has been working with MSF since 2014 and has been in Myanmar since March last year, 2015. And Julie will actually be talking on HIV-infected female sex workers in Myanmar, a retrospective analysis. And I'll request Julie again to be as effective in time management as Andrea has been, and conclude within the allotted time. Thank you so much.
Thank you.
Right.
Hi everyone. Today I will present the result of a retrospective analysis of HIV-positive female sex worker in Myanmar. As Andrea said, in Myanmar, HIV is concentrated in people who inject drugs, men who have sex with men, and female sex workers. The prevalence of the general population is 0.5%, whereas it is 6.3% in female sex workers. In Myanmar, a condom use program was first piloted in 2001 and has recently been replaced by a more comprehensive program, which now includes commercial sex outside of brothels and also include men who have sex with men. However, the prevalence of condom use in sex worker remains unclear. HIV in female sex worker in Southeast Asia context is understudied. There's little published literature, and the literature available mostly focus on prevention rather than clinical needs of infected female sex worker and their outcomes. And one of the main important point is that analysis and HIV prevention and care effort are often biased due in part by the common misconception of sex worker. People assume that sex workers are only adult women in brothels and karaoke parlor, although research is showing that street-based and informal sex work is also common and that men and children could also be engaged in sex work. A second point is that usually, like it is in the current reporting system of the MOH and in MSF, when cases of HIV are recorded, you can only select one category of high-risk behavior. You're either a sex worker or injection drug user, but you cannot report both, although it is known that often there are overlapping risk factors. MSF OCA has been treating HIV in Myanmar since 2002, and now has a cohort of about 32,000 HIV-positive patients on ART. We have 9 clinics in 3 states, Shan, Kachin, and Yangon, and we were one of the first NGOs to focus on high-risk group with specialized areas in counseling. We have now reduced our outreach and prevention activities now that other actors are present in Myanmar. So since there's very few data available regarding HIV-positive sex workers in Myanmar, our objectives are to describe clinical, virological, and immunological characteristics and outcomes of the HIV-positive female sex worker seen in MSF clinics. We did a retrospective cohort analysis using routinely collected medical data from Fuchsia database. We looked at all HIV patients admitted between 2002 and 2015 in Shan, Kachin, and Yangon projects, and we used the sex work was self-reported and defined as ever having sold sex. We analyzed a cohort of adult female sex worker and compared their characteristic with adult female who did not report sex work. And before we look at the result, I would like to show you where our cohort of adult female is taken from. So between 2002 and 2015, we had a cumulative cohort of 57,193 HIV-positive patients of both genders and all age groups. And of those, about 1% reported having ever having sold sex, of which 41 were males and 51 were under 18 years old. And in order to have more similar population to which compare the sex workers' outcome, we limited our analysis to female age over 18 years old and over, which gives us a cohort of 22,296 HIV positive adult females, of which 588 were sex workers. And if we look now and we compare female sex worker to non-sex workers, we can see that female sex workers are younger at diagnosis, with a median age of 26 years old, compared to 32 years old in non-sex worker. They have a similar baseline CD4 and a similar immunosuppression status at first visit. However, female sex worker had greater odds to be lost to follow-up before ART initiation, with 34% lost to follow-up compared to 18% in non-sex worker. If we now look at those who initiated ART, we can see that although female sex worker had lower odds to be retained in care after 1 year on ART, the retention in care of sex worker was still very high with a proportion of 83%. And of those who are currently under care, female sex worker had greater odds to be on second-line ARV compared to non-sex worker, with 9% of female sex worker on second line compared to 5% in non-sex workers. And overall, female sex worker were more likely to be lost to follow-up, pre or post-ART, but the majority of those lost to follow-up were before ART initiation. It was 70% of the loss to follow-up that happened before ART initiation. Of course, one of the main limitations in our study is that we think that sex work is most likely underreported. It can be underreported for various reasons, such as stigma and the fact that it's self-reported data, but also due to staff bias, who, like I briefly mentioned earlier, they're more likely to ask about sex work if the patient fits their preconceived idea of who is a sex worker. And we think that, however, our biggest reason for underreporting is the way that the data was collected and recorded. So like I mentioned earlier, only one high-risk behavior can be recorded in the current system that we have. And this information was also only asked at registration. And this is something that we are changing now. In conclusion, we recommend that in order to increase uptake of HIV services and retention in care in female sex worker, we should first better identify sex worker patients by sensitizing healthcare providers and by improving the data collection and recording of high-risk groups, which we are in the process of doing, like I said. And we need also to study a little bit more our cohort to better understand adherence, mobility, reason for loss to follow-up, and outcomes in sex worker. And all this could help us adjust our service delivery model to their specific needs, it could be privacy, flexible opening hours, and tailored counseling. Secondly, we should prioritize sex worker for test and treat, since they are more likely to be lost to follow-up before ART initiation. And we see that once on ART, the retention in care is still very good. And finally, we recommend routine viral load testing to improve early diagnosis of virological failure. MSF has started this year, and the MOH will start with the next global fund round. Thank you very much, and I want to thank everyone in Myanmar who probably could not be with us today because of the low bandwidth in Myanmar. Thank you.
Excellent presentation, Junior and Julie. And I would say that you've brought out the differences in the HIV amongst the female sex workers and the non-female sex workers in both in their presentation and the issues which revolve around them. So now the topic is open for any clarifications. Yes, yes, sir. Please introduce yourself, and then we can.
Dr. Tej Aluwalia from ICMR.
From?
ICMR.
ICMR. Okay.
My first question is, what type of sampling you used for your patients?
We didn't do sampling. We used a whole cohort of every patient who has ever presented to care in our MSF clinics.
And
So it's the full cohort.
And what is the meaning of solid sex?
Sorry?
Solid sex. You have used the term solid sex. What you mean by solid sex? Soul. It's a soul sex. Right. Sorry. Thank you.
I missed that one, sorry.
Okay. Any more? Fine. Thank you. You can keep thinking on the topic, and you will have another opportunity at the end of the session also to. And now from HIV, we move on to tuberculosis, and that also in one of the marginalized group, I would say, which is the children. So to talk on TB in children in Uzbekistan, don't forget MDR-TB. I would like to invite Junia Kajaziro, and she, please. She is working as a pediatrician with the MSF in Uzbekistan, and she's worked as a pediatrician in different capacities, whether in the emergency rooms or wards and neonatal care in Brazil. So she has extensive experience as far as children are concerned. And she was also a trainer in neonatology care and worked with public health education before she joined the MSF. So let us hear from you, Junia, about your experience in Uzbekistan.
Thank you. So good morning, everybody. To start talking, MSF has been working in Uzbekistan since 1998 in the semi-autonomous Republic of Kazakhstan in Uzbekistan, Central Asia. And we have a program there about tuberculosis. We diagnose and treat patients with tuberculosis in cooperation with the Ministry of Health of the country. And since 2013, we have a specific guidelines for treatment of children there. Uzbekistan is one of the 27 countries of the world with high burden of MDR-TB, multi-drug resistant TB, and this high burden is also expected within the pediatric population, because most often they will get this disease within their own houses or with adult which they are in close contact. And to diagnose tuberculosis in children, we have unique challenges, because usually children, they will get unspecific symptoms such as cough or fever, and they will, those of younger age, they have usually inability in producing sputum, and also they will have pulsibacillary disease, which means they have low concentrations of the bacillus in their lungs. Also, to try to improve diagnosis of tuberculosis in children, we must gather together the symptoms, radiological findings, and also laboratorial results, which means microbiological results when it's possible. And also it's very important history, to take a great history of the children. So in the history, it's very important to try to find between the contacts of the children any person that is on treatment of tuberculosis, trying to figure out if this patient has much drug resistant or much drug sensitive tuberculosis, especially in those cases that we have negative laboratorial results. And this is part of contact tracing. It's very important, trying to diagnose the children in the right way. And also trying to increase the laboratorial results. We have two different procedures that we can do in children, which are sputum induction, already implemented in Kazakhstan, and also gastric aspirated. So knowing about these difficulties in getting laboratorial positive results in children, and also knowing that Uzbekistan is a country with high burden of multi-drug resistant TB, we decided to compare the treatment regimens prescribed for patients, pediatric patients with a positive laboratorial diagnosis of TB and those with negative laboratorial diagnosis in Karachi, Pakistan. We, for this aim, we did a retrospective analysis of the routinely collected data from our program from 2013 to 2015 from all children and adolescents with age equal or less than 18 years old. As our results, we had the total number of 655 pediatric patients that were started on tuberculosis treatment during this time, 2013 to 2015, in Karachi, Pakistan. The median age of them was 13 years old. 51% of them were male. 20% of them were less than 6 years old, and 70% of the total number did not have a positive laboratorial results, did not have a confirmation laboratorial of tuberculosis. About the outcomes, we have data from 2013 to 2014, because when we were doing this research, many of our population that were started in 2015 did not complete the treatment regimen, those DS and DR. So our data is from the DS drug-sensitive patients from 2013 to 2014, 355 patients. From then, 69.5% had a good outcome, which means treatment completed, most of them, and cured. Cured, it needs to be with the positive laboratorial results on the beginning. And we had one patient that died, one patient that was a failure. 3% of them were lost of follow-up, and another 3% were transferred to MDR treatment regimens. And we had 24% of our patients with missing data. We don't know the outcomes in our database. So from our results, we had 86% of our patients starting on treatment, on drug-sensitive treatment, and only 14% of our patients starting on drug-resistant treatment. And from the patients that were started on DS, mainly they had a negative lab results, and for those that started DR, mainly of then they had a positive lab results. So from the 457 patients with negative lab results, only 1% of them were started on DR treatment. And from the 198 patients with positive lab results, 41% of them had as diagnosis MDR tuberculosis. The odds ratio between those two different groups is 63 and the p-value is less than 0.001. Just to compare the adult population in Karachi, Pakistan, in a survey from 2011, 40% of them were started on DR treatment. Also, we compare the treatment between the patients less than 6 years old and those from 6 to 18 years old. And the odds ratio between them is also relevant of the number 14, and our p-value is less than 0.001, meaning that children less than 6 years old, only 4% of them had positive laboratorial results, and those children and adolescents from 6 to 18, 36% of them had positive laboratorial results. Also, when we were collecting this data, we realized that 44 patients, they had more than one treatment course regimen prescribed for them between 2013 and 2015. And from these patients, on their first treatment course that we have on our database, 95% of them were started on DS treatment on their first regimen, and this proportion drops to only 18% on their first treatment regimen. From those patients, 42 patients that were started on DS treatment on their first treatment regimen, 16 of them had a negative laboratorial results, did not have microbiological confirmation of tuberculosis, and 26 of them had positive results. And from those, 81% were found later that they had multi-drug resistant tuberculosis and not DS. The range time between the first treatment regimen and the second treatment regimen, the corrected regimen, will vary from 24 days to 246 days. So, in conclusion, DR-TB is being underdiagnosed in children, especially those of younger age. And contact tracing is critically important when there is a lack of lab diagnosis, trying to identify the potential source of the infection of the children and try to have the likelihood of DS or DR-TB in children. Also, we figured out that we need to increase suspicion of DR-TB in children in Uzbekistan. Also, we need to increase our efforts to get a lab diagnosis in children, such as implementing gastric aspirate, which is really good for those children less than 6 years old. And it's of critical importance to do the contact tracing, especially in children without a lab diagnosis. I would like to thank the Minister of Health of Karachi, Pakistan, and also the Epidemiology Department of MSF in Nukus, especially Dr. Robert O'Connor. Thank you.
Thank you, Junior. And now this topic is open for discussion or clarifications, if any. Yes, ma'am.
Good morning. Myself, Dr. Upali Mitra. I'm a district program manager in Mumbai. My question would be to Julia. How many of patients, pediatric patients, were detected through contact tracing out of 655?
These we don't have in our data, but so I cannot speak for sure. But we are now trying to improve this contact tracing in Karachi, Pakistan. So I'd rather not say because I don't know for sure.
Yeah, thank you. And my second question would be, out of 247 which you mentioned as good outcome, how many of them were lab diagnosed and how many of them were without lab confirmation?
From those patients, 4.2% of them were cured and 23.2% of them were with treatment completed.
No, my question would be the initial 247 which you mentioned as good outcome, it could be cured or completed. However, initially they were lab confirmed or not? That would be my question.
For being cured, they need to have a positive lab diagnosis on the beginning, and from those patients, only 4.2% of them they had this lab diagnosis on the beginning.
So all of
they
them
were
who
cured.
Were, lab confirmed initially were cured.
4.2% of them.
4.2%.
Of that 69%.
Yeah.
All right, and any further? Yes, sir. Please provide him the mic so that he can.
Missing outcomes were 24%. Reasons for the same, because I used to look after the health systems research in ICMR. So from health systems point of view, what are the causes for this? 24% is a huge amount. So what are the possible causes for this 24% missing outcomes? Thank you.
This is actually something that we realized doing this research, and we saw that we need to improve our data collection, and it can be because few of the patients they change their names like one letter, and then we are not sure if they are the same patient or not, or sometimes it's written with different date of birth. So we really, there are few things that we saw that we should improve it and about this missing outcomes.
Yeah, I think it's mainly recording and reporting. That
Yes.
aspect of the program needs a greater look into. Am I
Yes.
right?
Yes.
Yeah, that's what you want to say. Yes?
Yeah, good morning. I'm Dr. Yashoda from Delhi. I would like to know what are the lab tests which you have used in this particular group?
We have in Karachi, Pakistan, the ISMEA, and also we have the culture MJITE, and also we have GenExpert and HI.
Okay, thank you.
Okay, thank you. And you can work on her presentation and we can have further discussion on the same topic. Thank you so much, Junior. And now I'd like to invite Dr. Sarthak A. Rastogi for a presentation on Too Little, Too Late, New Anti-TB Drugs for Patients with Complex Drug-Resistant Tuberculosis in Mumbai. Sarthak is actually a pulmonologist, and he specialized in this discipline in the year 2014, and he has been with MSF working on HIV and drug-resistant TB projects since just this January. His special interest is on drug-resistant TB, and let's hear from him what he has to say on the newer anti-TB drugs that we are familiar with.
Thank you, Mr. Chairperson. Good morning, all. I'm representing MSF OCB Mumbai, the project on HIV, DR-TB, and Hep C co-infected patients. Study is aptly titled as Too Little, Too Late. Just to break down the alphabet jargon, starting with the drug-susceptible tuberculosis, which responds to all the treatment, standard treatment, easy to treat, 6 to 9 months of treatment is required. We go further down the line, multi-drug resistant tuberculosis that is resistant to isoniazid and rifampicin. Further down the line, pre-XDR tuberculosis, pre-extensive drug-resistant tuberculosis that is in addition to isoniazid and rifampicin, it is resistant to either a fluoroquinolone or an aminoglycoside, but not to both. And extensive drug-resistant tuberculosis, XDR-TB, which is HR, fluoroquinolone, and one of the aminoglycosides to be resistant. Further down the line, we have unspecified drug-resistant tuberculosis patterns, which have no name as of now. People call them XXDR, TDR. So any patient can present as a drug-susceptible tuberculosis and can progress with failing each line, or they can be primary MDR or primary XDR. There are multiple factors for drug-resistant tuberculosis. So the scenario which as a part of a DR-TB community which we are facing right now, it's quite challenging. More and more difficult to treat drug-resistant patterns are emerging. It usually takes longer to treat. Use of toxic drugs are required, and basically the clinical the trial, there is no trial backing the clinical. There's no trial backing the evidence we have to treat the patient. There are fewer drugs to treat. Usually we have to reach the magic number of 4 or more, which we are finding it difficult. And when it comes to treating the cure rates with drug-resistant tuberculosis, the cure rates are slightly dismal. When it comes to MDR globally, the cure rate is 48%, and it drops down further to 38% in HIV, DR-TB co-infected patients. With enough of complaining, that the last decade has been exciting for us. We have several new diagnostic tools with rapid turnaround time after a gap of almost 100 years, if not more. There is a renewed interest in TB research. Reanimation of age-old forgotten tools, that is surgery in pulmonary tuberculosis, and after a gap of almost 40 to 50 years since the last TB drug rifampicin, we have 2 new drugs. The new drugs are bedaquiline and delaminate. They were given accelerated clearance by WHO in 2012 and 2013 respectively for conditional use and with monitoring and pharmacovigilance. Bedaquiline is currently registered in 9 out of 27 countries, of the 27 high burden countries. In India, a conditional access program has started, and the main problem with these drugs right now, apart from access, is the high cost. Bedaquiline per course is priced at $900 US dollars, and Delaminid is somewhere around projected to be $1,700 US dollars. While enough time to rejoice, the sad part is only 2% of the patients who actually need the drug have access to it. Coming to our clinic, MSF clinic in Mumbai, we provide free drug-resistant tuberculosis and HIV treatment services since 2006. So far, we have 1,101 HIV and 253 TB, DRTB beneficiaries. As you can see in the as you can see in the diagram, we are concentrating more and more on the severe patterns of drug-resistant tuberculosis, mainly pre-XDR and XDR. We have had access to bedaquiline through compassionate use program since 2013 till August 2015, when the compassionate use program was closed. We have access to Delaminid since June 2015. Prior to introduction of any of the drug, there was extensive counseling and consent required because of a black box warning of death and cardiotoxicity to these drugs. Also, we have to protect the drug from becoming resistant and spread of resistance to these drugs in the population. Also, these drugs were never introduced alone. It's a descriptive study from routinely recorded and collected medical data. A retrospective cohort analysis of 12 patients registered for bedaquiline and 14 patients for Delaminid from Feb 2013 to December 2015. Numbers might be small, but our patients on Delaminid constitute 10% of the global cohort of total Delaminid use so far outside clinical trials. So both these drugs are only issued for adults. We have had two HIV co-infected patients in the bedaquiline group, and almost 75 to 80% of patients in both the groups were XDR tuberculosis. And most of the patients have had exposure to second-line anti-TB drugs. The main cause of concern here is there were two patients who were never exposed to second-line anti-TB drugs, and they were highly unfortunate to get primary XDR tuberculosis. Coming to a concept called likely effective drug, which is we have arbitrarily defined as drugs either sensitive and drugs either sensitive on a DST result or less than 3 months of exposure to the drug. So most of our patients, approximately 80% of our patients, have 2 or less than 2 number of likely effective drugs working for them. 12 patients were registered on bedaquiline compassionate use. 1 died prior to initiation. 11 were started on treatment. 1 died after the bedaquiline course was completed. 2 patients in bedaquiline arm have completed their 24 months, and rest are doing well on treatment. In the Delaminid arm, 14 patients were enrolled. 1 died prior to initiation of the tuberculosis treatment. For 1 patient, it was extremely sad that we could not form an effective regimen, and patient was denied. 12 patients were then started on treatment. 2 died, and the rest 10 are doing well. Coming to major serious adverse events, there was 1 death in bedaquiline. As I told you before, it was after completion of the bedaquiline course. 2 patients had severe cardiotoxicity in each of the arms with each of the new drugs. And there were 2 other severe adverse events noted in the Delaminid group. These were the same patients who had severe cardiotoxicity of QTC of more than 500 milliseconds on the ECG. There were 3 deaths reported. Mainly these deaths were due to evolution of drug-resistant tuberculosis, and there was no direct relationship with the new drugs. When it comes to cardiotoxicity, there was no need for us to permanently discontinue the drug, and this was despite of the fact that most of our patients were on other cardiotoxic drugs like moxifloxacin and clofazimine. We have had promising outcomes. There was sustained culture conversion in 16 out of 18 cases. There is these new drugs are safe. for ambulatory treatment with adequate monitoring, including clinical lab and ECG monitoring. The limitations of the study, it was a small cohort, but mind you, it was one of the first ever documented cohort with a high proportion of 2 or less than 2 likely working drugs versus the magic number of 4, which is required for forming an effective regimen. What we have learned is most of our patients had prior exposure to second-line drugs. For these patients, at least 2 new drugs are required to establish an efficient treatment. Too few drugs are available, and they are diagnosed too late. When it comes to the access to these drugs, which is long, tedious, and arduous, patients died before initiating the treatment. Compassionate use program for Delaminid is quite restrictive and stringent, while due to the conditional access program that has started in India, the compassionate use program for bedaquiline has been cut down in the entire country. To conclude, use of new TB drugs should be scaled up, not to be preserved as a last chance of multiple failures. 2 new drugs is not effective in DR-TB management. We need urgent for there is an urgent need for broader access to bedaquiline and Delaminid combination for patients with 2 or less than 2 likely working drugs. There is need for larger trial data with new regimens, not just adding new single molecules. Also, these trials, they had excluded the pediatric patients, pregnant females, lactating mothers, and also we feel that there was a misrepresentation of HIV co-infected patients with drug-resistant tuberculosis in the trial. Also, remember that we had 2 patients who are primarily XDR. We need to tackle the ongoing transmission in the community, which is the thing we are facing in Mumbai more and more nowadays. In the end, I would like to acknowledge the MSF team from Mumbai and Delhi and our patients who endure the difficult life journey with DR-TB to have access to these new drugs. Thank you.
Thank you, Sarthak, for a very interesting presentation. In fact, I think experience with the drug Delaminid is really very limited, even at the global level. I mean, we really don't have too many people talking on that. So it's open for initial queries or initial clarifications which someone may have. Yes, sir. And the check shirt, yeah.
Good morning. My name is Rahul. I was formerly associated with this project. My question has 2 parts. The first part was, what was the duration of the Delaminid that were given to the cohort?
It's 6 months.
6 months, so during the IP.
Yes.
The second part was the clinical utility of adding a carbapenem to the regimen.
So most of the patients, almost all the patients we started on Delaminid were introduced along with twice-a-day infusion of imipenem 1 gram IV.
Is that a standard regimen that we are using because it's the first time?
So basically, we cannot introduce a single drug alone. We need 4 drugs. We have to squeeze in wherever possible, however possible. So we have started using carbapenems along with a combination of amoxiclav drug to get the clavulanic component into the drug, because the carbapenems, without clavulanic acid, they cannot work in M tuberculosis. So that's why we need to squeeze in wherever possible and however possible.
And the last part of my question was regarding, I mean, you're a pulmonologist, so what do you think is the relevance of surgery in patients that have reached such a brick wall where drugs don't work, and where you say it's too little and too late? I mean, how important is surgery?
So surgery for drug-resistant tuberculosis should be offered at a earlier stage. But yes, surgery is a life-saving tool for the patients who have disease restricted to either a lobe or only on the one side of the lung. It can be a life-saving measure. And even with these new drugs, surgery, I think so, will continue to be one of the forerunners for further treatment.
Thank you so much.
Thank you.
Okay, I think it's time to invite all the speakers on the dais, and we can now have a broader discussion on each of the topics. So just to have a recap, Andrea talked on, something about the long-term clinical, immunological and virological characteristics of the HIV-infected patients and on ARV therapy in Myanmar. And Julie, she was talking on female sex workers' HIV infection in Myanmar. And we had Junia, who talked on TB in children in Uzbekistan, and indicating that there has been a lot of underdiagnosis as far as drug-resistant TB in children is concerned. And the last presentation, of course, you all would know, was by Sarthak on newer anti-TB drugs. So if there are any questions or discussion points? Yes, sir. We can have you. The first row. Yes.
Thank you very much for very nice presentations. My question is related to the too late, respective presenter. I am Dr. Hakmal. I am from the Ministry of Public Health of Afghanistan. I was wondering, if you have any information from any other developing countries, because I was trying, to get some information about the background of the project. So is this is the first project here in India, or you have similar experience in other countries? Thank you very much.
Speaking about MSF, South America.
You could put on the mic.
Yes, it's on. In Mumbai, there are at least two other physicians who are using bedaquiline, and they have had experience to delaminate. When it comes to MSF, I know of at least South African Medical Unit in Cape Town, which is associated with MSF. They have had a good amount of exposure to both bedaquiline and delaminate.
Just to add to what he said, at the global level, the use with the bedaquiline is more commonly seen. In many countries, more than 40 countries are actually now using this particular drug. Delaminate is still limited, but we had some good information that it is now being offered through the Global Drug Facility at a highly subsidized rate. And I'm sure in the coming years, we'll have more experience on delaminate also. But the experience with bedaquiline is proving to be, that it's a very effective drug. And the only question is that how to roll it out in different scenarios. And in the Indian context also, I will say that the country has embarked on 6 sites in the country where it will be using bedaquiline as a drug. And just a small correction, Sarthak, that the compassionate use continues. You see, it's not that it has been withdrawn. There were talks earlier.
Okay, sir.
But the final call on that is that until and unless the entire country is covered with this drug, yes, so in the conditional access program, which is being tested in only 6 sites, in addition to that, the compassionate use will continue in the rest of the country.
Thanks for the info, sir.
Right? That's just that. Okay, yes, sir. The one in the blue shirt, please. Yeah, thank you.
I'm Dr. Animesh. I'm working with MSF in Russia and Belarus in the treatment of exterior tuberculosis. We have more than 100 patients in Russia on treatment with bedaquiline and around 10 patients on delaminate, and similarly in Belarus, more than 20 patients. My question to you is regarding the treatment of patients. Once you start them on treatment, you have 4 effective drugs probably, which includes bedaquiline or delaminate. But after 6 months, once the course of bedaquiline is completed, and probably imipenem you give it for like 6 to 8 months or maybe maximum 12 months. After 12 months, you probably have just 2 effective drugs in the regimen. What do you do in your case? In our case, we have different protocols which we use. But in your case, what do you do in Mumbai? Do you extend the bedaquiline? Do you extend the imipenem? Do you add more new drugs to have at least 3 drugs in the continuation phase?
So we have not extended bedaquiline, but we have extended delaminate beyond 6 months. And at least 2 of the patients, we are under approval for extending them till 12 months. Apart from that, we give imipenem till 12 months, and now there is a research coming about high-dose moxifloxacin. So after these drugs are stopped, we usually go on to high-dose moxifloxacin in the continuation phase also.
Do you combine bedaquiline and moxifloxacin?
Bedaquiline we have combined with moxifloxacin, but not high-dose moxifloxacin.
Do you see QT prolongation extension in patients combined with bedaquiline and moxifloxacin?
So yes, we have seen up to 480 milliseconds. Two of the patients had above 500 milliseconds. We stopped the drugs for around about 6 days, and after that we slowly reinitiated the patients not to have the QTC prolongation again.
So of the 11 patients who started bedaquiline, they had bedaquiline only for 24 weeks, following which the bedaquiline was stopped, if I understood it correctly.
Yes.
And there was no reversion after stopping bedaquiline?
No.
What I would say is, sir, that maybe over tea time you can have a one-to-one discussion with him. Let's give the opportunity to the other other people in the house. But just to give a broader look to your questions, I will only say that these two drugs still are being experienced with. We are not very certain on how to use them, but we have some guidance and guidelines, and we are still learning. The different regimens that are being offered around the world, there are different combinations which are being tried, but there are no concrete answers as on date, right? So yes, in Russia there would be some, in parts of Africa there would be other. In Indian context we are having different regimens, but one thing is which has been observed is that they are relatively safe. At least that particular aspect has been taken care of. That is why they have allowed more regular use of these drugs. That is what. Yes, ma'am, you had some question or a comment?
I'm Dr. Hemant, working with MSF and working with MDR-TB program since 2013. Just to add to Animesh's question, we were using linezolid in Armenia with bedaquiline, linezolid and imipenem. So we had two effective drugs when we withdrew bedaquiline. So by the time I left Armenia, we had put 32 patients on bedaquiline, and all of them also had linezolid along with that. But we did not use moxifloxacin, we used levofloxacin instead, not to raise the QTC interval. So
yeah, but you see the experience with moxi along with bedaquiline in different sites. In fact, there are some sites which have also used clofazimine in addition, and they have not found too much of an issue with a prolonged QTC. Right, so that is just for information at different sites at the global level when we review these things, because I'm part of that committee which is into this. So I'm just sharing that these are being used along with these combinations. There are, yes, these drugs cause prolongation in QTC as such also. Moxi does it, clofazimine does it, and it was apprehended that maybe in combination with bedaquiline it may be a more serious ADR, but that has not been observed, right? Cohorts are of course very few. We can't bring generalizations on this. Yes, sir.
It was just the beginning, so we were not so experienced to use bedaquiline with moxi and along with clofazimine. That's why we were on safe side. So my question again to Dr. Sarthak. In Mumbai, 3 patients have been reported to be having bedaquiline resistant. Am I correct? 3 patients who have bedaquiline
I
resistant.
have information that they have failed, but I cannot tell you whether they have become bedaquiline resistant or not. I am not aware that there is a test to do bedaquiline susceptibility or resistance testing.
It's being done in Mumbai and at center where really MSF sent the sample. So it has been reported recently in the newspaper.
Okay.
So when we talk about increasing the access, do we take this into factor?
I think you can focus on the question you really want to ask.
I'm saying for this one, bedaquiline, we are trying to increase the access. At the same time, we see a development of resistance to bedaquiline. In India, the market is so wide open that you can prescribe. How do we balance between the access and the safety to keep that bedaquiline safe?
In my personal opinion, bedaquiline can be kept safe if there is a restricted access to it. It's not like you go to the market and buy bedaquiline for yourself. It has to be enrolled out, like it is being done under conditional access program right now. And secondly, what we can do is, what I can think of a plausible way to go ahead is to give only prescription power of bedaquiline only to few certain physicians, not to all. That is
one of the just in the Indian context, I'd like to add that the vision is that somewhere down the line, when this becomes an acceptable drug on the basis of the pilots, it will be routed only through the national program and will not be available off the shelf for common use. So anyone who wants to use this will have to approach the program for that. It's the regulation has to be made more stricter, I would say. And your question is very pertinent, and it's important to understand that we can't lose this drug also. Right? Yes, sir. Are there any other? We have 3 other presenters also. If there are any questions to them, you could.
I am Dr. Dhyan. I am general physician. Sir, my question is that how much was the effectiveness of Delamide and bedaquiline, especially those who are co-infected with HIV positive and are on antiretroviral drugs?
So in our cohort, we had only 2 patients who were giving bedaquiline, and one of the patients died due to respiratory complications of pulmonary tuberculosis, but he died after bedaquiline course was completed. The other patient is completed the bedaquiline course.
Any interaction with the antiretroviral drugs?
So bedaquiline is known to interact with efavirenz. Efavirenz is a CYP3A inducer, so it reduces the bedaquiline levels. And there is a possible interaction with lopinavir ritonavir, which is a CYP3A inhibitor, and probably can cause increased levels of bedaquiline.
Any interaction with cardiac problem with antiretroviral drug patient on?
I didn't get your question.
As you mentioned that bedaquiline has got cardiac side effect. Any more side effect or aggravation of side effect, especially patient who are on antiretroviral drug?
I'm not aware whether it increases any further cardiac problems or any other side effects just because of antiretroviral therapy.
Okay, thank you.
Okay, any further questions? Okay, it's a comment you want to offer? Okay.
I'm actually working in Jharkhand, across about 11 districts in southern parts of Chhattisgarh also. I found a number of cases of tuberculosis. Now they don't have any treatment, they don't have any medical care, so there's a lot of issues. Now when you're doing this kind of work, are you going to engage with the government? Because unless and until someone drives them, they are never going to reach. And then the death rates are very high, mortality is very, very high. And they don't have accessibility and availability of both drugs and treatment and diagnosis is just not available. So it's a state issue, all right, but since you all are doing this kind of research and this kind of work and this kind of treatment, is it possible that you can also implement it in a state like Jharkhand? Because I think they need it really urgently.
So I don't have the personal capacity to speak on behalf of MSF, but our project is specifically dealing with drug-resistant tuberculosis, but there are other projects with OCA and OCB which are dealing with general health and as well as drug-sensitive and drug-resistant forms of tuberculosis. So they have access to sending the samples for microbiological testing to the reference labs also.
In all states or in?
So no, there are limited states. There is one in Telangana and there's one in Chhattisgarh, if I'm not wrong.
That's the northern part. That I know. Yeah.
And there's one project in Northeast India.
Yeah, I think just to clarify on the issue which you raised, because with the government system, I'm a bit aware because of virtue of my position. I can only say that the government is very clear in mind that it has to roll out this particular drug at a country level rather than limit it to some sites. And they have already approached for about 10,000 courses of the drug to the relevant global authority. And I'm sure that in the coming months, you will have something for the patients in that part of the country. Right? Yes, sir. And we like to now limit our questions because we are running short of time. So maybe just these 3 we will take, you and sir, after that you, And then lastly, we have Vijay from the people who are providing us bedaquiline, right?
My name is Tobdan Kalon. I'm the medical coordinator for MSF for the project that Sarthik presented. So just a response to the last question. Yes, we are indeed collaborating with the government, with the RNTCP in one part of Mumbai where this we intend to collaborate on introducing these new drugs.
Right, yes, yes sir.
It's for Andrea. Hi, my name is Yogesh. I'm an epidemiologist in Manipur.
Andrea, it's for you.
So, have you considered the adherence level? Because we talked in 1990, we have to speak on adherence level because that's also having mortality and morbidity. So, have you considered that in your analysis?
Yes, we did, and it's pretty high in our patient as well. It's 97%. So it's same adherence was taken in consideration and during the study. It's pretty high. The patients are pretty good. I found a big difference comparing with Southern African region where normally you have around 70-80% of adherence. Here it's much higher. It's around 97%. So we took into consideration.
Thank you.
And we think it's also one of the reasons why we have good result in viral load as well.
Right. So that's the last one now.
Thank you, sir.
Yes.
This is to Sarthak. So just for my understanding, I'll ask you two questions. One, as per the WHO guidance, this says that bedaquiline, or for that matter even delaminate, should not be added to the failing regimen, right? So when we want to add bedaquiline or delaminate, so have we drastically changed the entire background regime? Or what was, how we have constituted that OBR? That was first. And second, is there any experience on the combination of these two, bedaquiline plus delaminate? Thank you.
So for your first question, basically, well, whenever a patient comes to us, we do a drug susceptibility testing, and based on the drug susceptibility testing, we form a background regimen. And to that, with bedaquiline, we usually try to add another drug if it's available to the regimen. We usually do not add a single drug ever to failing regimen. If a patient is failing on a pre-existing treatment, we usually add with another drug which he has not been exposed to, or at least which he is sensitive to on DST. Second part of the question, there is a paper from Democratic Republic of Congo on bedaquiline and delaminate combination, on which the patient has done quite well on it.
Yeah, I think you talk into the mic and.
No.
Yeah.
So, with respect to our Mumbai experience.
So, in Mumbai experience, we have initiated a patient. If the presentation I mentioned that one person was not initiated on delaminate alone, she did not have much options, so she has been instituted on a combination of bedaquiline, delaminate, and along with imipenem infusion.
All right, and sir, I think the final one now. I know it's very interesting, you know. I mean, whatever the questions are telling me that the house is very keen on the issues which are being discussed.
Well, apparently I will not ask about MDR-TB in Mumbai. I mean, enough of MDR-TB and the delaminate, please. I just wanted to share with Julie, just a question, Julie, because it was an amazing presentation regarding sex work in Myanmar, and usually we count in epidemiology. Do you have any ideas to do some qualitative research in order to speak with the women and maybe men and children and find out some of how the experience is about accessing care, diagnosis and care in Myanmar?
Thank you. That would be very interesting. I don't think at this stage that we have any plans for something like that, but we just have these results now, and we want to do more analysis, in-depth analysis, and based on that, I think we can raise other questions and see if there's some space to do more research and include discussion and figure out why do we lose them to follow up, why what are their barriers to access to HIV treatment.
Okay, I think yes. You had something to say? Okay, right. I think before I conclude, I'll just take the prerogative of the chair to ask one question to Junior, a clarification rather. And this is, regarding the issue on treating probable TB or probable MDR-TB, because now these are known entities and accepted entities in children. So what would you say? Is it part of the program guidelines there, that whether to treat, because you see, you said that most of the children who were treated with drug-resistant TB had bacteriologically proven drug-resistant TB. At the same time, you also mentioned that getting the sputum for testing out in these children is very difficult, and it's a challenge in itself. So to take care of these issues, there are now globally guidelines which suggest that, okay, even if you're not able to get sputum, you can, in the clinical context, think of drug-resistant TB in a child,
yes,
and then start treating as probable drug-resistant TB. Now, is that something which the country is thinking?
Yes, we can, actually this is what we are trying to raise here, that we should think about treating MDR-TB in children even if they have negative lab results. Yeah,
fine,
definitely.
Right. So I'll take this opportunity to thank this entire team of presenters for the morning session on my personal behalf and on the behalf of all the audience. And I'll also like to thank those who participated in the discussion. Thank you very much. We conclude this session here.
Thank you, Dr. Sarin, and all the presenters. Fantastic session. It's just great to see the interest in TB. You know, what 2 new drugs can do to the whole, changes the landscape completely. So it's exciting to see what's going on. So we're going to have a break now. We will have the keynote starting exactly at noon. So I suggest that you take a break and be back 5 minutes to 12. And Dr. Swaminathan will be here to deliver the keynote address. So I'll be rounding you up 5 minutes to 12. Please be on time. And again, I want to remind people who are asking questions, stand up, state your name, state your affiliation, so that for the benefit of the camera and for the live streaming as well. Thank you, enjoy your break, and we'll be back in 15 minutes. Thank you.
when children die from hunger and disease, when disaster devastates the lives of thousands, when people need urgent medical care, we provide medical aid for people throughout India and across the world, whoever they are and whenever they need it. Based in India since 1999. Médecins, Frontières are doctors without borders.
In conflict zones, hospitals are being attacked and destroyed at an alarming rate.
Last year in Syria alone,
one medical facility was bombed each week.
This cannot be the norm.
When medical facilities close
because doctors and patients are attacked,
this means people can't get the medical help that they need.
Not a target is a simple message
about our shared humanity, especially in times of war.
Please join us and share this video.
Let your voice be heard.
Hospitals,
patients,
and doctors are not a target.
Hello. Martin? Shall we get everybody to please be seated? Please take your seats. Please be seated. I've just been told that we have 57 people watching online from 16 different countries. So as Europe and rest of the world wakes up, we can expect more people to watch the proceedings online. All right, if you're all seated, we'll get started with the next session. It gives me great pleasure to introduce Dr. Soumya Swaminathan. Dr. Swaminathan is the Director General of the Indian Council of Medical Research and Secretary at the Department of Health Research, the Ministry of Health and Family Welfare. Prior to this role, Dr. Swaminathan was Director of the National Institute for Research in Tuberculosis in Chennai since 2012. After completing her medical degree, MBBS from AFMC Pune, and MD in Pediatrics from All India Institute of Medical Science in Delhi, Dr. Swaminathan received further training in neonatology and pediatric pulmonology at the Children's Hospital of Los Angeles, University of Southern California, and a research fellowship in the Department of Pediatric Respiratory Diseases, University of Leicester in the United Kingdom. Dr. Swaminathan later joined the Tuberculosis Research Center in Chennai in 1992 and has spent the past 23 years in health research. Her research interests include pediatric and adult tuberculosis, epidemiology and pathogenesis, the role of nutrition, and HIV-associated TB. Dr. Swaminathan also served for 2 years as the coordinator for neglected tropical diseases at the TDR. Her professional memberships include the International Union Against Tuberculosis and Lung Diseases, the International Scientific Advisory Expert Group for the UK All-Party Parliamentary Group on Global Tuberculosis, and the Third World Organization of Women Scientists. Dr. Swaminathan also serves as a member of the UNAIDS expert panel and the WHO TB Department Scientific and Technical Advisory Group. She is a fellow of 3 of India's science academies and is globally recognized for her work on HIV/TB. So please join me in welcoming Dr. Swaminathan to deliver the keynote address titled Medical Research Priorities in India and South Asia and the Role of the Not-for-Profit Organizations. Welcome.
Good afternoon, everybody, and thanks very much to Unni for that very kind introduction. And it's a real pleasure to be here with all of you today, both those of you who are in this room and those who are watching on the webcast. I think it's a great initiative to have this kind of an event by the MSF. Of course, I've admired the MSF for many, many years, as I'm sure many of you in this room have, and I've always had a secret desire to work with the MSF. Perhaps one day that will come true. But I have met many colleagues and visited many of their field sites, including in places like Swaziland, where I saw the MSF project on MDR-TB in really remote mountainous communities, where they first tried to work with community volunteers giving injections of kanamycin to these people who otherwise would have to travel 30 or 40 miles every day to get their injections. And I'm also familiar with the work in Bihar on Kala Azar and also in Mumbai on MDR-TB that you've all been listening to in the morning, as well as work in the former countries of the Soviet Union, again on MDR-TB mainly. So I'm going to just share some thoughts with you today about what are some of the research priorities looking to the future for our region, the South Asian region. We share a lot of commonalities. Essentially, we all come from the same stock, and also what NGOs can do. How can NGOs contribute to research, which is, I think, something which is really. I should start by saying, first of all, that health research as such, I think, is neglected in this part of the world, is not given the high priority that it should, is underfunded, and doesn't attract good people. And I say this, knowing that it can raise a lot of eyebrows. Very recently, there was a paper published that many of you would have seen by Dr. Nandi and his colleagues, and they analyzed the research output from India, the medical colleges, and they found that more than half of India's medical colleges, we have about 400 now, 400 plus, half are private, half are government. More than half produced less than 5 papers a year, and many of them produced no papers at all in a year. And only 5 colleges in India accounted for more than 80% of research output. And you can count on one hand the number of medical colleges that are doing research. So I think that says a lot about our training, and this is where I think the Medical Council of India and others really have to look at our medical curriculum and exposure that we give to our students. And I think this is true probably of other disciplines as well. It's not only medicine, but today we're talking about medical or health research, that medical students are not exposed to research at all. And in fact, we hardly ever hear the word research, I think, during medical college, in this part of the world anyway, which is a contrast to the training in other parts of the world, where students, even in school and when they're in college, are encouraged to undertake research, do internships, take a year off, and so on. And the other, so that's one thing I think we have to focus on, is really the exposure, the training, the building the capacity, as well as giving opportunities to medical students, at least those who are interested, to pursue research. And then, of course, the whole area of supporting research, health research in a much bigger way, having a strategic approach to developing the capacity within medical colleges. So now that I'm talking about capacity, I'll just mention a few of the schemes that the ICMR does have and which further need to be expanded. One is the short-term studentships we have for medical students in while they're still in second, third, fourth year of college. They have to find a mentor, write a proposal, a short project which they can do in the summer holidays, submit to the ICMR. It's screened online by reviewers from all over the country, and then 1,000 of them are awarded every year. So we start with, this year we had 5,000 applications. So every year the numbers going up. So that's a very good sign. It means people are interested, and if there are opportunities, they will take it. So we have 1,000 of them. They submit their reports. The reports are reviewed, and those which are very bad are not considered further, but majority of them are good enough to be approved and get a certificate. And also they get 10,000 rupees for having done that. Apart from that, we of course have PhD scholarships and postdoc fellowships and junior and senior research fellowships. But now we want to really expand that number and also start a whole program for junior medical college faculty. So this is something that we're working on, and hopefully we'll be able to come up with some good schemes similar to what the Department of Science and Technology has for faculty in universities. Mentorship is a very important part of this, and as I visit NGOs around the country, and they do such excellent work in the field, all of you, because you're in the community, you have an understanding of the various facets of community life. Generally, NGOs engage much more with the community than government is able to or does. And you're based there, and there's a certain commitment. I'm talking about the majority of the good health NGOs. So an exposure for a student or a young faculty member who's more in an urban environment to an environment like that, I think would be a real eye-opener. So one of the things that, again, I was considering is how do we get people from medical colleges to move and perhaps do sabbaticals in NGOs. The NGOs would also benefit because most NGOs are working with a handful of people, usually overburdened with the clinical care or the community projects or whatever they're doing, less time for research and even less time for documentation and writing up. So lots of NGOs who've done tremendous work, but you can't read about it anywhere because they have not had the time or the inclination or the capacity to put it together and publish it. So I think a scheme where we could have some movement of people who are interested in community-based research, say from medical college, public health departments or community medicine departments out into the field and spend a year or 2 years, could not only give them that exposure to the realities of life in remote rural or in underserved urban areas, as well as the other way around, that they could bring, if they had skills in epidemiology, biostatistics or IT, could bring to that NGO the skills needed to take the data, capture it and help write it up. So I think we have to try this out and see how many takers we'll have for something like this. The other thing, of course, is in India we've had a very long and rich tradition of NGOs working in the health sector, and we've had several examples of people who won the Magsaysay Award, for example, for the community-based healthcare programs, including Dr. Bang and Dr. Rani Bang, and also Aroles from Maharashtra, the Amtes, both brothers, Vikas and Prakash. Amte, and of course the father was a very famous person in leprosy, but they continue that tradition. And I name a few of these, and there are many more, including MSF, including JSS, Jan Swasthya Sahyog in Chhattisgarh, and so on, where there's a more academic or an intellectual approach also taken. It's not just serving the community, but it's evidence generation as well. And we know, there are again many examples of such evidence that have found their way into policy. Probably the most well-known one is Dr. Abhay Bang's studies in rural Gadchiroli, where he used community health. They were just community volunteers. They were just ordinary women who volunteered to serve as sort of maybe the forerunner of the Ashas. They were given basic training, given a bag, basically focusing on maternal and neonatal care, and then they delivered gentamicin injections to babies when there were signs of sepsis, not randomly, because I've gone with them out into the field. They know how to look at newborns and find signs of sepsis. I mean, it's quite based as much as possible on an algorithmic approach, and they showed that you could bring down neonatal and infant mortality tremendously by this approach. It was published in the Lancet, discussed globally, adopted globally now as policy, but still, you know, there are always difficulties in implementing something like this through the government, because there are so many issues which come up, legal and other issues, and you know, so it's not always that evidence gets quickly implemented, but you know, the first step is to generate that evidence. The other unique thing about, I think, NGOs doing research is that you tend to pick up the problems which are priority for the community. Okay, so very often people sit here in Delhi or anywhere else and decide, okay, this is the list of research priorities for the country, now let's go out and do it. And you go into the community, and when you talk to community members, their priorities are completely different. And I learned this when I worked in Javadu Hills, which is a tribal area in Tamil Nadu, where we went with a TB project, where we were trying to get youth volunteers from the villages to do case finding as well as to be dot providers. This was in the early 90s. And, you know, it was very remote at that time. We had to walk to most of these villages, and many of them said, you know, the first government team that's ever come to our village and so on. We found also the life expectancy there was quite low because access was an issue. But the interesting thing was that they said that, why are you only talking to us about TB? You know, that's not our top problem. So we have so many other issues before that. You know, people have fractures, they don't have any access to care. Our children are undernourished. There were no Anganwadis there because of the rules about Anganwadis, you know, 1 for every 1,000, and these hamlets are all widespread. And we realized the community was okay. They went along with the TB project because we were very persuasive, but we realized that they wanted a holistic solution to their problems. They didn't want one team coming for TB, another team coming for something else. This is exactly what we end up doing in government. Similarly, I think I was talking to Dr. Bang actually when I was in Gadchiroli, and he said that, you know, when they first went to Gadchiroli, they thought that sickle cell anemia was a huge problem in the tribals. As you know, most of our tribal communities have a high prevalence of sickle cell trait and anemia. So that this should be the big problem here, and that we should, you know, try to get ways of screening, testing, addressing it. And then in a series of meetings with the tribals, they said, sickle cell, I mean, that's fine. I mean, we know it occurs. It's been there for generations, and that's not our major issue at all. So we really don't want you to be focusing on sickle cell. And here are our list of things. TB actually came out as one of the very top ones, malaria and snake bite. And even till today, that malaria is huge there. So, so this is where I think that there's a diametrically opposite approach taken by government and by NGOs, where the priority setting is done based on a participatory approach, or should be anyway. Maybe everybody doesn't do it like that, but that would be the ideal way to do priority setting, is a more in a participatory way rather than a top-down. Now, there could be another way of also looking at research priorities, and that is to look at what's the burden of disease. What's the burden of disease today, and what is it likely to be in the future, and what really are the gaps in knowledge that we should be working on. And that then takes you to a more systematic approach, which is more based on the data that you have. And all of you would have seen the global burden of disease reports, which have come out and continue to come out, and that showed very clearly that between 1990 and 2013, if you look at India, the top 10 causes of death and the top 10 risk factors, there's a clear shift from infectious diseases being the top killers. It was TB, pneumonia, diarrhea, up in the top 3, and it's completely moved now to cardiovascular disease, cerebrovascular disease, and chronic lung disease. And TB is still up there in the top 5, but the other causes have plummeted. Diarrhea has gone down because of ORS and better water and sanitation. Pneumonia has gone down, childhood pneumonia, because of immunization, and as we roll out more and more childhood vaccines, that's likely to go down further. And also with, of course, you need also access to antibiotics in remote areas. If you look at the risk factors, the top risk factors in 1990 were things like undernutrition, unsafe water, and I don't remember the third one, but they were all again related to water and sanitation issues. And if you see the top risk factors today in 2013, it's hypertension, number 1, diabetes, and air pollution. So there's environmental air pollution and indoor air pollution, which we must not forget in South Asia is a huge risk factor for millions of women who are still using solid fuel. So both environmental ambient pollution and indoor air pollution come in the top 10 risk factors, and added together they end up being the third most important risk factor for us, which in turn lead to the burden of disease. So this, I think, really gives us a lot of food for thought, that as we are controlling the infectious diseases due to the number of things I said, general overall improvement in the standard of living, access to clean water and sanitation, of course we still have a ways to go, better immunization policies, more availability of antimicrobials, and so on. The infectious diseases are coming down, and this is just totally going out of control, and there are many reasons for it which we won't be able to go into in a lot of detail today, why hypertension and diabetes has become such a huge a problem. A lot of it is lifestyle related, urbanization and so on, but a lot of it, why is it a problem in urban and in rural and tribal areas? Most of us think, they have a nice eco-friendly lifestyle, they still live in a much more fresh environment and they have access to fresh food, but it's not true. And survey after survey has shown that the rates of hypertension, especially hypertension, but also diabetes in rural and tribal areas is as bad as the urban rates. Within a few percentage points of each other, there's no great big difference. Remote tribal communities are showing. So if you look into the reasons why Lakshadweep, after post-tsunami, the community now is provided with everything from the government, rehabilitation measures, including the PDS supplies. And most tribal communities who've now moved out of forests and cannot no longer depend on forest for their livelihood are now eating what's provided in the PDS. And what are we giving in the PDS? We're giving polished rice or wheat, sugar, some dal and some oil perhaps, but it's essentially a very carbohydrate heavy diet. And if you can't afford to buy fresh fruits and vegetables and you can't go into the forest to collect it, then this is what you're going to eat. And our National Institute of Nutrition in Hyderabad, which is one of the biggest ICMR institutes, has done many surveys over the years now looking at dietary patterns and what Indians are eating. And the average Indian is taking less than 10% of the recommended allowance of fruits and vegetables, of green leafy vegetables and fruits. And calories where, quite a few Indians are still having less calories than they should, but the calorie gap is not so much. The protein gap even is not so much. The gaps come in the micronutrients and because of the imbalanced diet. So this is one big reason. And salt and sugar are the other two things which are contributing to this. And of course the reduction in exercise because of the availability of transport and so on. And I think lack of knowledge and awareness is a very big thing in communities as to what is a good diet. If you go by the television and advertisements or if you go by what the wealthy are eating naturally, then everybody wants to have pizza and noodles. And even when you go to urban slums, I often see the children are eating all these packaged, you can get them in small packets now, 5 rupees packet. So it's not a big expenditure for the parent. So the children pester the parent till they get that 5 or 10 rupees and they go. And I used to work in a fishing community in Chennai. And I used to say, but your diet is so healthy, it's fish and rice. And why are these children, so malnourished? They said, well, they don't want it. So they want noodles. Or they want to have, some chips and things like that. So, and the parents give in because maybe for whatever reason. So I think we need in India now to stop, if we have to put a brake on the rate at which we are progressing in the NCD, whatever you want to call it, epidemic or whatever, huge interventions in many areas. I would say policy interventions, yes, and that's particularly, we're talking about tobacco, that it becomes very relevant. Again, in rural Gadchiroli, I was surprised to find that over 60% of the population takes chewing tobacco, and starting in childhood. So we saw many young children who were already addicted. And we know that we just released our cancer data. Some of you would have seen the press coverage last week. So the data were from our cancer registries from 2012 to 14. We have now about 29 population-based and 29 hospital-based cancer registries, which are the best source of data for cancer in the country, and can you can see trends, you can see what's happening in different parts of the country. There's a lot of heterogeneity. You find overall breast cancer increasing in women. That's a #1 cancer today. Again, related with urbanization. So if the breast cancer risk for an Indian woman is 1 in 40, it's 1 in 20 for a woman in Delhi. In men, lung cancer #1, but colon cancer increasing. And of all the cancers, 30% are tobacco related. 30% overall, and 40% in men are tobacco related. And the registries in the northeast of the country are very, very worrying, because first of all, 60% of cancer in the northeast is tobacco related. And there's a high incidence of, apart from lung, esophageal and stomach cancer, which could be related, apart from tobacco, to other dietary risk factors. Maybe smoked meat, could be forms of alcohol, could be other risk factors in the diet. We don't know. Maybe infection either. I mean, it needs further investigation. And of course, cervical cancer #3 among women, the rates are coming down overall. Especially in urban areas, the rates are coming down quite dramatically. But again, it's one of those cancers which could be prevented by widespread HPV vaccination policy. And of course, early detection is very important. One other thing the registry brings out is that only 10% of people are coming for diagnosis in stage 1. So 90% are in stage 2 and above, and that obviously makes their outcomes poor. So that's the other risk factor, is tobacco. And obesity is fast catching up. We still have high rates of stunting and malnutrition in the country. Many of you would have seen the data, the NFHS data, that shows that it has come down a little bit in children under 5, but still way above 30% stunting and undernutrition. And this whole debate about, is it genetic or is it true malnutrition, I think is a false debate, because when you look at children from the same ethnicity who are growing up in a good environment with clean water, sanitation and good nutrition, you can see that within a generation the heights going up. So it's a question of the environment being poor. And very interesting work now being done also in malnutrition to look at interventions. So we know now that it's not only food, it's not only what you're taking in, but it's also the absorption and availability of those nutrients which are important. And if you have a lot of infections, then you're unlikely to respond to that increased food. So what is the answer? Is it deworming? And the trials that have been done for deworming have shown very marginal improvements over a period of time, both in cognitive function as well as in nutritional status. Is it more food, supplementary food? Micronutrient, are there deficiencies of micronutrients which need to be corrected? Or is it something else? And studies in Vellore by Dr. Gagandeep Kang and all, where they replaced, it was a randomized trial where they gave one group of people clean water because they felt that maybe it's the water that's the issue. The food part of it was the same in both communities. These were very poor slum communities. And after a year, they found no difference. The rates of infection had come down in the children who were living in the area with the water, but there was no change in nutritional status. And now we have this concept of an enteropathy, an infectious enteropathy which develops early in life in children who live in poor sanitary conditions. It's not just worms, but it's an enteropathy due to multiple infections which prevent growth even when the children are getting calories and protein. And so the interventions have to be holistic and they have to be early in life. But the point I'm making is that there needs to be evidence generated as to which approach or which combination of interventions will work. Similarly, we know from our iron and folic acid program has been in operation for a long time, and yet the rates of anemia in women and children remain high, almost static. They just don't budge. Is it a question of just compliance with the iron and folic acid tablets, or is it something more than that? It could be availability of the iron because of the kind of diets that we take, high phytate diets which prevent iron absorption, or is it other causes of chronic anemia which are not responding fully to iron and folic acid? So we've been discussing with the ministry as well as to what kind of implementation research should be built into programs. So this brings us back again to the whole area of evidence for policy making. And so I think this is really something that is very much needed and which will help our health programs actually put in better interventions or to change track midway when you see that things are not working. So going forward, we're looking at, within the ICMR, at focusing on few key areas of research. I mean, there's so much to be done in India, and the infectious disease part of it obviously has not gone away. It's just that the balance has shifted. It used to be 60% infectious, 40% non-communicable, and now it's gone the other way, 60% non-communicable disease burden and the mortality, and 40% is due to infections plus maternal and child causes of death. So we're actually doing a much more detailed exercise now along with the Public Health Foundation of India, first of all to do state-level disease burden estimations, but also look more closely at all the surveys that have been done, especially the health surveys and nutrition surveys, to see whether we can do more analysis and interpretation to find out what the possible interventions could be. And these state-level disease burden estimates will be very helpful for state policymakers because, as you know, health is a state subject in India. Though policies can be made in Delhi, they can be modified and the implementation has to be done by the states. So obviously the burden in Chhattisgarh may be totally tilted towards malaria and undernutrition and TB, whereas the burden in Kerala would be diabetes, hypertension, cardiovascular disease would be, where they need to really focus. So I think this is important for a country like India. And in fact, the national level estimates really don't help anybody in policy making. So much more, we have to go into much more detail and perhaps even down to the district level. The Prime Minister, when he spoke last week, to the secretaries about, he has a program where he monitors programs, took the TB program, and after the secretary had made his presentation, he said that, we need district level data. We should focus on district level performance and do interventions at that level. And it's true for other diseases like leprosy as well, where at the national level we've eliminated leprosy. We've gone down to less than 1 in 10,000, but there are many, many districts in the country, about 130 or 140, where leprosy new case detection is still above 1, and leprosy certainly is not eliminated. So now the target is by 2019 that we target elimination of leprosy at the district level by doing more active case finding and by ensuring treatment and compliance, and perhaps putting in a couple of new interventions for prevention among the household and neighborhood contacts. we're looking at actually using a vaccine called the Mycobacterium indicus pranae. This is a vaccine that has gone through many clinical trials and has an efficacy of about 60% against leprosy. So if we are able to vaccinate contacts, not only household but social contacts as well, for every leprosy patient, can we actually drive transmission down or drive down the new case detection over a period of years? So this is a question that hopefully we will begin to answer through an implementation research project that we are planning with the ministry. So there are several other diseases like Kala Azar, where MSF has contributed a lot in Vaishali district of Bihar in generating the evidence for the single dose amphotericin B, liposomal amphotericin B treatment, which is now policy, as well as diseases like filariasis, where the mass drug administration we've been doing now for many years, but a recent survey has found that again, there are many districts where the rate of filaemia or antigenemia has not dropped down below the 1% that we're looking at. So again, one has to ask what the problems are. Is it compliance, or is it that the drugs need to be supplemented? So we're going to do some implementation research for filariasis as well, where we're going to add ivermectin to the two drugs which are already used, which is DEC and albendazole, in a couple of districts, high prevalence districts in Karnataka, to see whether that, because it's been tried in a small population of Papua New Guinea, and they found that by adding a third drug to the two drug MDA, you could really bring down microfilaremia almost to zero in the people who got it. But that needs replication, and it needs evidence before the policy can be changed. So we are hoping to start that also in the next few months. So there is a drive also towards the diseases which are going to be eliminated. I think there's research needed, because the last mile is always different. When you're left with a handful of districts now in Bihar and Jharkhand where Kala Azar is a problem, similarly 100 districts in the country where leprosy case detection is still high, another 100 districts where filariasis is not going down, but we want to eliminate all these in the next 2-3 years. So research towards elimination of some of these infectious diseases is certainly still very important. And I think this is where, again, the NGOs can take a lead, because what is often missed in many programs are the socio-behavioral aspects. So you can go around distributing tablets, but if people don't take their tablets for whatever reason, or people refuse to be vaccinated for whatever reason, then the program isn't going to work. So we have neglected this. I think you need social scientists as part of, I think, all research. At least that anything that involves a community, which is public health research, there has to be a social scientist as part of the team, preferably health economist as well, so that one can look at cost effectiveness of interventions. So towards building up the evidence to policy in a more formalized way, we're looking at setting up a health technology assessment board, which is similar to NICE in the UK, which is similar to HITAP in Thailand. Many other countries have established such boards, which would look at weigh the evidence that's available, including cost effectiveness analysis, aspects of equity and access, and make recommendations to the government as to which of the possible interventions should be adopted. And of course, then the government, there has to be a system where the ministry then takes the recommendations of this independent high-level board like the NICE in the UK, which have often given recommendations which are not popular at all, where there's been a lot of opposition from various groups. But ultimately, you have to be in that position where the decisions are made openly, transparently, and based on evidence, where you can stick by it, and the government then usually does accept in such a situation. So we're working towards that. It will take, I'm sure, a couple of years to really put in place the whole structure where it's functioning at that level. But we're starting the process with the NICE UK helping us. Research capacity we talked about. Implementation research is the third pillar. The fourth one is leveraging traditional medicine, where again I think India can play actually a unique role. South Asia overall, but certainly the rich traditions that we have in India, various forms of medicine, and also outside that, we have so many non-codified practices, so many herbal practitioners, traditional healers, especially in our tribal communities that have this wealth of knowledge of all the medicinal plants available in their region. There is a lot of scope, I think, for us to use modern biomedical approaches and the technology that we have today to, first of all, of course, try to discover and develop a drug from medicinal plants like artemisinin for malaria, like ivermectin, like so many other drugs that we have, but also to validate traditional practices. We cannot, sweep them all with the same brush. In the sense that, yes, there are many quacks who operate in these remote areas, but those quacks are actually using allopathic drugs and exploiting people. That certainly has to be discouraged and controlled. But there are true traditional medicine healers who have knowledge of plants, and many of the time those things have definite medicinal properties. Many plants have, we know that, and so many drugs have come from plants. So it's a question of studying, documenting, verifying, validating, doing clinical trials where necessary, and then taking them forward. So I think this is where China has done very well, and in contrast, perhaps we haven't focused on this because there are two streams and the two streams are not talking to each other. And again, there's very little interaction and exposure between the allopathic stream and the non-allopathic doctors, whether they're Ayush doctors. So we have an institute in Belgaum, I was there last week, where they really identified a whole lot of traditional healers from that area, mostly tribal communities in the Western Ghats, which, as you know, is very rich in biodiversity and medicinal plants. And they now have an integrated clinic where these traditional healers can come and practice their medicine. At the same time, we can do observational studies to see what is happening. Similarly, we have a clinic sitting with Ayurvedic doctors and allopaths. The Ayurveds have a herbal remedy for dengue, where they say you can actually prevent the platelet count from coming down. This obviously needs to be validated. So I think in this season, we'll start a clinical trial to validate or to look at the efficacy of this herbal extract, or it's a combination of 7 medicinal herbs, in preventing the platelet count decline in dengue. So those are examples of that piece of work. The last priority or area where we want to focus is in setting up data platforms, data warehouses, and repositories. I think that is an area where, again, the whole world is actually looking at what's the best ways of sharing data, of making it available as quickly as possible on platforms where people can access it. Because I think data that's been collected, especially using public funds, must be made available to people as rapidly as possible, as transparently as possible. And of course, paying attention to the individuals or the principal investigators who collected that data. I mean, they have a right to use it first. But I think more and more policies are shifting, both of the science agencies that support research as well as of journals that accept papers. Many journals are now encouraging a pre-publication online. You can submit in a repository. NIH and all the other funding agencies have rules about when you have to make your data available, especially the publication as well. And there's a lot more open access publishing happening. So in this area also, we hope to be able to work over the next year or so to develop the data warehouses where we can put, say, for example, all the nutrition data that's being collected in so many different surveys that people are doing. There's TB data, there's cancer data, there's a lot of data which, if available, then will be useful for researchers in different institutions to access and be able to. So again, a lot of policies have to be developed, SOPs have to be developed, and then one has to have the capacity to. So finally, before I end, I think that I'm a strong believer in collaboration and collaborative research, and I think that we now you look at journals and you try and look at high impact publications, you'll find sometimes that the list of authors, runs into pages. It's in the hundreds sometimes. So this shows that, the era of individual, yes, there's always going to be individual excellence, competitiveness. I think that also needs to be there to advance biomedical, the frontiers. But at the same time, I think to have impact, you need transdisciplinary, interdisciplinary, collaborative research, where you have people from different streams actually coming together to solve one common problem or to do it in a mission mode. So we're trying to do something like that for tuberculosis now, and we're at an advanced stage of planning now for a TB research consortium, or we probably going to call it the India TB Research Foundation. The idea is to really have an independent body that looks at priorities for TB research, identifies problems that need to be solved, and then is able to fund groups of people who want to come together to solve a problem, whether it's a point of care diagnostic for TB that can be done on a drop of blood or in saliva. That's what we'd all like ideally, is to be able to diagnose TB with a rapid diagnostic test like we do for malaria now or for dengue, or whether it's a short regimen for treatment of MDR-TB using new combinations of drugs, a better vaccine, or a strategy. It could be strategies in the community as well to improve TB compliance. So this foundation hopefully would see the light of day very soon. It will be completely public, private, corporate. Everybody is invited to really join in. We'll have to do a lot of fundraising. Some funds will come from government, a lot of it will come from outside. And it will also, we'll try to involve as many people as possible who are interested in solving the problem of TB. So this is an example of trying to address a problem rather than funding individual projects, which very often look at small pieces of the puzzle, but then those never really get put together. I was talking to a group of PhD students yesterday, and if you look at thousands of PhD theses that we produce every year, a lot of it probably has very valuable leads that they have found, but they get shelved, and after that the guide is busy with something else. He's got his next set of PhD scholars. The PhD student has gone on and is doing a postdoc with somebody who's interested in something completely different. So I think we're really missing an opportunity. Similarly, for academics who are working in a lab, they have funding to do a certain amount of work. They may have a very important lead or a finding for a drug target or a diagnostic, but they cannot take it forward without additional support as well as the involvement of industry. So this sort of a platform where people can come together and work as a team to have a product at the end of it is what we're looking at. And I welcome all those of you who are interested in TB to really join this. We should be able to make a public announcement, I hope, in the next few weeks. So I think I'm going to stop there and thank you all once again for the very patient hearing, and happy to have any discussion only if you feel it's appropriate. Thank you.
So we'll take a few questions before we... Okay, we'll take a few questions before we break for lunch. I just want to point out that ICMR and MSF has had a long relationship. In 2003, we jointly set up the Drugs for Neglected Diseases initiative, which has actually come out with 10 new drugs in the last, since 2003. So that's an incredible achievement. And it's along the spirit of collaboration that you spoke about, working with the Ministry of Health in Malaysia, the Institute Pasteur, Oswaldo Cruz Institute in Brazil. So there's a global public-private partnership that is coming together to work on some of the pressing sort of medical issues of the day. So I hope that collaboration continues, and of course, in a country like India, with the capacity it has, an institution like ICMR has a huge role to play, not just in setting priorities in this country, but also sort of leading the way for the rest of the world as well. So thank you. So I'll take some questions. I think the gentleman in blue, yes? Please stand up, state your name, affiliation, and the question.
Hello, I am Partho. I'm a professional consultant with a background in research. My question is, as you represent ICMR, which is a very pioneering body in India, very close to the government and policymakers. You referred about data warehousing, but the focus was more towards forefronting the data that we have, the plethora of data that we have. What I feel that is to add to that thing, there can be an analytics, health analytics, which will be very helpful. Why I'm saying that? Though health research hasn't been so developed in India, as you mentioned, still we have plethora of research studies, data, surveys across, which are discrete. Even you mentioned about PhD thesis research papers, which have leads. Now that's the end, wherein analytics can bring in wonders, because they will start with the linkage. First the linkage, then for the exploration of it. So health analytics as a profession within health, industry, will do wonders as it has done for other industries. So I think that's something wherein, if we focus, can do justice to the data that we have. It may be behavioral data, stated data, or might be your incidence data. But this stream will actually appreciate all the information we have in the optimal way that's possible.
Thank you. So, questions, please. Yes, gentleman out there.
Thank you. Afternoon. My name is Danish Ahmed and I work at the Public Health Foundation of India. I must congratulate you, Dr. Swami. That was an excellent presentation. And my question sort of stems from the fact that the health system in India is fragmented. And at one point we have a research agenda to find new therapies, new cures for existing diseases. But on the other hand, we also have existing knowledge that needs to go to the community, to the grassroots. In that sense, there's research need for that. And also there are a lot of NGOs that work across India in different capacities. You mentioned one forum, for example, for TB that will hopefully in the future bring different NGOs together. But going forward, how do we bring different agencies, NGOs, all working together under one roof so that knowledge dissemination is more, not only in research, but also in implementation, because that's, I think, a focus area. And in India, who do you think is responsible for ensuring that research agenda is driven? Is it the Ministry of Health's concern? Is it the ICMR? Who would you understand is the nodal agency, and then they would bring together everybody under one roof? Thank you.
Yeah, thank you for that question. I think it's quite important. Bringing everybody together in India is always going to be a challenge, because just the size and the diversity, but I know what you mean, and what you're saying is that there are a lot of NGOs and other groups doing good work with good findings, and perhaps those findings are not used as optimally as they could, or not taken note of, and so on. And that is a good point. Perhaps we should have something like a health research conference, something like that every year. I mean, there was one that was done recently on tribal health, which was best practices in tribal health. That brought about 20-25 NGOs together, and Ministry of Health was there, ICMR was there, and so it was in different areas, right from malaria to sickle cell to nutrition of under 3 children and so on. That was very useful exercise, and I think I'm sure would help drive some changes in the ministry. So we could think of, it would have to be focused on something, otherwise it'd probably be too diffuse, but I think it's a good point. And as to who should be the driver of this, I think the Department of Health Research, under which the ICMR comes, certainly should be the one that's really pushing this agenda of health research, but Ministry of Health has to be there, because they are the users, they are the end users, and they must be convinced of the need and the importance of research feeding into their programs. And I think there is now a good understanding and a demand from the ministry as to because realize that programs which are not based on evidence or data or experience are not as successful. So thank you for that point, and also for the point on health analytics. I think it's a very good point. There's no point just collecting huge masses of data if you're not going to be able to use it. we have lots of computational people in the country, but very few working on health analytics. The big buzzword now is big data. So I think we should be able to attract and train and retrain maybe a few people to work in this. I think we can learn a lot.
And as you pointed out, surely these discussions should happen not just in Delhi but also at the state level, where they're the end users of this information. They make the policy as well.
Correct.
Right.
One of the schemes that the DHR has now is to set up these multidisciplinary research units in medical colleges. I mentioned at the beginning the dearth of research coming from our medical colleges. So we've now funded about 40 government medical colleges and about 12 rural research units in primary health centers, where we've given them staff, some money for consumables, as well as very good basic equipments to do basic lab tests. So, but again, it's up to them now. The faculty has to generate the research questions and use the data. I think there's something at the back, somebody at the back.
Yes.
Yeah.
Hi, I'm Leena and I work a lot with civil society and MSF. So I had just one question. The government has a new innovation policy, both from the Niti Aayog, the former Planning Commission, and the Department of Industrial Policy. Both are focusing on intellectual property as a driver of biomedical research. What is the opinion of the ICMR on that issue?
Yes, I mean, I think ICMR, of course, believes in the, will follow the government policy on intellectual property. But there are many instances where we take a call on the IP generated being of public health importance, and therefore not necessarily has to be patented or anything, but rather has to be brought quickly into use. So there have been many instances. So I think we will always take an approach from what is needed from the public health aspect and support that. So it's not only going to be about filing patents.
All right, the gentleman there.
I am Dr. Dipankar Maji, coming from West Bengal Health Department. Ma'am, you have spoken a good many words on convergence of different agencies. And now, as you already have a huge experience of working with different organizations and going into different fields, I like to ask once again from you, apart from the last point that you spoke on, this transdisciplinary research activities, if you say a few more words on how the NGOs and the government platform, they can work together, they can supplement each other. I ask this because the government machinery has its plus points. It's a huge machinery spread all over the country. And on the other hand, the NGOs, they have their plus points. They can percolate to even the remotest places. So how these two different type of organisms, they can supplement each other, I want to hear a few more words from you.
I think there have been examples, where they've worked together. Certainly the ICMR, funds research in NGOs as well. We don't have a policy of not funding only government. We fund private also and NGOs also. And recently we had a brainstorming on mental health priorities. And we invited several NGOs from around the country because they are the ones actually who are doing a lot in mental health. Much more, I think, than what's happening really through the government platforms. And so, again, the conclusion at the end was we discussed various priorities and so on, but how to make it work. And everybody agreed that if a state government wanted to really implement the district mental health policy, then it would be best done with an agency that had experience in the field and was working in the community and that had already found a way of implementing the policy. And I think 9 out of 10 times that organization would be an NGO, but there may be also government institutions that have done it. I mean, there are several. So I think now what we are trying to do is to convene the groups together, the NGOs as well as government, in many areas. Mental health is one example, but I think in the whole, in every area you can think of examples, and then set up programs where this could actually be implemented. So again, it would be it would be implementation research in partnership with the government and NGOs, and then demonstrate. And I think where it's worked, we should we should write it up and put it out there so that people can actually learn from examples. So if any of you are aware of such things, I think it's worth writing about.
Wait, microphone, please. And please state your name and...
Yeah, I'm Mohua. Ma'am knows me.
No, it's not for ma'am. It's for the camera and it's for other people watching. There are people watching. Please state your name.
All
and
right, my name is Mohua Chaudhary. Okay, I am a journalist and I'm also doing some research in Jharkhand, as I discussed before. Ma'am, I just wanted to ask you, in places like southern parts of Chhattisgarh and in Jharkhand, there's a huge amount of discrimination. So NGOs also don't reach out to in these tribal areas. So how are you going to be able to manage it in case you're doing research there? Because we do need to do research there. There's a lot of disease burden which goes unaddressed. So how do we do that? Because in tribal areas discrimination is rampant. So which is why ASHAs don't go there, and the PHCs don't work, CHC don't work. So for you to be able to do research, do you think the state will give you the kind of support that you think that is required right now? Because I'm very concerned about that.
See, the ICMR can't do everything. You know, the ICMR has 32 institutes, 8,000 staff, and only about 800 scientists. So that's a very small number for the country.
Yeah.
The ICMR can promote and support research and help people who want to do it, but somebody should be willing to come forward and do it. So whether it's a medical college faculty, and we can encourage, we can highlight, we can bring these sort of things to the fore and say, these are gaps, these are areas where nobody is working. We can put out a call and say, you know, this is what we would like people to do. So that we can facilitate. But obviously we can't ourselves reach every corner of the country and address every problem.
So you do need some help at the state level itself.
From the state, definitely. And very often the states are now coming up, you know, the state health departments are coming to us and saying, you know, come and help us with this. We've got cancer as our problem here. You know, we've got malaria in this area, which is very resistant. We've tried everything, it's not going away. So there we step in and we say, okay, now let's convene people and let's find a solution to this issue.
So if a team is put together by the state, then you'd be able to...
Yeah, so more and more we are responding to state government's request to us.
That's the step that needs to be taken. Okay, thank you.
If I may ask you a question. So you identified the amount of research that is being done by medical universities as not being adequate. Well, what about the issue of quality and the issue of ethical review, etc., which is again a huge stumbling block to research being done in this country? We know that clinical trials are now being many clinical trials have stalled because there's no clarity in guidelines, etc. So how ICMR, I suppose, is the institution that should be taking leadership in this area. Can you please comment on that?
Thanks for that question, because it's a very important area. I didn't have time to mention it. So ICMR, of course, has been, you know, developing the guidelines. We're now revising the 2006 guidelines for research. They should come out in 2016 with many newer areas added on, like research in tribal populations, research in children, and also research in the area of genetics, gene editing, stem cells, and so on. We are not a regulatory body, so we make guidelines. This is yet to become a bill. Hopefully in the next couple of years, the biomedical research regulation bill will become a reality, in which case then there'll be it'll become law, and, you know, people would have to abide by it. But meanwhile, what we're trying to do is to work with the different stakeholders in the whole area of regulatory science. And this obviously involves investigators, it involves ethics committees, it involves the review panels that sit at the DCGI, and it also involves the Medical Council of India, who has to take action when people are found doing unethical things. So it involves all these stakeholders. We've been most closely working with the DCGI in re-looking at these clinical trial regulations, and a lot of changes have happened and are going to happen in the coming months, which will put more burden on the ethics committees actually. So this is where I think we're going to have a challenge. We have more than 1,000 ethics committees registered with the CDSCO, all of varying quality. So we, at the moment, don't have a system of accreditation, but that's coming. So they will have to be accredited, which means they'll have to be trained as well. A lot of capacity has to be developed. So we are working now. There are 3 or 4 consortia in India that have been doing training for ethics committees. We're trying to bring everybody together onto a common platform, have some common training modules, set up some online training as well as, in-person training. But it is very much needed. Mm-hmm. We also have to work, I think here the media can also play a role, because mostly it's all the negative aspects of clinical trials that get highlighted in the media. And the positive stories are never told. Why are clinical trials important? What advances have come because of clinical trials, and why nothing can advance in medicine without clinical trials. So I think public needs to be educated about it, and more communication from scientists has to be there, more openness and transparency, and more community advisory boards. I think there are very few institutions which have community advisory boards. Everybody has to have an ethics committee, but I think we should encourage more institutions to set up community advisory boards. That's a good way of engagement with the community.
Perhaps a Fogarty type program in India where ICMR takes the lead in educating all these researchers, but also maybe making ethics part of medical curriculum. I think
Absolutely.
Very little exposure to ethics in medical colleges. I think that's a good place to start, I would say. Last question before we break for lunch. Yes, please, gentlemen. Yeah.
Dr. Tej Aluwalia, ex-ICMR scientist. Madam, out-of-pocket expenditure is still in India is 70 to 80%. So how we can make the health systems available, accessible and affordable for the common masses in India? Because if one person in a rural village get a cancer or any type of cardiovascular diseases, the farmer has to sold his land, and the farmer has, over a period of 2 to 3 years, the farmer's family becomes laborer family. So how to solve that problem of affordability, accessibility and availability of the health systems, services to the common masses in the country? Thank you.
Okay, you have the whole afternoon to answer that.
No, in the next 2 days as well. So.
No, but it's a very important question.
It's an important question. We can't answer it now. Everybody is debating this. You know that there are panel after committee who has made recommendations. It's being considered now by different arms of the government as to which is the best approach. Different states are doing different things. Some people are privatizing primary health care, talking about insurance coverage. So I think this is an area where obviously there will be need for a lot of debate and maybe some evidence generation as well, but there's no answer that I can give you in 2 sentences. But I do think that we've neglected preventive and promotive health care. We've been focusing entirely on treatment, and therefore we have to build more and more tertiary care facilities, and we're looking only at that. How do we provide tertiary care facilities now to the people who need it, which certainly has to be provided. But how do we prevent more of those things from happening, more chronic kidney disease, more cardiovascular disease? That has to be only by prevention and promotion. So I think that is where we need to focus, how to make our primary health care stronger. And that aspect of the whole alma mater has been completely forgotten. So,
but yet the budgetary allocation for health has gone down, and the stress, they've been focusing more on developing tertiary, setting up aims in every state. So do you expect in the next budget that some of this imbalance will be sort of addressed? Or?
I think we have to advocate for that.
Yeah.
And we have to talk with data and with evidence. Yeah.
All right. I think we'll sort of stop here for lunch, and we will meet again. There are 2 more exciting sessions in the afternoon, and we'll see you back in half an hour. Oh, okay. And the people who are part of panel 2, please stay back for a briefing while the others can proceed for lunch. Thank you. Thank you. Please thank Dr. Swaminathan for an excellent presentation. But is there a real sort of advocacy going on?
India, home to more than 1 billion people, it is also home to the neglected tropical disease, Kala Azar. The disease has many names: Kala Azar, Kala Jwar, black fever, dum-dum fever, and its medical name, visceral leishmaniasis, or simply VL. No matter what it's called, Kala Azar is very much a disease of the poor. 15-year-old Naina has Kala Azar. Naina lives in Bihar state, northern India, home to more than 100 million people and the epicenter of Kala Azar in India. Half the world's cases of Kala Azar occur in India, and 90% of those are in Bihar.
जब काला जार का बुखार आया तो मुझे ठंड लग रही थी, भूख नहीं लग रही थी और मेरे पेट में दर्द हो जा रहा था और मैं चल रही थी तो चलने का मन नहीं कर रहा था, लग रहा था अब मैं गिर जाऊंगी.
More than half of Bihar's population live below the poverty line and are among India's poorest and most vulnerable. The importance of education is therefore well understood in Bihar, and this plays heavily on Naina's mind.
उसके बाद मैं 2 महीने तक स्कूल नहीं गई, मैं छुट्टी उसमें लगा दी हूँ. यूँ तो मैं और सोचकर दुबली पतली हो गई हूँ. मैं हमेशा सोचती हूँ कि मेरे को अभी मैट्रिक का एग्ज़ाम देना है और मैं पढ़ नहीं रही तो कैसे पास होंगी. मैं जब यहाँ से ठीक होकर चली जाऊँगी तो मैं पढ़ाई में बहुत मन लगाऊँगी, कम से कम 8-9 घंटा तो ज़रूर पढ़ूँगी मैं, तब तो आगे बढ़ूँगी ना, तब तो पास होंगी ना.
At the London School of Hygiene and Tropical Medicine, Dr. Saqib Burza explains Kala Azar.
So Kala Azar is one of the most neglected tropical diseases. It exists in specific areas, specific regions in the world: South America, East Africa, and the Indian subcontinent. Essentially, it's a disease of parasites which is transmitted by a sandfly. The sandfly tends to reside inside and around the domestic area of the house, and especially prevalent in areas where there's poor quality housing. As such, it tends to be a disease of the poorest that affects the poorest and the most marginalized and vulnerable in society.
Dr. Temi Sunioto works with Médecins Sans Frontières in India.
The symptoms that may arise is, first of all, fever, and the fever should be prolonged, meaning more than 2 weeks, and then also the patient starts to have a loss of appetite, leading to the weight loss, and eventually a swelling of the internal organ, like swelling of the spleen and swelling of the liver. I know that in the end, this Kala Azar will reduce the immunity of the body, so eventually the patient could die due to any other infection.
Dr. Pradeep Das works with RMRI, the Rajendra Memorial Research Institute of Medical Sciences in Bihar's capital, Patna.
In India, it is caused by Leishmania donovani, a protozoan parasite. But in the world, there are many species, about 20 species, which causes leishmaniasis, but mainly are cutaneous, but Kala Azar causes visceral leishmaniasis. And in India, practically in Bihar, it is most common public health problem.
Kala Azar is almost always fatal if left untreated. Naina has come to the MSF-run Kala Azar ward at Sadar Hospital in Hajipur in Vaishali district, Bihar.
जहाँ जहाँ आदमी बोल रहे हैं, जहाँ जहाँ डॉक्टर दिखाने के लिए तो हम वहाँ पहुँच रहे हैं. हम लोग ठीक होने के कारण ठीक हो जाएगी. बच्चे ठीक रहता तब ना माँ बाप को अच्छा लगता है.
There are many challenges working in an area like Bihar. Bihar is one of the poorest states in India, with some of the poorest health indicators and the poorest literacy rates. An estimated 56% of the population lives below the poverty line and for the most part are dependent on the public health system to receive quality treatment. But with a dysfunctional public health system, the population is forced into the private health system, which is largely non-allopathic, consisting of rural health practitioners without formal medical training.
Also, as a result, there's quite a lot of cost incurred to these patients. So these patients who are already extremely poor then incur sometimes catastrophic costs in order to achieve inferior quality treatments and diagnoses.
Ganesh Paswan, who was treated more than 4 years ago, knows only too well the long and costly road to diagnosis and inferior treatment.
इससे हम यहाँ से ताजपुर के तरफ थे, मौरिया चूड़ा मिल में थे. वहाँ पे हमको बुखार लगा. मालिक को कहे जी भाई हमको बुखार लग रहा है. मालिक ने हमको गोटी ला के दिया. मतलब 5-6 दिन लाके गोटी दिया. फिर भी नहीं ठीक हुआ. तो देखे जो मतलब रात में सोने वक्त हमको इतना पसीना बादू देता था. हम सोचे जी बादू किस लिए देता है. वहाँ का डॉक्टर सुई लगाते लगाते थक गया. वो बताते ही न थे कि मैं वहाँ से मालिक को बताए जी हम यहाँ ना ठीक होंगे, मैं जा रहा हूँ अपना घर पे.
Ganesh was soon misdiagnosed with malaria and received injections for several days. Injections that each cost the equivalent of a day's wages. The doctor then suggested a blood test, another expense.
उनके ठीक है. बोले जी पैसा इसमें लगेगा 500 रुपया. उनके जब हम ठीक हो जाए तो इसमें क्या है. उनको 500 रुपया दिए, खून टेस्ट कराए तो यही से रिपोर्ट ये दिए बना के डॉक्टर साहब जी आपके पास में कल आ जा रहे.
Ganesh was given a week's supply of pills and had to return every 7 days for another week's supply. He was also told to avoid strenuous work for a year.
तो हम साल भर नहीं काम की तो ससुराल वाले से कर्जा लेते थे, गांव वाले से कर्जा लेके जो भाई हम ठीक हो जाएंगे तो काम करेंगे तो दे देंगे. तो गांव वाला से 10,000-15,000 रुपया ना लेके खाते थे. तो इस वक्त में मजबूरी में हमको काम करना पड़ा. और बच्चे को देखे कि अपना जान को देखे. और बच्चे के लिए अपना खुद जान को अथी करने लगे. तो काम करते करते हौले 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 करके मतलब आधा पीठ खा के महाजन को देने लगे पैसा. फिर भी अभी भी हमको अभी इतना करते ही 30,000 रुपया पड़ जाए.
Despite the seriousness of Kala Azar, it remains a neglected disease. Many believe this is simply a matter of location. Not only does Kala Azar affect the poorest regions of India, but it affects the poorest people within those states. It is, according to Dr. T.K. Jha, one of the unjust characteristics of Kala Azar.
Take the history of Kala Azar. I say that this is one of the most undemocratic diseases because it affects the poorest of the poor.
Without a strong political voice, the marginalized and most vulnerable are left to compete with what are considered more pressing health concerns, namely tuberculosis, malaria, and HIV. In a resource-poor setting like rural India, the ability to focus on a disease that affects only a subset of society is impossible. As with so much of their lives, those with Kala Azar simply become casualties of circumstance. There is also the financial issue, according to Dr. Suman Rijal from the Drugs for Neglected Diseases Initiative, DNDI.
There is no incentive for the current pharma industries to invest in making better tools for treatment of Kala Azar. So till about a decade ago, we were still using treatments which was introduced in the 1940s and 50s, the sodium antimony gluconate. It's only in the last 15 years when there has been a few champions who have come out and really pushed the agenda.
One of those champions was MSF, an organization that has always had an interest in neglected tropical diseases. For MSF, working in Bihar was a natural fit, and by the early 2000s, finding a less toxic, less time-consuming, and an easily accessible treatment for Kala Azar than what was currently available became a priority. The move away from the toxic and increasingly resistant sodium stiboglutamate, SSG, had begun, and other drugs and combination therapies were being used. Sodium antimony gluconate, pentamidine, miltefosine, paromomycin, and amphotericin B.
A new drug in the West that had been identified for the treatment of fungal infections in cancer patients, something called liposomal amphotericin B, which is in fact it's a different version of an old drug called amphotericin B, which it's a different formulation which allows it to be given in a higher dose over a much shorter period and is far less toxic. This is a drug that was recognized as an appropriate treatment for Kala-Azar, much safer and much more effective than the alternate treatments. As such, MSF decided to intervene in order to develop the evidence base that would allow policymakers to consider liposomal amphotericin B as the most appropriate treatment for Kala-Azar in the Indian subcontinent.
Dr. Nina Slima from MSF in Barcelona was involved in MSF's Kala-Azar project in Bihar from the beginning.
So what we really proposed in 2005 was to start a project treating the patients, a large cohort of patients with the best treatment available, which is liposomal amphotericin B. This was the best treatment option because it was the most effective treatment and the safest, so it could be used for all age groups and also for women in childbearing age.
However, there was reluctance to accept MSF's proposal. The use of liposomal amphotericin B, what was to become known as ambisome, had not been proven at a large scale. The drug was expensive and it required cold chain. The feasibility of using ambisome was not looking promising.
I heard that there is a project submitted to Government of India and Government of Bihar by MSF for treatment of Kala-Azar cases. But it was not been passed at 2005. In 2006, I presented this project to Ministry of Health and Family Welfare. At that time, the NBDCP people came to Patna and they said that whether you really want to be a partner of this. We said, okay, we want to be a real partner of MSF. And then we submitted again in 2006. They asked us to some modification. Again, I presented in the Health Ministry Steering Committee. And this project was then sanctioned in 2007 in partnership with MSF and RMRI.
2 years of negotiations followed, but only when MSF could show that it could lower the price and prove the effectiveness and safety of patients did they get the green light.
So we started to treat the first patient in 2007, the 16th of July. The first child was treated in a hospital in Hajipur in Vaishali district, which was one of the highly endemic districts of Bihar state. And we could do it thanks to doing a partnership with a research entity, Indian research entity. So RMRI was one of our major partnerships. They allowed us to import the medication, to set up properly the project, and we were collaborating with them so that we could possibly publish our data and try to establish the influence we wanted to make in India to switch the protocols.
As the work continued and various combinations of miltefosine, paromomycin and ambisome were used, evidence began pointing towards single-dose ambisome as the most effective and beneficial first-line treatment.
This is when MSF decides to do a study with the NDI to show it at a large scale, so the different combination modalities and the single-dose ambisome, which was really what MSF was supporting because it's a single point of care, so the patients can come and be treated with fatal disease like Kala-Azar in 1 to 2 hours of hospitalization or at primary healthcare level. So either at hospital level, at community level, which is really increasing the access to these populations.
By December 2013, MSF could prove the effectiveness of single-dose ambisome. They showed a 98% cure rate of Kala-Azar, a reduced hospitalization cost alongside the reduced hospitalization time, and an increase in the access to healthcare.
Well, the benefit of this new treatment would actually will have impact to the patients, because the patient used to have to first undergo various different diagnostic before finally diagnosed with Kala-Azar, and in the end, when they are diagnosed with Kala-Azar, they have to have treatment that are either having a very bad side effects or have to make them hospitalized for quite a prolonged period. So even a day of having to go to the hospital and being hospitalized will mean a lot in terms of the loss of their income.
All those involved in Kala-Azar in India, Bangladesh and Nepal began pushing the WHO to recommend single-dose ambisome as the first-line treatment to Kala-Azar. Success came when the treatment protocols were changed in September 2014.
It's one long-awaited change, I would say, in the treatment protocol, and I think this is going to be a crucial game changer in terms of finally controlling the disease in one of the most high-burden center of Kala-Azar in the whole world.
Back in Sadar Hospital, nurses prepare single-dose ambisome for Naina. The treatment is given intravenously over a period of 2 to 3 hours.
यहाँ आने के लिए इमरजेंसी डॉक्टर साहब ने बोले और इलाज के बारे में अभी मैं नहीं जानती। डॉक्टर साहब तो बोले थे एक ही दिन आने के लिए, उसके बाद शाम को छोड़ देंगे। दवा मिल जाएगा, मैं ठीक हो जाऊंगी तो घर चली जाऊंगी।
Naina gets comfortable and her treatment begins. Thankfully, 55-year-old farmer Jageshwar Rai was referred to the Sadar hospital.
तो वहाँ हम ओम प्रकाश कर गए, पुत्र साथ में था, वो हमको धरा कर दे गया, हाथ पकड़ के चलने में भी नहीं हम सकते थे। बहुत ही निछतर का तेज है, आपको एकदम तुरंत कलाजार पकड़ा है, यहाँ आ गए से हम आज देते हैं कागज़ बनाकर चले जाइए सदर हॉस्पिटल में से आपको वहाँ खाना मिलेगा और बढ़िया ढंग से इलाज होगा, हैं से वहाँ चले जाइए। भर्ती के बाद में इलाज चला, रात में हमको शीशी जो पानी होता है पीला करके वो हमको चढ़ाए, बस देखने को हम टन टन बोलने लगे। हम पुराना कहानी इनको कह देते हैं। देखिए कालाजार हुआ हम लोग भैंसी के साथ है, मतलब अगल में खाट बिछा कर सोते हैं, और गंदा उंदा रहता है तो हम कितनों होश में रहते हैं, लेकिन हमको ये गोबरे से धरिए उपतनती है। सब चीज़ अच्छा लग रहा है अब पहले हमको जहर लगता था मैडम। बहुत आदमी को इलाज हुआ है अलग अलग से, लेकिन सदर हॉस्पिटल में हम ही गए हैं सर, सदर हॉस्पिटल में वहाँ हमको पैसा नहीं लगा, मुफ्त इलाज। कितना डेट कर गया, हमारा भाई एगो चचेरा डेट कर गया, पहलवान इतना मोटा था, तो उस टाइम में ये दवा भी नहीं था, विदेशी दवाई नहीं था, वो डेट कर गया।
But medication is simply one part of the triangle that is Kala-Azar. Former MSF doctor and now part of the Kala-Core consortium, Dr. Bernard Benka explains.
So it's a vector-borne disease. So basically you have three important parts. You have one is the patient or the host, then you have the parasite, and then you have the vector, which is the sandfly, which carries the parasite. So you have to intervene on each level, and exactly that makes these vector-borne diseases like really difficult to eliminate, let's say. It depends also entirely on the host. In India, we have the advantage that it's believed that human is the only host of the parasite. So we think if we just like find and treat every single patient, we should be able to control the disease.
Finding patients can be as simple as going door to door. This is where Ashas, or accredited social health activists like Kishto Devi, play a crucial role. Ashas are community health workers employed by the Ministry of Health to actively identify and screen likely patients and raise awareness about Kala-Azar.
MSF के बारे में बहुत जानते हैं, उन्हीं लोग को ट्रेनिंग दिए हुआ है, हम लोग पूरा जानकार हुए हैं, क्या क्या करना है, कैसे बालू मक्खी होता है, पैदा कहाँ रहता है, बुखार कालाजार जो होता है से कौन चीज़ के काटने से होता है, सब हम MSF के द्वारा ट्रेनिंग मिला है तो हम लोग के जानकारी हो गया है। तो हम लोग जानकारी हो गया तो हम लोग जाके रहे घरे घर, तो लोग को हम कहते हैं 100-150 घर घूमते हैं, घरे घर जाके पूछते हैं कैसा है, किसी को बुखार तो नहीं है, कोई की बुखार है अगर तो जाकर स्वास्थ्य केंद्र में दिखावे, ब्लड व्लड जाँच कराएं। जैसे कि यहाँ में जाँच में आया कि कालाजार पॉजिटिव है तो लेके जाते हैं हाजीपुर।
Kishtal Devi has another way of spreading health messages about Kala Azar. She sings,
झूठ बोले खटमल काटे, ऐसे खटमल से ना डरियो। जैसे कि हमको गाना अच्छा लगता है, हर चीज पर हम गाना बना लेते हैं। क्यों डरियो बालू मक्खी से तुम देखते रहियो। अगर हम गाना गाएंगे और गाते हैं तो लोगों को लगता है कि इस तरह से बालू मक्खी काटने से बुखार लगता है, यहाँ रहता है बालू मक्खी, मच्छरदानी में सोना चाहिए, ब्लड जांच कराना चाहिए। हमको जानकारी तो हम कह देते हैं कैसे सब बात है, हमको जानकारी। मैया तोरे पियरी चढ़ाईबो, मोर रानी बेटिया के बुखरवा छुराई द।
In addition to running the Kala Azar ward at Sadar Hospital, MSF supports 5 primary health centers or PHCs throughout Vaishali district, including on the river island of Raghopur. In this remote setting, MSF staff conduct an IEC session, Information, Education and Communication, to inform villagers about Kala Azar, how it is contracted, its symptoms, and how to receive treatment. In villages such as these, the unsanitary living conditions are obvious. So too is the proximity of animals and animal waste to humans, and the general use of thatched housing. When combined with the abundance of water and high humidity, you have ideal conditions for sandflies to live and breed. Ramchandra is the government nurse at the Raghopur Primary Health Center.
कालाजार यहाँ अधिक गंदगी से, बालू मक्खी से होता है, और अभी तो कालाजार के विषय में पब्लिक जान गए हैं कि 2 सप्ताह से अधिक होने पर बुखार और कालाजार का शंका है और पीएससी में जाना ज़रूरी है, और पीएससी आते हैं तो उनको इलाज होता है।
If a person presents at a primary health center or PHC with a fever, the doctor may suspect Kala Azar. The doctor will then recommend an RK39 test, a highly accurate, rapid diagnostic test for Kala Azar.
हम उनको RK39 करते हैं, फिर लेटा करके उनका एस्प्लिन देखते हैं। एस्प्लिन अगर मिला, RK39 पॉजिटिव हुआ, तो हमने उसका इलाज शुरू कर देते हैं एक सिंगल डोज में। ये सिंगल डोज बहुत अच्छा लग रहा है, मरीज को भी सुविधा मिल रहा है और मरीज तुरंत क्योर हो रहा है।
Apart from diagnosis and treatment, controlling the vector is equally important.
How is that done? Mostly by spraying. So in this IRS or indoor residual spraying is also a very important activity within Kala Azar disease control, let's say. It's not only treating the patients, there's like many other things in these like kind of vector-borne diseases that you have to take care of to achieve actually elimination.
With continuing vector control, good IEC programs, and a highly successful first-line treatment, elimination of the disease is now firmly on the cards. But challenges and questions remain.
Okay, so the elimination of Kala Azar would actually just mean that the Kala Azar ceases as a public health problem. It doesn't mean that we will have a 0 case immediately, but let's say that the scope of the problem will not be as massive as it is now.
What we have to achieve is to bring down the incidence rate to 1 or less than 1 per 10,000 population at PSC level.
You have to understand, and we understand that it will be probably like more difficult, that once elimination is achieved, that actually everyone keeps up the good work and the effort to sustain this elimination and not like just lays back and relaxes and then like things turn bad again.
You have to maintain good quality of indoor spray, you have to maintain the surveillance, you have to maintain the treatment, and all the activities which are being done today, they have to continue it.
Once a patient is cured of Kala-azar, they could also develop a skin complication called PKDL, the post-Kala-azar dermal leishmaniasis, which also known to be quite an important reservoir for the parasite, and then it potentially could prolong the transmission. So apart from the Kala-azar itself that are being treated by the single-dose ambisome, there are other subgroup population with the patient that needs to be also addressed in order to achieve the elimination.
We have to also think about asymptomatic carriers, because our study from this institute first time showed that about 18% of the asymptomatic, they become the full-blown cases within 3 months.
One of the things we realized after starting the project was that we were getting a lot of patients who were coming with relapses despite being treated with this very good drug, liposomal amphotericin B. What we realized then is that a lot of these patients were presenting positive for HIV, and of whom half didn't even know that they had HIV. So we were the first people to diagnose them with both Kala-azar and with HIV.
HIV-associated Kala-azar, they are swarming with parasite. Wherever, right from top to bottom, you find the parasite is there. The parasitemia is more than 100 times than active case of Kala-azar.
Co-infection itself is a real problem for both the patient and the public health provider, because these patients tend to have very poor outcomes first of all. Secondly, they tend to relapse frequently. And thirdly, when you've got a limited number of drugs to treat these patients, there's a much higher probability of these patients spreading the disease and developing resistant strains to the drugs that currently exist.
It is now the afternoon. Naina has received the ambisome and is feeling well. And just like that, it is time to go home.
मैं घर जाके अपने भाई सब के बताऊंगी कि वहाँ पे ऐसे ऐसे होता है. वहाँ पे काला-जार का इलाज बहुत अच्छा होता है. वहाँ का डॉक्टर साहब बहुत अच्छे होते हैं. फिर नर्स मैम भी बहुत अच्छी होती है. मैं अपने दोस्तों को बताऊंगी कि अगर तुम्हें काला-जार होगा तो तुम हाजीपुर सदर अस्पताल में जाओगी. वहाँ पे ठीक हो जाएगा.
The question of whether or not we're on the right track, I think the answer is yes. I think there's now, in my entire time of dealing in VL, I've never seen such a huge political commitment from across the spectrum, both from the local governments, from the WHO, from the international stakeholders, from the international NGOs. Over the last couple of years, there's been a real coming together of all the different partners to try and take these urgent steps to eliminate and control this disease. To put it simply, if we don't manage to do it in the next couple of years with all the political, financial and stakeholder support that we have, then it's going to be hard to actually do it in the future.
Good afternoon, everybody. Please be seated. We have much ground to cover in the afternoon. We have two interesting sessions, an interesting lecture on 3D printing, and also you shouldn't miss the posters that are put outside. So let's not waste much more time. Let's get started. All right. All right. So the first afternoon session will be on hepatitis C, delivering care and hope for hepatitis C, barriers, responses, and the lessons learned. And it gives me great pleasure to introduce the chair for the session, Dr. B.B. Rivari, Bharat Bhushan Rivari, is currently working with the WHO country office in India as the NPO and has over 100 publications to his credit. He's involved in a number of research projects with ICMR, UCLA, and Brown University. He has also undergone training on HIV clinical management in Thailand and Japan. He has also received a Fogarty Fellowship on HIV at Johns Hopkins University in Baltimore and was awarded the Fellowship of Royal College of Physicians, Ireland in 2010. So Dr. B.B. Rivari, welcome. Dr. Rivari will then, of course, introduce the rest of the panelists and invite them to the podium. Thank you. I wish you all a good afternoon of discussions.
Thank you, Gunni, and organizers for giving me this opportunity. And I think this session is coming at a very opportune time when the World Health Assembly itself is discussing the global health sector strategy and the targets that has been contained in the global health sector strategy for hepatitis. So I think most of you are aware of the magnitude of the problem, that there are around 240 million cases worldwide with hepatitis B, more than 140 million estimated with hepatitis C, and more than 20 million deaths due to hepatitis alone. And these are much more than the total HIV and TB deaths put together. Also in Southeast Asia, there are almost 100 million people living with chronic hepatitis B, almost 30 million with hepatitis C, and Indian scenario, if you come, we have almost 6 to 12 million cases estimated with hepatitis C based on the studies, which are not very large studies but extrapolated to the population. You may be aware that the global health sector strategy for hepatitis 2016-21 has set some very ambitious target, and that include bringing down the annual infections of hepatitis B from 6 million to less than 1 million, that is 0.9 million. Also reducing the death from 1.4 million to less than 0.5 million. So these are very ambitious targets, which are at the moment very challenging because there are no defined hepatitis program in many countries of the world, including India. But again, as we discuss this session organized by MSF, I would just like to brief you that now WHO has engaged with Government of India, and Government of India has agreed in principle to start a hepatitis C treatment program in India that is likely to be launched. We are just in the process of formalizing the guidelines and other things, and Lina is well aware of the progress on this. So to begin with this session, I would like to invite our first speaker, Dr. Safia, who is a public health professional with an interest in finding preventive health solution and capacity building for marginalized populations. She has worked in many countries of the world on contemporary health crises. I would request Dr. Safia for her presentation, first talk. Topic of her talk is Introduction of directly acting antivirals for hepatitis C treatment in a primary care clinic in Karachi, Pakistan. Dr. Safia.
Good afternoon, everyone. I hope you had a good lunch. I have the enviable task of getting you out of your food coma. So I'm presenting on behalf of Dimitro and the rest of the team in Karachi who's been doing wonderful work. Unfortunately, none of them could make it here today. The title of the abstract they submitted, the work they're doing, what I'm presenting today, is Hepatitis C Treatment in a Primary Healthcare Clinic in the High Hepatitis C Virus Burden Setting of Karachi, Pakistan. Just to give you some context, so this is a map of Pakistan with hepatitis C seroprevalence in Pakistan at the district level. Karachi is a coastal city, and it's the largest megapolis of the country. It's a financial hub. Since 1947, there have been refugees, migrants, IDPs that have migrated there, so it's quite a melting pot. Hepatitis C infection in Pakistan, to give you some background on that, there was a national prevalence survey conducted in 2007-2008 by Pakistan Medical Research Council of hepatitis C virus antibody seropositivity, which showed it to be at 4.9%. Later on, between 2010-2015, a systematic review was also conducted, which showed an even higher adult Pakistani population prevalence of 6.8%. However, given that the census in Pakistan hasn't been conducted since 1998, making large estimates is difficult to do. It's not very reliable. I will, however, give you an idea based on current research. Provincial prevalence data varies considerably. In Sindh, so we have 4 provinces. Sindh, it's 5%. Punjab, it's 6.7%. Balochistan, 1.5%. And Khyber Pakhtunkhwa, not listed on the slide, is 1.1%. There are pockets of higher prevalence. What I mean by that is that within the city, there's urban, peri-urban, and rural. You've got within districts as well as within the different provinces. So very big, different. There's a lot of variabilities of high prevalence. Yeah. Give you a context of where the study was conducted, where the work was done. MSF intervention has been in Machar Colony in Karachi. Machar Colony itself is an informal settlement. The population, according to MSF's project document, is 150,000. 150K, yeah, and 300,000. MSF Primary Healthcare Clinic has been there since 2012, which is actually when I joined there as well. And initially the focus was on emergency care. So it was a standalone emergency care. However, they changed the project orientation and to suit the needs better to the population. And MSF is working with the SINA over there. Hepatitis C was recognized as an important health issue because of all the global work done that in this regard, and screening because of this was started by MSF in March 2015. So therefore it is now a primary healthcare clinic and it has a focus on hepatitis C. Treatment of chronic hepatitis C virus infection was also started later that year in May 2015. To give you an idea of the care delivery, it's an integrated primary care facility. It started off as a little corner in the setting, so it was a small corner, and over there it was dedicated. They had GPs there who were trained, and they were only specializing and working on this. The rest of the care, meaning the lab, the mental health support, the nurses, all of that is integrated, so it's shared with the rest of the setting and the facility. And the good thing about this is that the colony, it suits their needs, the primary healthcare setting. Screening was conducted according to WHO guidelines, so there was rapid diagnostic point of care tests. Chronic hepatitis C confirmation was done via PCR later. Then you know about the APRI score. So it's a ratio index of AST and platelets. It was used to stage initiation of the treatment, okay, for staging, so prioritize treatment. Sofosbuvir and weight-based ribavirin at 12 or 24 weeks was used, and that's why it was important. I'll come back to that as to why it's 12 or 24 weeks. It's based on genotyping. The treatment, we have hepatitis C virus viral load was conducted at baseline, end of treatment, and for 12 weeks after treatment completion to ensure there's no relapse or to check for it. Data was collected under routine programmatic conditions, and because this was the standard of care, MSF provided, its ethic review board provided an exemption in this regard. Okay, so we have the results. We have 4,589 patients of MSF clinic was screened between March 2015 and April 2016. 27% of these were hepatitis C virus antibody positive. A total we had was of 1598. Some of them were screened within the clinic, some of them from outside, but total we had 1598. That was our population. 25% of these patients had APRI already greater than 1. As you know, APRI gives you an idea of how bad the fibrosis and cirrhosis is. So we have 368 hepatitis C virus genotype results were already available. I'll show you that in the next slide. This is the distribution of the hepatitis C genotypes. The green area is the genotype type 3, which is the most common in Pakistan as well, as it's also what we found in our results, followed by type 1 and then type 2. So it's exactly the same distribution in Pakistan currently. Okay. According to the results, we had 300 patients who initiated their treatment between April 2015 and May 2016. 136 of these patients completed their treatment. 135 therefore had negative PCR at completion. 1 still had positive. 15 were lost to follow-up, and 1 patient discontinued treatment due to other medical reasons. 155 patients, so that's almost 51%, are still on treatment. This is an in-clinic part of the cascade to give you an idea. I hope you can see that clearly, the labels on the axis. To give you an idea, this is the complete follow-up outcomes. Unfortunately, given that this was in routine programmatic conditions, we only have 45 completed follow-ups. So the end of treatment response was, though, at 95%, which is quite high, and we didn't expect that. And the SVR12 was 78%. So this is comparable to a lot of clinical trials, and that was also what was very surprising. Clinical trials show between 75 to 95% of SVR, and this was 78. So that was under routine programmatic conditions, which is quite incredible. Relapse was of only 1 patient. Lost to follow-up before end of treatment was 1, which means the patient didn't complete their treatment. Only 1 patient didn't. Lost to follow-up after end of treatment was 7, which means that they finished their treatment. However, they weren't classified, and we couldn't follow up to check to see whether they relapsed or not, which was 15%. Failure was 1%. 1, which is 2%. Just to give you an idea, so the conclusions from this that we can draw, again, it's very interim, very small. You saw we had a complete follow-up of only 45. So we have to be a little bit cautious of the conclusions we draw. However, it is a simplification of diagnostic and treatment algorithm, which is pretty surprising. You would expect hepatitis C care to be in specialized centers. However, this was decentralized. If you remember, it's a primary healthcare setting. We had 78%, which had SVR12, so that showed they had successfully been cured. And it shows that it can provide care at primary healthcare setting to the affected communities at the community level, and therefore this feasible so far this model does seem feasible. The challenges that we're still facing, however, and that need to be addressed are the need for referral of complex cases such as decompensated cases and things like these to hepatology centers. And so we're currently collaborating with centers and specialists in Karachi to work with them and to have reference specialists in place and see if we can go forward with that for the special cases that require further care. IV drug users, which is intravenous drug users in the clinic, were not utilized in the study. We did not include them because this is a special population, and even though Karachi has one of the highest heroin users and IV in the world, it is very important to note that these require special case finding strategy. You have to be sensitive. We have to try not to alienate these people because we want to make sure we can complete the treatment that we get them on. And I think Dimitri wanted to thank all these people. So again, on his behalf, most importantly, the patients who trusted the team with their health, and all the contributors and the medical team and the community workers. Thank you.
Thank you for a very nice, crisp presentation and giving us the results basically, whereby you have good end of treatment 95% negativity and SVR12 at around 78%. The session is open for quick questions, 2 or 3. Please stand up, take a mic, identify yourself, your name, organization, and be very brief in your question or comment.
Yeah, I'm Dr. Yashoda, working in Delhi for MSF. I have a question saying that mainly you have taken the population of drug abusers or...
Of drug users, you said?
Yeah.
No, so those are the, I'm sorry, I think I said that at the end. The drug users were excluded in this.
Okay.
Specifically
so
because we want to...
It's a primary health case, so you
Yes.
have taken whoever, screening you have taken as a mandatory.
Exactly, and it was screening according to the WHO guidelines of risk factors that you can generally identify. So according to those 2014 guidelines, you screened according to those. The drug users we didn't take, and it's a good question, on purpose is because we want to make sure that we don't lose them in between. It doesn't get lost to follow up. So we'll have a special strategy which is already starting, and it'll be in place soon for that. So yeah.
Okay.
Thank you.
Thank you.
Hi, I'm from MSF Myanmar, OCA. So I would like to know, this is HIV negative population or HIV positive, co-infection or mono-infection? Hep C.
So as far as I know, in the study, none of the patients were HIV. So yeah, we didn't screen for that, and we didn't do that because that's another very sensitive topic and thing to go into. So it was mainly based on the ones who would come in. So not in this study, yeah. So
For the treatment, you treat everybody without fibrosis, or is there any prioritization on the treatment?
Yes, exactly. That's actually a very good question. So I'll take you back, I'll draw your attention here, where I said we did the APRI score, right? So the APRI score was for prioritization's sake. So usually we use FibroScan, right? And FibroScan was not available, and you need a specialist and all this for that. It wasn't available in that setting, which is actually even more interesting because we use APRI, and that helps stage the fibrosis. And as you know, the type 3, which genotype type 3 that exists in this area is more resistant, so it's tougher to treat because it's rapid progression from fibrosis to cirrhosis. So we have all of these things as well. So we just use that APRI for prioritization. Yeah.
So you mean more than one?
Right now it was at equal to 1 and more than 1. However, it's again right now Ramzan is coming up, and after that we're going to change it to 0.5. So that way we have even more people, because it's definitely for sure we're going to miss a lot of people because of that, and we can prioritize better according to that. Yeah.
Thank you.
Thank you very much. As per WHO recommendation, the prioritization is recommended, as we know, for people with advanced liver disease, with HIV co-infection and other comorbidities. Since FibroScan facility may not be available and we want to provide a decentralized treatment for hepatitis C, I think the APRI score needs to be validated further. But yes, it can be used in case the FibroScan is not available. One comment another I have to make. Basically, when we are using now the new regimen, that is sofosbuvir, daclitaxavir, I think we can really do away with the genotypic testing, because that may become difficult in clinical care setting.
Right.
Maybe on a surveillance basis it is okay, but we have, if pan-genotypic drugs, we can take that advantage. Wherever it is not possible to do genotype,
Right.
we can really do away with that.
Thank you. Yeah.
Thank you.
Thank you.
We move on to the next speaker, Simon Jones. He's quite well known to us at NACO and WHO. He's a medical coordinator for MSF in India, having worked earlier in South Sudan, Turkmenistan and Ukraine. He has extensive clinical background in emergency medicine and rural general practice. Simon will be presenting on the 5 pillars of care, an inclusive and equitable medical approach to hepatitis C care in people who inject drugs. Simon, please.
Thank you, Dr. Rawari. The aim of this presentation is to justify why people who use drugs should be included in programmatic hepatitis C treatment decisions, and how this can be achieved in an equitable manner within the current context of limited treatment availability. MSF has been present in the Manipur state of India since 2004. Manipur shares a long border with Myanmar, which has proven to be fairly porous to the transit of opiates. This has resulted in a high number of intravenous drug users within the northeastern states of India. MSF currently operates 2 HIV ART centres under a public-private partnership with NACO. These are situated in Cherachandapur and Moray. We provide predominantly care for HIV, in addition to treatment for drug-resistant and drug-sensitive TB. More recently, we have commenced treatment of hepatitis C in the context of HIV, hepatitis C co-infection. Hepatitis C and the HIV epidemic in the northeastern states of Manipur of India has been driven by the use of intravenous drugs. This has resulted in a very complex mix of interrelated competing comorbidities within our cohort. Hepatitis C. If we look at the prevalence of hepatitis C within India, I beg your pardon, HIV has been the mainstay of treatment. Since 2012, MSF systematically started screening for hepatitis C, and we found co-infection rates with HIV and hepatitis C of approximately 30%. Within India, the estimated prevalence of hepatitis C is 1 to 1.5%. The estimated prevalence of HIV is 0.26%. However, in Manipur, a high burden state of India, the HIV prevalence is estimated at 1.22%. The morbidity which ties these two diseases together is substance use and, in particular, intravenous injecting drug use. A large study was conducted by Solomon et al. In 2015 across India. The HIV prevalence and the hepatitis C prevalence was determined in just under 2,500 people within 3 sites of Manipur. And as you can see by these prevalence figures here, the injecting drug using community has a very high burden of the HIV and hepatitis C disease burden, particularly when compared to the Indian prevalences listed above. In addition to this, these morbidities is overlaid mental health illness. Psychiatric disease is significantly higher in people who inject drugs compared with the general population. In addition, recent evidence is suggesting that hepatitis C has a direct impact on the central nervous system, resulting in cognitive and psychiatric illness. Due to shared social determinants of health and immune deficiency caused by HIV and hepatitis C, this population remains vulnerable to tuberculosis as well. Now, when it was recognised that comprehensive treatment of HIV in this context must include treatment of hepatitis C, the limited treatment availability instinctively led to the adoption of an exclusion mentality when determining who should be offered this treatment. That is, the exclusion of patients who are more likely to have poor outcomes, adverse events, or more complicated treatment courses as a result of treating competing comorbidities. This complexity was made even more complex as a result of the fact that up until the beginning of 2016, pegylated interferon, with its inherent adverse effects and complexity of treatment administration, was the mainstay of hepatitis C treatment within the Indian context. Added to this, there was a programmatic desire for good performance, resulting in the exclusion of patients with multiple comorbidities and initial prioritization of patients with advanced liver disease. This provided another exclusion barrier for people who injected drugs, as people who are actively injecting drugs by and large have less advanced fibrosis than past users as a result of the duration of hepatitis C infection. Concerns of reinfection, poor adherence and poor outcomes for hepatitis C in treatment for people who inject drugs was also another factor which was considered. However, more recent studies have proven these factors to be unfounded, with injecting drug using groups being treated with hepatitis C having comparable results to non-infected, non-drug using groups. Additionally, the rates of reinfection of injecting drug users following treatment of hepatitis C is approximately 2%. A model of hepatitis C care based on ethical and biological imperative necessitates a paradigm shift in the mentality from one of exclusion to one of inclusion, such that vulnerable groups, including people who inject drugs, can be equitably considered for inclusion in hepatitis C treatment initiatives. This requires a holistic, patient-centred approach focusing on individual priorities and not specific diseases. Ethical considerations of autonomy, beneficence, non-maleficence, justice, and respect for persons has been largely ignored in these considerations, but these are required, such that therapy is considered for all groups who could be effectively and safely treated, including the marginalised groups with high prevalence. This will provide an important opportunity for modification of of behavioural modification and uptake of harm reduction services. In addition, it's well noted that the highest burden of incident cases of hepatitis C is amongst the people who are injecting drugs. As such, there is a very strong public health argument for the inclusion of people who inject drugs into hepatitis C treatment considerations. That leads, of course, to the idea of treatment as prevention, where modelling studies has revealed that treatment of a rather modest number of people injecting drugs for hepatitis C will result in a significant decreased prevalence over the next 15 years of hepatitis C. This is a diagrammatic representation of the model of care employed by MSF in the Manipur, which we feel results in equitable access to the currently limited availability of hepatitis C treatment for all patients infected with hepatitis C within our cohort. There is basically three parts to this model. Initially, there's cohort entry, which is through voluntary HIV testing and sputum screening, in addition to referral in from harm reduction and other services. This is followed by a process of integration and individualised patient prioritisation, that is the prioritisation of treatment needs. After this has occurred, the individual patient receives a specific individualised care depending on the treatment priority which is identified. This represents the 5 pillars of our care in the Manipur project. If we look more closely at the process of assessment and prioritisation, this consists of 2 components: a comprehensive medical assessment looking at HIV status and the adequacy of the HIV treatment being given, the HIV hepatitis C staging and severity, and also an opportunity to screen for and diagnose opportunistic infections. The comprehensive psychosocial assessment looks at demographics, social support, mental health screening, substance use screening, in addition to motivational barriers and adherence factors associated required for treatment. On the completion of these 2 comprehensive assessments, the medical team and the mental health team conduct a clinical case conference on a patient-by-patient basis to identify the patient's most pressing medical priority. Once this is identified, the patient enters one of our pillars of care to have the most pressing medical priority, an intervention for that priority. Following completion of that intervention, the process is repeated such that another clinical case is reviewed, conducted. The medical and mental health team again reassess the patient and prioritise the remaining existing comorbidities and medical treatment needs. Of the first 92 case conferences conducted on our HIV hepatitis C co-infected population, 11 of these patients were deemed to have an intervention for HIV as their most pressing medical priority. This was as a result of either adherence problems or the possibility of failure to first-line treatment. Of these 92 patients, 1 patient was identified as having an opportunistic infection. Of the 92 patients, 54 patients were deemed to have hepatitis C as their most urgent medical treatment priority. That is to say that their HIV was well controlled and that there was either an absence of substance use disorder or psychiatric illness, or, if present, these were well controlled and stable. Following the individual interventions for these medical priorities, a repeat case conference was conducted. Of the 11 patients who received an intervention to stabilise their HIV treatment, 3 patients were deemed suitable for consideration for hepatitis C treatment. The patient who had opportunistic infection was treated and also deemed suitable. Of the 15 patients who required stabilisation of their substance use disorder, following intervention including OST, 9 of these patients were now deemed suitable for inclusion of treatment consideration for hepatitis C. That is, their substance use disorder was stabilised to the point where treatment could be effected safely and effectively. Of the 8 patients with significant mental health disease, 5 of these patients, after pharmacotherapeutics and counselling, had their mental health stabilised and were also considered for inclusion into hepatitis C treatment. The average duration from the initial case review to prioritisation for hepatitis C treatment for all types of interventions was 7.5 months. If we look at those patients that were initially requiring assistance with substance use disorder, the duration of the intervention and reprioritisation was slightly higher than the average at 7.8. For those with a mental health intervention, it was 5.9. And for patients with HIV adherence issues or treatment failure, the mean duration of intervention required was 8 months. In conclusion, we feel that through a multidisciplinary model to assess, prioritise and manage related comorbidities, the most vulnerable populations can be equitably included in treatment of hepatitis C. There is a requirement for program management and treatment providers to understand, accept and adapt care models to issues of social function and stigmatisation specific to people who inject drugs that currently limit access to treatment, including the parallel provision of effective harm reduction services. And finally, there are sound ethical and scientific justifications for the creation of model of care delivery specifically tailored for the needs of people who inject drugs. I'd like to acknowledge our MSF advisors, Dr. McKeel and Dr. Chris, and the MSF team in Manipur who do a terrific job. I'd also like to thank Dr. Till Kinkle, whose contribution to the initial discussions were responsible for a reorientation from an exclusive to an inclusive mentality. And I would also like to acknowledge Dr. Julian Schiefer for his valuable contributions to the ethical considerations. Thank you.
Thank you, Simon, on touching up a very important component when we talk of IDUs on the adherence, particularly in a clinic-based setting. Our experience for HIV also has shown that the adherence among PWIDs can be issue given specific clinic timings and access and certain social related issues. So it is a very important service model, but we have to really look into the scalability within given setups that government setup have got overcrowded ART centers now, which are going to get an additional burden of TB treatment also being provided through ART centers and hepatitis C. So we have to really look into some of the models which can be used involving the community, involving the care and support centers which are run by the positive people and community. The session is open for 3 questions. No question? I think it is a post-lunch. Yes, please. Can you please give the mic there?
Hi, I'm Dr. Ramesh, medical advisor for Yangon Clinic. We do have a hepatitis C program. We're just starting. So it looks like you have more experience than us. So on this regard, I just want to make a point here where you have these 5 individual care services to find out whether people are HIV and to do accordingly TB, Y, Hep C, and you have this substance use disorder. Now for this part, how are we dealing with these patients who are using drugs simultaneously also treating their hepatitis C? Because they are a challenge in themselves because of their habits. So what are we doing and what are the challenges that you face? So we could kind of get an idea. It would be a good time to share. Thank you.
I think that's an interesting question, and that's basically the basis of what the model tries to work out. Now, in the past, the use of intravenous drugs was considered an exclusion criteria, full stop. It's now being considered that patients get reviewed on a case-by-case basis. Certainly, when someone has unstable behaviour with their drug use, then you expect treatment of hepatitis C to be less successful. Certainly, the evidence shows that if people are injecting regularly and in an uncontrolled manner during the treatment of hepatitis C, their treatment outcomes, their adherence is poorer than the general population. However, patients who have stabilised drug use are involved in harm reduction services and particularly OST. There is research, and this involves programs using pegylated interferon and ribavirin, so complicated treatment programs. The research has revealed that the treatment completion, the adherence and the outcomes are comparable to the population who are being treated who do not use drugs. So the idea of the model is to equip the patient, to look at the patient on an individual basis and optimise the conditions for which hepatitis C can be hepatitis C treatment can be given. So this doesn't necessarily mean abstinence at all, although if we get to a point where substance use is controlled, then we know that they have the equal opportunity and will perform just as well in a hepatitis C treatment program compared to non-drug users. If there's a certain point where their drug use behaviour interferes with their social function, it's impulsive and it's regular, then the evidence suggests that they will not perform as well. So it then becomes a very patient-by-patient, individualised judgment call as to when you have this patient as suitable as possible to have the expectation of successfully treating their hepatitis C. And that goes back to the principle of justice, where we want to ensure that we can effectively treat patients and with a positive risk-benefit ratio.
Just to add, since national program does not have an idea about hepatitis C, doesn't have a program, and we cannot give you, but if we go towards the HIV findings, yes, there are issues with the drug users who are not stabilized, who are not into OST program. There are issues with the adherence. And particularly, there are targeted intervention in those high pockets where IDUs are more. There are community-led targeted interventions whereby we follow them up. Loss to follow-up is reduced through outreach, but still there are some issues definitely in terms of adherence.
Hello, I'm Dennis. I'm from Delhi School of Economics, and luckily I come from Manipur in Churachandpur district, and I've also gone to More where the MSF are working. And I just want to ask on how really effective is the model, especially in Churachandpur and More, because when we are seeing on the IUDs, are the patients first of all detox in order to give that kind of treatment? And with the stigmatization that is happening, does it really, how does it work out? Because the stigmatization is so much out there, and the support, because it sees that it's on an individualistic approach, and how does you coordinate with the families of the IUDs?
I think you've touched on a number of issues there, which I'll address too. Firstly, the issue of detox is not something that we consider to be important. Detox, basically, particularly in this setting, where most of the settings in Manipur are non-medical detox, and that basically means keeping a patient and letting them go cold turkey without medical intervention. This is not a requirement. The requirement is stabilisation. So there is no requirement for detox as such. We aim at stabilisation of a patient to get their social function as good as it can be, such that they have a good chance of a positive outcome following hepatitis C treatment. Number one. Number two, stigma. Obviously, stigma is a big issue across the board for people who inject drugs. Now, within this model of care, it's an integrated model, and part of that accounts for the stigma, because with traditional models where hepatitis C is treated in hospital settings, specialist settings, there is a larger degree of stigma even from the medical staff. There's no links to harm reduction services, and there's no real appreciation of the factors, of the social factors, of the lifestyle of people who inject drugs. Now, within this integrated model of care, these factors are considered, and hopefully by the fact that it is a conducive patient-centred approach, that will have some impact on decreasing the stigma. The other thing to also be aware of is that this is all taking place in our HIV treatment cohort. And the stigma for HIV, a lot of ground has been made in that regard now. So within that environment, I think there's a number of buffers which help decrease that stigma and make it a service where people who inject drugs are happy to come, knowing that they will get fair, equitable treatment and be treated appropriately.
Thank you, Simon. I think we'll take up your question when we have all the speakers on the dais, because we are exceeding the time. So we have a very important next talk on access to new HCV treatment tools, barrier responses and lessons learned from MSF experience in South Asia. And we have the leader in this IPR related issues, not only for HCV, but also for HIV. Lena, I think you all know, I don't have to introduce her. She is a friend of NACO, Government of India, advocate, activist, and a friend together. Lena.
Thank you so much. And I'll just look for my... I'm so sorry. 14? Okay, thank you so much. So it's a great privilege to be here. It's 15 years from the day I started work as a young lawyer. And since then, I've come a long way in public health and access to medicines. And I've had the privilege to work with one of the finest access units in the world, which is called the Campaign for Access to Essential Medicines. It's a specialized unit of Médecins, Frontières. And we have been working on hepatitis C for the last 11 years, from the day I started work in the access campaign. I would like to acknowledge the contribution of our HIV and HCV pharmacists to this presentation and the work around access to medicines. And I'll just introduce my presentation. It has an introduction, barriers facing access, strategies and responses, and conclusion based on the medicines that we require to treat hepatitis C, which are direct-acting antivirals. So I call them DAAs. So if you just have that question, what is DAA? It's direct-acting antiviral. So what's the background? From 2005 to 2013, there was considerable debate on treatment for HCV in co-infected patients. That means people living with HIV who also had HCV. There was also considerable data to show that if we did screen the cohorts that we had, there would be much more numbers of hepatitis C. But we were stunted by the lack of availability of very effective drugs, and predominantly by a very old chemotherapy drug, which is called pegylated interferon. It causes huge side effects. It makes people very sick when they're on that treatment. Some people told me that it was worse than being on any other treatment that they've ever been. They felt more sick than the disease had ever made them. And most importantly, it did not have a very high efficacy rate. And lastly, it was expensive, and it was a biological medicine. And MSF, in its history of treating patients, has not dealt very well with biologicals, except for vaccines. So the whole issue of biologicals faced us. We were not able to procure the medicine in time, and we decided to wait for the direct-acting antivirals. So from 2013 and 2015, you see a huge excitement, speed up of testing in MSF to start screening our cohorts in Myanmar, in Pakistan, in India, and get ready to treat the most vulnerable populations. In the case of Myanmar and Manipur, it started with just wanting to treat co-infected patients, but as you can see, there was a change in prioritization to the most vulnerable community, which are drug users. In 2015, we started treatment in Pakistan, India, and in 2016, we are on the cusp of treatment in Myanmar. We have the drugs starting to come in, which are direct-acting antivirals. Multiple barriers still exist to treating hepatitis C in the region. For example, if you look at Ukraine, or if you look at Iran, or you look at Thailand, Malaysia, the issue of access to direct-acting antivirals is definitely a burning issue. So wherever you are going to be operational and wherever you're going to treat, for example, vulnerable communities, whether they are HIV positive or just simply drug users, you're going to need to be prepared to deal with hepatitis C and the need for direct-acting antivirals. MSF strategy was very pure and simple. We were focused on getting 2 good direct-acting antivirals and putting them together into a combination that we could give across genotypes and make it available to anybody who needed it. So it did not matter whether you were a drug user, you were HIV positive, and so forth. So the idea was simplify treatment so much that some of these discussions about exclusion become moot, because the treatment is simple. It's like antiretrovirals. You combine the medicines, you make it simple, and you make sure that people have it in a simplified 1 day a pill or 2 pills a day, and you ensure that the treatment is short and effective. We knew that this was a cure, so that means that we did not have to sustain people on a lifelong treatment. It was, the debate is about 8 weeks, 12 weeks, and so on. So it was a short cure, And if we had 2 drugs, we could treat more people as they came along in our projects. We worked very hard with the WHO technical groups on the WHO new treatment guidelines, and Dr. Isabel from MSF was part of those drafting committee. And we made official submissions to the inclusion of sofosbuvir into the WHO essential medicine list. So we knew that sofosbuvir and daclatasvir, as I call them, SOFU and DACLA, we had to get them into the WHO essential medicine list and make them affordable to be able to treat our patients in the region and across the world. Few people may not even recognize. This is Dr. Andrew Hill. He's a pharmacologist. He did a study to show that actually the cost of direct acting antivirals was as cheap as what today antiretrovirals are. So sofosbuvir, the drug that we all talked about in different projects, is actually just $68 to $136 for 3 months to make. And then daclatasvir is practically free. You can give it free with sofosbuvir. It's $10 to $30 per treatment. So if you combine these 2 drugs, the cost of treatment wouldn't go above $150 to $200. He did that looking at the structure of the molecule, and he put that number out. And I'm going to talk about why that number was so important to sort of revolutionize MSF's thinking around it, because suddenly we realized that this treatment could be as cheap as antiretrovirals, which is $100 per patient per year. And we needed to get it down to that price so that we could treat more people, and we could see that the effect would be that governments would be excited enough to start viral hepatitis programs and treat hepatitis C. So what did we do? The first thing that you do when you want a new medicine is to find out if there's going to be a monopoly on it or not. And we went and found the patents. And as I said, today everyone talks about sofosbuvir and daclatasvir. At that time, they were just numbers. They were 7797 and so forth. And there was a chemical structure. And we had to go and find these patent applications. All I can tell you is this: I had to learn chemistry very fast and figure out which applications related to what. And I had a lot of help from a Pakistani colleague of mine called Azizur Rahman. He's by far one of the finest patent attorneys I know, who helped me find these molecule structures. Patent oppositions were filed in Brazil, China, Russia, Ukraine, Argentina, and Egypt, on its own initiative, rejected the patent applications filed by Gilead Sciences to support its own domestic production. Egypt has the highest burden of hepatitis C in the world, and after that is Pakistan. It was challenged in Europe and so forth, and of course, people followed with a challenge to daclatasvir. The recommendation from WHO was something that was very much needed. It came in 2014. Treat all adults and children with chronic hepatitis C infection, including people who inject drugs, should be assessed for antiviral treatment. And when someone just asked, what about, will they be stable? Will they adhere? I think this recommendation is based on the fact that you can actually treat drug users. The treatment can be simple enough to address the needs of people who use drugs. Of course, you do need to give all the other allied support services that are required. So the drug sofosbuvir. People in this region of the world are obsessed with the price of gold. Gram for gram, it costs 67 the price of gold in the United States. That's the price of this drug, $1,000 a pill. And we had to make sure that this drug was in generic production and available to patients across the region and across the board. So some of the issues that I'm going to talk about is about compassionate use for dying patients, price and availability from originator companies like BMS and Gilead, patent claims in generic production, voluntary licenses and anti-diversion, and delay and lack of registration. A regulatory barrier can be as big as a patent barrier sometimes. Similarly, daclatasvir, more expensive than diamonds. My family always asks me, you could be as rich as anybody. You should put a few bottles and carry them across the border. And it's really funny because that's exactly what everyone is thinking right now. Can we come to South Asia and get treated for hepatitis C? Because this has become the hub for hepatitis C treatment. Again, similar issues. BMS would not supply daclatasvir to MSF. For years, we've spent negotiating. We didn't have compassionate use access. We had problems with registration. BMS does not believe in registering its medicines. It just believes in filing patents, clearly. And of course, offering us donations when we couldn't get the drug into the country because it was unregistered. So the donation was completely unsustainable for us. So what did we, I would say one of the first things we learned from hepatitis C is that compassionate use is important for patients in developing countries. If you have advanced liver disease, or you have, if you look at HIV or you look at MDR-TB, you can't wait for the drug to be registered and all the studies to be completed. You'll be dead by that time. So some clinicians need to go and ask for the drug for those patients who urgently need them. And this was something that is now being used extensively in MDR-TB, where delamanid and bedaquiline is not registered in those countries, and we need to treat MDR-TB patients, and now, of course, for hepatitis C, when the drugs were unregistered. Treating critical patients is a starting point for all of us, and it was really important. We started negotiations with Gilead and BMS, asking for access to compassionate use. And I must say, the Manipur project played a huge role in asking and pushing for compassionate use for its patients. They agreed to give us named patient access. So patient by patient, we did very painful paperwork to get the drug into the country and treat patients. However, they still charged us. So there was no compassionate use. There was complete lack of compassion, as I would say, on the part of the companies. They just excluded Asia from compassionate use, particularly South and Southeast Asia. MSF strategy: push companies to give us compassionate use access, get companies to file for registration in key countries, whether it's Pakistan, India, Myanmar, whether it's originator or generic companies, find a source that will register the medicine so that the drug is available in the country, and request waiver of local clinical trial from DRAs. Now, often we hear a lot of debate around clinical trials, but sometimes clinical trials, the last phase of it, the local trial can take so much time that you may have to waive it off in certain conditions. Not always, but in certain conditions. So a lot of civil society got together for asking for waiver on sofosbuvir and daclatasvir, and the Indian FDA did provide the waiver, which is revolutionizing treatment and making available more generics from India for other countries. Quality validation of DAAs. It's a very important issue for a humanitarian organization to be responsible for the quality of medicines that we provide. We have, besides encouraging the WHO PQ to speeden up the pre-qualification of direct-acting antivirals, we ourselves have taken up the whole issue of going to the companies and asking them to apply for WHO pre-qualification and validation. They see it as a market entry. We see this as an important marker of quality validation in developing countries. There are many license agreements. License agreement is about an agreement between two parties. In this case, a multinational company and a generic company. Majority of these agreements include countries like India, Pakistan, and Myanmar, and then exclude countries like Ukraine, Thailand. So it's a dilemma for MSF to accept these licenses, because some of our patients are on this side of the border, and some of our patients are on the other side. So there's no treatment without borders, unfortunately, for us due to these license agreements. They also, if you look at it, this is the region that is locked out of access, and you will see Central Asia completely locked out of access. And I think this is a big problem with the license agreement. Lastly, they said, every bottle, you must provide a name and you must give the bottle back. And that was a very big problem for us. So it was patient by patient, we would get treatment from Gilead. Gilead was worried that the medicine would find its way back into the United States and other countries. We refused. We do not believe that a company is entitled to patient data. And we helped projects negotiate out of many of those conditions. We still return the empty bottles, and we would like to stop doing that in many places. But as soon as we have validated generics, we'll be out of this whole issue of having to return empty bottles to Gilead. So we allied with civil society. We spoke up against these unethical practices of pharma companies like Gilead, and we also talked about the middle-income countries who were excluded from there. Outcomes. Generic sofosbuvir has been developed and registered in India, Bangladesh, Pakistan, and Egypt. Generic companies are marketing the combination of sofosbuvir and daclatasvir. There is an internal quality assessment within MSF, besides the DRAs registering it, 2 more slides. And we have now validated sources from Hetero and, of course, Farco Pharmaceuticals, Egypt, which gives me a great pleasure to see that, generic production is not only restricted to India any longer, but is taking root in a number of other developing countries. More sources are emerging. Perhaps Pakistani companies soon will come out with a validated source. Treatment with sofosbuvir and daclatasvir will start. The medicines are coming into our projects as we speak. No more pegylated interferon. We will be free of pegylated interferon in 2016. Thank you. Okay, so the lessons learned from MSF experience. The partnership between medical projects and the access campaign is really important to deliver access. And I think it's also true for NACO and DNP, for example. I think treatment providers and people who fight for access need to be together and talk to each other and be able to work together to deliver access. You have to tackle IP problems. You have to tackle regulatory barriers. Big pharma's donations, voluntary licenses are always problematic. People need to be more discerning about them, need to take a magnifying glass and read all the clauses that exist when they offer you a donation or any other kind of agreement. Medical needs need to be met by legal safeguards and pushing for policy change. So in the end, yes, medical projects are important, but the whole purpose of the projects is to push for policy change so that drug users, people living with HIV who are co-infected and other people who need it are able to get the treatment they need. Access to Hep C medicines reflects the continued challenges of access to affordable medicines. Developed countries have reached the pain threshold. As I said, $84,000 for just one drug in the United States. It's very clear. I would like to say that I have helped the Buyers Club in India, and they take medicines across the world for people in Austria, Italy, Spain, Canada, United States, and you can see that it's no longer an issue that only affects developing countries. It's affecting Eastern Europe, for example, and there's a need to build allies and talk to them about access to treatment as well. The future, Bangladesh. They were the first producer of what I call Hopitavir. That was a generic of Sofosbuvir, and this is going to be the future of generic production. It's going to go beyond India to South Asia and other countries. And of course, all the years that people have spent fighting and marching and asking for the rights for direct-acting antivirals. So this was the presentation. Thank you.
Thank you, Lina, for a wonderful presentation and the wonderful work you have been doing along with Delhi Network of Positive People and Lawyers Collective, increasing access to all these drugs. That has been a great work, but you have a challenge. Sofosbuvir has been granted the patent now in India, and your work needs to go further. Though it is not applicable for India, but if we don't have sufficient exports, the cost will not go down further. And recently I had some interaction with people from Aga Khan University in Pakistan, and the cost of drugs in Pakistan is cheaper than in India. We need to address that issue also. And they import from India. I request all the three presenters to please come to the dais, and we can have some quick, crisp questions from the audience. We have only 5 minutes for that to keep the session in time. Speak into the mic, identify your question.
Disease areas that we have to care for, a major chunk seems to fall in that hepatitis C is to be taken care of on a priority, and then when you reprioritize, then again a large chunk curing hepatitis C. So is it because of it is a pressing need for those patients?
Firstly, I think it's quite clear hepatitis C and HIV
before surgery. But like in Pakistan, she was mentioning in primary health care. But I'm excluding for hepatitis C to reduce, decreasing the high prevalence for HCV.
As far as screening before any surgery or before anything, I don't think that is the policy. Jaundice, elevated enzyme, history of blood transfusion, thalassemics, those, but it is only a recommended testing as such.
To decrease, if any of the panelists, if they have answer to this, actually, whether
If
to
you have a risk
bring
behavior,
it
yes,
to
you can be, but
only-
it is not a universal screening policy.
Okay. Thank you.
I think we are now near the closing of this session. I thank all the speakers for wonderful presentations and the audience for being alert in the post-lunch session. I didn't see any person dozing off. I think that was the speakers, this thing that they kept the audience alive, interest alive. And I thank the organizers for giving me this opportunity to be here and chair this session. Thank you very much.
Thank you, Dr. Devara.
Hand over to you.
Lena, can you, I'm the chair, so I'm just being a dictator. Could you just comment on the recent patent that was given, the implications of that? Last week, was it? The patent was granted for, yeah.
So the implications of a patent being granted in India, and in the context of a prior existing agreement between Gilead and Indian companies, is less so on Indian patients. So the impact is not on Indian patients themselves. It's on the people who've been excluded from the agreement between generic companies and Gilead. So if you are based in Ukraine, you are in Russia, you are in Thailand, you are in Malaysia, these are all the countries with a high burden who have been excluded from receiving generics. So the patent actually closes that door of finally for them, because in some ways, even if you even in these countries, as they gear up to start thinking about treating Hep C, they're going to need multiple sources of generics, and not, for example, they need the Egyptian source, they need the Indian source to drive down prices. Unfortunately, the Gilead license is very prescriptive about where you can sell and where you cannot. And there are a large number of high burden countries which have been excluded. So the patent grant doesn't do any damage to Indian patients, but does do a lot of damage for access across borders. That's all I can say. And in that context, I would like to say this: the last thing I think is we need to challenge the patent, and we need to keep keep the battle on, because if you look at Egyptian and Bangladeshi producers, they buy the raw material from Indian companies. So even that can get blocked if the patent continues. So these are very real issues about drug production. So we really need to have a much more comprehensive discussion about where the raw material is going to come from if India's got a patent and they won't sell to the Egyptians because of the patent.
No, but it indirectly affects India. It affects India in the terms, if you see into HIV generic drugs, 89% of the global demand comes from Indian generic, and that gives them the volumes. If you don't have that volumes for Hep C drugs, costs are not going to come down. We are now at $335, and we were expecting this will come down to $200. It will not come down if we have a patent. So it has a bearing on Indian thing also. It is not only for export. It affects Indian, and that is what I feel. I am not an expert.
No,
but
I agree.
That is
I agree. I agree on that. Yeah.
All right. Thank you very much. As Lena pointed out, just an interesting statistic, 62% of people who file for bankruptcy in the United States file because of healthcare costs. So it's no longer just a developing country problem. And 72% of those people had health insurance, right? So it is a huge issue, not just in India and in countries like India, but also in the rich countries where people are no longer able to afford life-saving medications. So I think it's important that in India, when we take a stand, we don't take a stand just for Indians. I think we have a responsibility that goes way beyond our borders. Thank you, Lena, and thank you for the panel for the interesting set of presentations. So now we have a wildcard presentation. It didn't sort of fit into any of the other sessions, but nevertheless a very interesting presentation on opportunities and challenges of rapid manufacturing in humanitarian health. If you go to any, in the countries where I've worked, in Africa and other places, it's littered with hospitals with high-tech equipments that have been donated and no longer work. White elephants, there are these scan machines, there are incubators, there are all sorts of high-tech equipment that don't work anymore. So this is an interesting, with the advances in technology, exploring new ways of sourcing materials closer to where the projects are. So there's an interesting example from interesting presentation from work that's been done in Nepal, which has huge implications for the work of humanitarian agencies around the world. So I'd like to quickly introduce our speaker. Excuse me, I'm fiddling with... Okay, quickly introduce our speaker, Abby Bush. Abby works as a technical advisor for Field Ready, a startup seeking to revolutionize the delivery of aid through local manufacturing. She is currently heading Field Ready's operations in Nepal and is working through numerous partnerships with NGOs, maker spaces, and industrial scale manufacturers to investigate how local manufacturing can best benefit the earthquake response. Her background is in manufacturing engineering, which she studied at Cambridge University, and has previously worked in operations, manufacturing, and design. Abby, welcome.
Hey, hi all. First of all, can I start by saying it's an absolute pleasure to be invited to speak today, especially as our wildcard presentation. I'm very excited. I hope you are all too. So, as a room of professionals, I'm sure you're all very good and like to keep ahead of current affairs. And I'm sure you've all seen these very exciting stories coming up in the news of how 3D printing is going to revolutionize medical care. So, for example, stories of 3D printers producing new structures of drug, 3D printers being able to provide bespoke, personalized implants for people, 3D printers being able to print organs. This is all very exciting, but it's a little way off in the future. And what I want to speak to you about today is to give you a snapshot of what is currently happening in the medical sector in a humanitarian context with 3D printing. So, because of the nature of this talk, a little bit of a wild card, I thought it would be helpful to provide you with a bit of background as to who I am, what I'm talking about, and why on earth I'm talking about it. So I currently work for an organization called Field Ready. I'm based in Nepal. Field Ready has a very optimistic view of how 3D printing and other digital manufacturing technologies can revolutionize the humanitarian sector in the future. I thought I'd explain what we mean by this with a bit of an example from a project I'm working on with UNICEF in Nepal. So on the left of the screen, you can see a picture of the UNICEF shoreboard. This is a device that's used to measure the height of children and identify cases of malnourishment. A very important device. And I just thought I'd share with you the journey it takes to get to Nepal when and where it's needed. So it actually starts off in the USA, where it's manufactured. It's then shipped to Copenhagen, where UNICEF devices are stored in a big warehouse. There you can buy one for the nice sum of $82. It takes about a week to process the order. It then gets put on a ship, which can take up to 3 months to get to Nepal. In the aftermath of the earthquake, of course, it was a little bit complicated getting from a ship into Nepal because of various restrictions, such as the blockade. There was a bottleneck at the airport due to the amount of aid that was trying to get into the country. There were rapidly changing customs restrictions, changing basically every few weeks from the government. And by that time, it's cost you another extra 15% and taken you several weeks to get there. After that, it's got to go through several layers of local warehousing to get to where it's needed in the health post. And again, by the time it's got there, you've potentially increased the cost by a further 15%, and in some cases, because of the difficulty of transport in Nepal, 120%, and added another several weeks to the process. And on top of that, you lose 10% to damage. So by the end of that, you've got 2 planks of wood and a measuring tape, which have cost you upwards of $100 and 10 to 32 weeks to get there. So, we already think we can do a little bit better than that, and we're excited about new technologies such as 3D printing and helping us get there. The future we envision looks like this, where the factory is essentially right next to the point of need, so things can get there when and where they're needed, exactly when you need them. So today I'd like to give you a snapshot of just 3D printing, particularly 3D printing, being used for humanitarian Nepal in the medical sector in particular. Because of the early stage nature of this field, the way the research is presented is basically 3 case studies. 2 are from field-ready projects. Essentially, the projects have happened through me doing workshops with medical professionals, exploring what they would do given access to this technology. And then actually manufacturing, installing and monitoring the parts. And the 3rd case study is observation of spontaneous activity which has happened between a professional in the medical sector in Nepal and a local makerspace in Kathmandu. So on to our first case study. So this is a picture from a hospital in the Nuwakot district of Nepal. It was a hospital that was unfortunately destroyed during the earthquake. It was knocked down, and currently most of its operations are being run out of a series of tents. I'm not sure whether you recognize the unit in the picture, but what it is it's a box in which you take an electricity cable from outside, an industrial electricity cable, plug it in, and then you can get electricity to all your electronic medical devices that you need to run in order to provide good care. So this is the original connector. I'm not sure if you can see at the back from that unit. You might be able to see that it's perished and the connection has failed. What this meant for the hospital was that they didn't have power in this tent. This unit was donated by an aid agency. There are none available on the local market, and there certainly aren't any spare parts available on the local market. And so the options for actually replacing the unit are very, very limited. It's quite expensive, and basically the hospital couldn't afford to import a new one from abroad. So what we did to resolve this problem, I went there with my 3D printer, sat down, measured up the part, modeled it on a computer, and then printed out a fresh one, which is the one you can see in the picture there. And the result of this is that instead of having no electricity and unable to get the spare part, the hospital was easily able to obtain something that got it working. This part cost $12 off my 3D printer, so not bad. To give you another example of this, here is a picture of a baby incubator from another hospital. This hospital has 5 baby incubators. 3 of them have been in a back room for over a year. Again, it's another piece of donated equipment. This one is not even manufactured anymore. It's so old. And what happened was the little clips holding the sides on broke, they failed, and the doctors were unable to safely use the equipment anymore. So again, what we did, we went in, measured up the part, and produced a new one. This was invaluable. There would have been no other way of getting these incubators back up and running. So on to case study number 2. So this is a different example where I've been working with an orthopedic surgeon who works in a hospital in Kathmandu, but he's also involved in lots of humanitarian projects around the country. And I wanted to explore what he would do given access to this technology. So it was interesting getting his views on the matter because the places he wanted to go with 3D printing was much more to do with equity in care. So making sure that the same treatment is available for people with very little resource in very remote areas of Nepal as is possible in Kathmandu. And one of the problems he shared with me was in repairing people's broken wrists. And what you'd usually do is you'd take an orthotics device to support the wrist for several weeks while it heals. He can only get one type of this device in Nepal, a metal bar basically wrapped in Velcro. And he finds that, if you compared all the sizes of your wrists in this room, I'm sure you'd find quite a lot of variation. And if we tried to attach the same wrist strap to all of you, probably some of you would find it very comfortable, some of you would suffer quite a lot with it. So the project I've been working on with him is to take a mobile phone, scan somebody's hand by taking lots and lots of photographs, and produce a device that fits exactly. So this one is my own, so if I ever break my wrist, I'm safe, I'm good. So there's a further example of what we've been doing. I'd like to change the tone of the conversation now. So I've talked a little bit about the very positive things that can come out of having this kind of technology in the field. And in both these scenarios, the risks associated with the projects was very low. Had we not completed them, had either of the parts failed, there wouldn't have been any harm done. However, in this latest project, the risks are a little higher. So this third one is blank for a reason, and the reason is that this project is still ongoing and the outcome for the patient has not been seen yet. So I'm keeping it deliberately a little bit vague. But the story behind this is an excellent surgeon working in oncology was treating a cancer patient and they had to have their ankle bone removed. He wanted to be able to replace this bone suitably. And what he did was he went along to a local makerspace with a 3D printer with a scan of the ankle bone and asked them to 3D print a plastic version of that bone. You can then, it's a common process, you can take this plastic model and use it as the basis for metal casting. So he cast it in medical grade steel and then has subsequently implanted this in the patient. Now, while I'm very excited about this project and the possibilities it opens up for treating people with an excellent standard of care in the field, I'm also watching the outcome of this project quite nervously. There are quite a lot of places that this treatment could have gone very wrong. For example, the material that they used in the 3D printer is absolutely not suitable to go anywhere near somebody's body. If the process resulted in any plastic being left on that final part, which with this material is quite likely, that patient will now have very unsuitable plastic implanted inside his body, for example. There are other concerns with the process which I won't go into now. So the conclusions from this for me is I think this is a very exciting space to watch. And I'm very, very excited about the possibilities this opens up for providing an excellent standard of care, even in the most remote and resource-starved locations. I'm particularly excited about the ability to provide spare parts and keep donated or expensive or complex medical equipment running. However, I'm a little concerned about the risks, and I think my, call to action for today from you all is to think about perhaps creating a code of practice for medical professionals in the field. I think the value of this would be seen in that if medical professionals were, comfortable and happy with talking about and understanding the applications and limitations of this technology, first of all, it would be great to see many more people identifying great opportunities to improve operations and improve the ability to access spare parts or basic medical equipment out in very remote locations. On the other side of this, I think it's very important that with the rise of makerspaces, the increase in access to this technology and the obvious desire amongst professionals to yield the benefits of this, I think it's very important that we're able to advise on this and make sure that things are done in a safe and low-risk manner. So thank you very much for listening to me today. I hope you enjoyed it and open to questions.
Few quick questions, maybe one or two, before we break we have a poster break where Abby also will demonstrate her 3D printer, and you can ask her more questions. But if there are one or two clarification questions or more pressing questions, we can take it now.
Hi.
Here? Yes.
Hi, my name is Yogesh. I'm a epidemiologist in Manipur project. Thanks for a presentation. I'm more fascinating on technology. But from history says, during 1970s to 80s, World Bank provided for African countries more or all the equipments. Even UNICEF has noted same thing, but there was no technicians to handle more. I mean, India, in some of the places where I work, it happens same thing. In 3D printing, we need more technicians persons. It's not a simple job to print 3D print everything. So in lower resource, because the technicians are so low, so what's your opinion on that? Because you have to train more people, and how you can utilize that. Of course, it's utilizable, but you need more, because if you're providing some equipment for the ground, you also need some technicians. Or if something goes wrong, you have to repair it. So for that, you need high specialized technicians to repair if the equipments go wrong or something. So what's your opinion on this?
Thanks for your question. It's a really good one. Is this working? Okay, good. So because of the early stage nature of this project, we're exploring a number of avenues to see what works best in terms of providing the technical capability for running these machines. I think what might surprise you is that for a lot of people, the skills are actually almost there. So anyone who with an engineering background, or even things like jewelry making or robotics, the biggest skill that's needed for a 3D printer is CAD modeling. And a lot of people have that already. So one of the ways we're working now in Nepal is working with people who've been trained in engineering and then jumping the last tiny step, which usually takes about half an hour to train somebody how to actually operate a printer. And then they've been doing a lot of the work with us and for us. Other ways we're looking at it is potentially deploying them within aid agencies. And again, usually there are a few people already there with a lot of the capabilities to learn these tools quite quickly. A further step, we are exploring installing them directly in hospitals. That is something we're looking at right now and working with technicians who are already there. And seeing if that is also a viable route. So there's a few ways of doing it, and I'd love to be able to say this is definitely the way it's going to happen, but next time you invite me to speak, I'll probably have a bit more data on that.
Yeah. Just to add to all of the equipment you talked about, World Bank funded, part of the problem is, again, going back to what Lena said earlier, donations. A lot of these were provided as donations with no real consideration whether they were fit for the context or fit for purpose. So they wanted to show that they were, charitable donations. They gave these equipments, but with no real, consideration beyond that, either to train people or to provide, at least for 2, 3, 4 years, spare parts. None of that was a consideration. So again, this whole notion of donation being a good thing, you have to really take it with a pinch of salt, or like Lena suggested, use a magnifying glass to look at the contract which comes with much of these very ill-guided donation programs. Okay, another question? Yes.
Hi, I'm Padma from MSF. Just a quick question. Very curious to know what is the actually price of the 3D printing press in itself, or the machine in itself, and how sustainable do you think this is in terms of it getting embedded into the humanitarian sector?
Okay, good question, big question, small question and a big question. So the first one's pretty easy. The printer I've got out there cost about $800, and what this basically means for the parts you're printing is it's just under $3 an hour when you're printing something. So for example, this item here would take about 4 hours, so it would be about $12 off a 3D printer. A project we did in Haiti, which was to make umbilical cord clamps. They're very small, they take about 20 minutes, so they're about $1.50. So basically the cost scales with the material. That's the biggest factor in the cost of 3D printing. However, that's probably set to come down with, there's a lot of work being done on recycling plastic material, such as it can be put into 3D printers. And that would be very cheap, which is quite exciting. And the second question was on sustainability within the sector. Gosh, there's quite a lot of different ways to answer that. So I guess key problems with it would first of all be training, which we've discussed, so making sure that people are able and comfortable with running it. I think that one's probably not too bad to overcome. If you come and chat to me about how it's run, how the 3D printers run, you'll probably realize it's much more simple than most of the medical equipment you're already using. Second would be energy. So there's been a lot of concerns about, how much energy does a 3D printer consume? Is it really feasible to take one out to the field when you might not even have any power to charge your mobile phone? So there's good news and there's bad news. So the amount of energy it consumes, I'd say it's probably similar to a TV. So if you imagine running a TV in the field. The way we've been working so far is we've been powering it off a car battery. So the vehicle we've driven into the field, we've simply plugged it into the car battery and let it run off that. The project we have going in Nepal at the moment is looking at running it 24 hours off a solar panel. What it would take to do this is probably 2 large lead-acid batteries and 1 big solar panel. That would be the energy to run it. Any other questions on the sustainability aspect? No? Okay.
Just like all technology, the more you use it, and the more cheaper it gets. I mean, 25 years ago when I started using a computer, just to print a sheet of paper was it was an expensive proposition, right? So it has changed. And also the leaps in technology that happens in Africa now. You don't find land phones anymore. Everybody uses a mobile phone. So I think 3D printing has a huge. I think the possibilities are enormous, and this could be the way a lot of materials are made locally, produced locally, etc. Who knows? Yeah. I think the possibilities are endless.
I was just going to say I really agree with that point. I think Nepal's a great case study in point. So in terms of industrial development, and how manufacturing is involved in lots and lots of different countries, is you've kind of gone along the same linear process as, I guess, I'm from the UK, so I'll use the UK as an example, the same industrialization process where you've gone from little workshops through mass manufacture, and that's how you get things to be cheap and available to everyone. In Nepal, that's actually not a very good idea because it's sat between China and India, and even if you brought mass manufacture to Nepal, you'd be better off importing stuff from its neighbouring countries. It's not really an option. So I'm quite excited about the possibilities that this has for essentially leapfrogging and being a really great technology to get really good quality and amazing standard products from local scale businesses.
And also democratization. I mean, you can download designs from the internet and you can print it. I think it'll change the way things are sourced and what is used in the field as well. All right, one more question and then we have our poster break, right? One more question, last question.
So it just occurs to me because we're talking about availability of people who know CAD, computer automated design, and how we have so many mobile phones. And did you ever explore the possibility of somebody using a mobile phone to take a picture of the broken part and sending it across to maybe somewhere in Kathmandu, making the part and sending it across?
That's such a good idea. Yeah, no, we are exploring possibilities like that. I think it could really, that is actually the biggest problem that we're facing, is that we've got so many people who are able to 3D print and able to identify the problems, but it is the CAD designers who are that little step. So we're actually developing a platform called Humanitarian Makers where people can submit essentially design challenges, design problems to engineers anywhere around the world, and then the person back where it's needed can click a button and just print it out. So we had our first great example with a nebulizer in a hospital where a little plastic connector had broken. The engineer in the hospital designed the part he wanted. We sent the design off to somebody in Italy, and then he did the CAD model, and we did a few iterations with him and then printed it out back in Nepal and got it installed, which is really cool. So yes, that is the future.
Great. Thank you, Abby. Abby will be outside. The 3D printer is outside. And I do encourage all of you to go have a look at the posters. We have two posters on MDR-TB. In fact, we have Animesh, who spoke earlier, who came all the way from Russia. And then we also have another poster on HIV/AIDS, one on mental health, and also one on HR, human resources in humanitarian settings. So 30 minutes, and then we are back for the final session, which will be another exciting session chaired by Vikram Patel. We'll see you back in half an hour. While you're looking at the posters, please have a cup of tea and coffee. And I ask those who are in session in the last panel, the presenters and the chair, to come here for a briefing. Vikram, if you're in the audience, can you just join? Is Vikram around? Yeah. So, briefing for the last session, please. I did see Vikram.
In conflict zones, hospitals are being attacked and destroyed at an alarming rate.
Last year in Syria alone,
All right, take your seats. Shall we get started? Victoria? Yeah? All right. Welcome to the third and final session, Febrile Illnesses, NCDs, the Unusual Suspects. I hope you enjoyed I hope you were able to discuss the posters, at least have a look at them, speak to some of the presenters. As you can see, there's a breadth of research and programming that is being done not just in MSF in India but also in other countries in the region. And the next session is another example of that, where we have presentations from Nepal, India, Iran, and South Sudan. Just to give you a little bit of information, we now have people in approximately 30 countries who are watching the presentations here through the MSF website, through YouTube, through links that are embedded in partner sites such as BMJ, etc. So it's incredible that it's only the second year of the scientific day, and hopefully as years go by, I think the viewership will increase. And we want, of course, more and more people, medical students, the scientific establishment, medical professionals, and also other generally interested public health professionals to attend these meetings every year. All right, so let's go on to the next session, and it gives me great pleasure to introduce Vikram Patel. Vikram is a psychiatrist and researcher known for his work on mental health problems in low-resource settings. He is currently Professor of International Mental Health and Wellcome Trust Principal Research Fellow at London School of Hygiene and Tropical Medicine, where he is the co-founder and former director of the Centre for Global Mental Health. Other affiliations include the Public Health Foundation of India, where he is the co-director of the Centre for the Control of Chronic Conditions, and Sangat, where he co-founded an Indian NGO dedicated to research in the areas of child development, adolescent health, and mental health. And we in MSF know Vikram very well. He's collaborated on many projects and consulted on many mental health research projects, as far as I know, maybe others as well, Vikram, over the years. So Vikram, it's great to have you here. Welcome. And Vikram will introduce the rest of the panel.
Yeah. Thank you. Well, good afternoon, everyone. First of all, congratulations to all of you. This is the most committed and obviously dedicated group of public health researchers and action and activists to have lasted out to this very last session, or perhaps it's the drinks that follow that's keeping you going, I'm not sure. But anyway, the delay means that there'll be a shorter gap between the end of this session and the start of drinks, I've been reliably told. We have 4 speakers. We're running 45 minutes late, so I'm going to really cut straight to the presentations. Suffice to say, if you look at the program, this is a very eclectic session, probably the most eclectic session that we've had today. All the 4 talks actually capture very different areas of health. But I think it is interesting that the session has been titled The Unusual Suspects, and perhaps the reasoning for this particular title will become evident as we make our way through these different presentations. So I'd like to invite the first speaker. Also, I'd like to welcome the online audience, by the way. It's delightful to know that there are approximately 30 different countries that are currently connected to this particular session here in New Delhi. So our first speaker is Kanika Koirala, who is a medical doctor by profession. She's based as a research coordinator at the BP Koirala Institute of Health Sciences in Nepal, and is also pursuing a PhD in global health from the University of Geneva. Dr. Koirala is going to talk to us about one of the most perplexing medical problems that one encounters in routine healthcare, which is unexplained febrile illnesses. Dr. Koirala.
Thank you, Dr. Patel, for the introduction. And okay. Okay, so let me start first. Good afternoon, everybody. I would like to welcome you all to the session and also to the online audience. I am presenting on behalf of my team. So that's me, Kanika Koirala, and I would like to acknowledge the effort of the team before I start the presentation, because this was a huge study and it is not only my effort, it's also the effort of the whole team, and that's why we have these results now. So it's the causes of persistent febrile illness in the eastern part of Nepal. So start with Nepal. So Nepal, it covers an area of around 147,000 square kilometers with a population of approximate 27 million. So that's the map of Nepal. And in the center you see a red spot, that's Kathmandu, the capital, that I am sure most of us know about Kathmandu. But you see the two red spots to the eastern side, that's where the study was. And so you see the two centers separately. It was in a part called Dharan and Dhankuta. We chose these two centers because they were in the eastern side and because they had different topography. Dharan is more toward the plains and Dhankuta is more towards the hilly side. And it will be more evident when you see the results, because the presentation of the patients were different, and even the diagnosis that was found at the end was different in both the regions. So these are the two hospitals. The one on the top is the one in Dhankuta. It's a district hospital. And the one below is the institute where I am from, BP Koirala Institute of Health Sciences. So the study we did on persistent febrile illnesses, which was more than 7 days of fever. Fever, as we all know, presents for many various diseases. It's a syndrome, and it can be for cancers, for infectious causes, for connective disorders, so many. But we were mainly focused on neglected infectious diseases, which were prevalent in the region. This was a part of an EU-funded multi-country study called NEDIAC, which actually stands for Neglected Infectious Disease Diagnosis. So we studied the differential diagnosis, associated clinical and laboratory predictors in patients with persistent febrile illness. We took patients from more than or equal to 5 years old, fever of more than 7 days. The study went on from January 2013 to October 2014, and we did it in 2 centers. We filled case report forms, took the medical history, physical examination, laboratory investigations at baseline when the patient presented to us first, and even at follow-up after 1 month. The tests that we performed for all the patients were hemoglobin, white blood cell count, kidney function test, liver function test, blood cultures, urine routine and cultures, malaria rapid diagnostic test, and HIV serology. Besides these tests, we had other tests which the physician could request for, but these were compulsory for all the patients. We also did the chest X-ray, abdominal ultrasound, sputum examination. The testing of samples was done at national reference laboratories and at international reference laboratories. The tests like PCR or ELISA, which are not available in the country, were done outside. The conditions that we targeted, we call them target conditions because, like I mentioned, fever can be a presentation for various causes. We were looking for malaria, tuberculosis, leptospirosis, relapsing fever, visceral leishmaniasis, HIV, brucellosis, rickettsial diseases, and enteric fever, because these are more prevalent in the area and these are infectious and neglected in the region too. So the formulation of diagnosis, we had case ascertainment done by the experienced physician based on pre-specified case definitions. So now to the results, we had around 578 patients recruited, 447 in BPKIHS and 151 in Dhankuta. So the target conditions, so as you see, this is for BPKIHS, which is in Dharan. We have, because this is endemic to visceral leishmaniasis, we have a lot of patients with visceral leishmaniasis. And then we have tuberculosis, rickettsiosis, scrub typhus, leptospirosis, enteric fever, HIV, and relapsing fever. Relapsing fever this is the first study to report relapsing fever from Nepal. And then this is the proportion of the cases that we had seen. And then the other conditions, because as I said, fever is not only for the infectious diseases. So when the patient came to us, we just recruited them if they had fever. So the other causes that were isolated after we found the diagnosis were pneumonia, tonsillitis, respiratory infections, UTI, leukemia, solid tumors, misinfections. You see the last column, that's the undefined. So there were around 48% of cases that were undefined after we ran all the battery of tests nationally, internationally, and we still had a lot of undefined cases. So from those 48% that were undefined, there were 63% that were suspected to have enteric fever, from which 84% had received antibiotics. And then Dhankuta, like I said, both the centers are situated in different topographical regions. So you see in Dhankuta we have tuberculosis, scrub typhus, leptospirosis, and there is no VL, malaria, brucellosis, where we had seen VL, many cases of VL in BPKIHS. Same goes here. These are the proportion of the cases that we had seen in Dhankuta, and these are the other conditions. So here also we see the last column, which is the undefined cases. So we have around 54% of the cases were undefined in Dhankuta also, from which 85 were suspected of enteric fever and 91 received antibiotics. So what we plan to do with the results? First, we had decided to do the study because there was a study done long back in Nepal in 2004 for fever to find out the prevalence of the various causes of fever. But since then, there was no other study done. So we thought it's essential that we know what are the prevalent causes of fever. And then we wanted to develop a diagnostic guide, which we hope that it helps the healthcare workers in improving the diagnosis for the fever cases. So this is what we developed. You see the first row? The first row is the first step. So if the patient comes to us with fever more than 7 days, we do the history taking. So this is something what all physicians do. But we have limited the points. So we have just duration of fever, history of VL, pallor, travel history, cough, bloody sputum, abdominal complaints, and family history of VL or tuberculosis. So we have listed out the bullet points so that the physician does not forget, and these are the very essential points that must be taken. Then we do the examination. So again, we have limited the number of points that the physician has to compulsory because we are targeting the primary healthcare levels. So we do not want them to miss out anything. Then we have the lab, the urine, the chest x-ray, the rapid diagnostic tests, ultrasounds, and lumbar puncture. Then what you see in the center is a panorama, because we think when the patient presents to the physician never thinks of a disease on itself. The physician thinks of various diseases and how do I treat the patient. So we think that this represents what goes on in the physician's mind. We have put the diseases in boxes, and so you see Kala-Azar or VL, tuberculosis, pneumonia, enteric fever, abdominal infections, urinary tract infections, meningitis, leukemia, leptospirosis, scrub typhus, rickettsiosis. So these were the ones that were prevalent in our region, in our study. And then you see these boxes below like I will take the example for tuberculosis and Kala-Azar, I've put them in red. So you see the boxes below Kala-Azar. You see a plus and a minus. So that's the positive predictive value. So more likely if the patient has splenomegaly, a hemoglobin less than 10 per 10 gram, and rapid diagnostic test positive, bone marrow positive for leishmania, and fever more than 2 weeks, the patient has Kala-Azar. And when we put it in the negative, so if the rapid diagnostic test is negative, we think that the patient might not have Kala-Azar. So this is what we plan, and we are still developing this. And we hope to put this at the primary healthcare levels, and so it will help for easy diagnosis. These positive and negative, we had the post-test probabilities, and from which we got the likelihood ratios, and so we developed the positive and negatives. And the conclusion, the common causes of persistent febrile illness differ from the parts of Nepal level non-endemic for visceral leishmaniasis. I stressed on the non-endemic for visceral leishmaniasis because the other studies that have been done so far in Nepal are done in areas which are non-endemic for visceral leishmaniasis. So it always misses out the visceral leishmaniasis, which is pretty prevalent in Nepal. So we wanted to do it in an area which is endemic for visceral leishmaniasis. And thank you.
Thank you very much, Dr. Koirala. I've always been fascinated by this subject of persistent and apparently unexplained fever. I was most intrigued by the finding of the very large proportion of individuals who, despite these very thorough and it seems to be almost comprehensive tests of infection, a range of infections, still came out with no apparent pathogen. And I remember a similar study, several studies from Africa looking also at malaria endemic zones and finding very large numbers of people who were being given putative anti-malarial treatment actually had no malarial parasite. So I have two questions. The first is, did you see an age-specific difference in the rate of the inability to find a pathogen? And in particular, I'm thinking that older people in your sample might probably have other causes of fever that are not infectious in origin. And so that was my second question. Do you think it might be worthwhile if you had to repeat the study to investigate other non-communicable diseases, autoimmune conditions, for example, certain kinds of malignancies that also present, in fact, with unexplained persistent fever, particularly in older people?
For the age-specific difference, we are still doing the analysis, so we'll have a more detailed analysis, and I can tell you after that if the older people had different causes or no. So I cannot answer that right now. And if we repeat the study, more than only seeing if there is a difference in the older and younger, we were actually thinking of this because we were very intrigued by the 50% of undefined, and actually that is the group that we want to highlight and we want to actually help, because that is the group that needs the diagnostic guidance. So we plan to do something with viral, because we have not seen the viral infectious possible, and so we were thinking of including tests for viruses. And we actually initially, when the study was planned, the viral part was thought of it, but because it was more than 7 days, we thought viral infections are generally below 7 days, so maybe it's possible it's not viral infections, but you never know, because the point of entry was if the patient reported 7 days of fever. It was not measured 7 days of fever. So it's possible there are viral infections too. So we were thinking of including viral infections next time.
Okay, thank you. So we've got a few minutes for maybe two questions. So we've got a couple of minutes for two questions. Would anyone like to ask Dr. Koirala anything about this study? Okay, so we've got a question up there, the lady in the black t-shirt. If you could just speak in the mic and just introduce yourself as well.
I'm Maitri Porecha. I work for DNA newspaper. My question to Dr. Koirala is that the patients that were included in your study at the end of over 7 days and had febrile illness, which was not detected, how were they treated, and did any of them succumb to the illness that they had, or the illnesses of this nature usually are such that the patients recover naturally themselves, and over how many period of days do they come out of this particular condition?
Okay, I cannot give you exact figures right now, but from what I could say is we had a few deaths in the study, but the deaths were mainly the ones with the malignancies. So the ones who came undefined, they did not have a outcome as death. They mostly recovered. And also because in our part of the world, antibiotics are not regulated. They get them over the counter. So most of them actually had taken antibiotics before coming to us. So it's possible that they were partially treated and then they got some more antibiotics and they were cured. And mostly because if they were partially treated, and that's why we could not detect something. So that's very high likely, but I can give you more detailed figures once I have the complete analysis done. Thank you.
Any other questions? Okay, well, thank you very much, Dr. Koirala. So moving on to another very neglected health concern. The next speaker is Tamri Hussain. I don't know if I pronounced that correctly, but if you're from Kashmir, it could be Hussain, but actually spelled Hausen. But I'm going to call you Hussain for the moment anyway. Tamri is working as an epidemiologist with MSF New Delhi, and she's going to be describing, I think, a very important study for this country on the mental health consequences, or rather the mental health correlates of living in the Kashmir Valley in India.
full screen. That's all right. Okay, good afternoon. Thank you for all still being awake at this time of day after hearing so many people speak. Today I am presenting the results of the Kashmir Mental Health Survey that we conducted last year. This survey was conducted in collaboration with the Department of Psychology at the University of Kashmir and the Institute of Mental Health and Neurosciences in Srinagar. So from the map, the state right at the top in purple is the state of Jammu and Kashmir. We conducted our survey on a portion of this state called the Kashmir Valley. The Kashmir Valley is made up of 10 districts. It shares a border with Pakistan in its northeast. It has a total population of 7 million people, 73% of which live in rural areas, 97% of Muslim religion, and it has undergone sporadic political insecurity since the division of India and Pakistan in 1947 by the British. In 1989, an insurgency began for self-determination, and since that time, the state of Jammu and Kashmir has faced ongoing conflict. So why did MSF conduct this survey? MSF conducted a smaller survey in 2005 in 2 districts of the Kashmir Valley and found a high prevalence of mental distress. Other empirical studies conducted in Kashmir have also found a high prevalence of mental distress. There was a need for updated baseline data across all 10 districts of the Kashmir Valley in order to measure the mental health of the population. Where prior research on conflict-affected populations has really focused on the effect of conflict-related trauma on the mental health of a population, current research now is looking at more a holistic view on the impact of living in an area affected by conflict, also considering stresses of daily life and livelihood such as unemployment, underemployment, poverty, and the breakdown of socio-cultural support systems, which all have been shown to have negative impact on mental health. The objective of our survey was twofold. It was mixed methods research. We set out to estimate the prevalence of mental health related problems specific to depression, anxiety and post-traumatic stress symptoms in the Kashmir Valley and to determine accessibility to mental health services. The first part of this objective was done by a household survey and the second part was done through qualitative focus group discussions. Today I'm only presenting on the survey results. So our methodology, we used a probability-based sample where we used population proportional to size to identify 40 clusters per district. Across the 10 districts, we covered 400 villages and 5,600 adults. We had 10 teams of 53 enumerators, all with postgraduate qualifications in psychology, sociology and social work. They received 2 weeks of training. A pilot was conducted during October 2015 and the survey was conducted between October and December 2015. Our data was collected using an electronic questionnaire where 2 screening tools were embedded, the Hopkins Symptoms Checklist for depression and anxiety and the Harvard Trauma Questionnaire for post-traumatic stress disorder. We also collected data on demographics, functionality, substance use, problems of daily life, coping and traumatic experiences. Now, just a note on the screening tools, we conducted an earlier study in 2015 where these screening tools were culturally adapted and translated by an expert team of psychologists and psychiatrists in the Kashmir Valley. We conducted a validation study between February and April where the Hopkins Symptoms Checklist was validated for Kashmir. We developed a validated cutoff score for depression and anxiety. However, due to sample size restrictions, we did not get a validated cutoff score for post-traumatic stress disorder, so we used the internationally recognised cutoff for our survey results. Our survey data was weighted and statistical analysis carried out. This is just a quick table from the validation to show the cutoff scores that we used. The international cutoff score for depression is 1.75. Our culturally validated cutoff score was 1.57, so quite a bit lower than the international. For anxiety, our cutoff score was the same as that recognised internationally at 1.75, and for post-traumatic stress, as I said, we used the international cutoff score. The results, we had a very high response rate, 97.7%, and after data cleaning, we had 5,428 interviews for analysis. 78% of our sample lived in rural areas, 67% were women. The mean age was 39 years. The age ranged from 18 to 120. I'll do a caveat here that in Kashmir, a lot of people don't know their exact age, so they estimate their age. Either that or Kashmir has some life-giving water that could be marketed. 68% were married, 35% reported having had no education, and 38% of men had some form of employment. For 81% of women, home duties was their main activity. Now, in the results I'm presenting next, these have been weighted for the overrepresentation of our sample, of females in our sample, and also for the complex sampling design. And what we found was that 45% of adults across the valley showed significant signs of mental distress. 41% with probable depression, 26% probable anxiety, and 19% with probable post-traumatic stress disorder. The reason we classify these as probable is that we did use screening tools based on a cutoff score, so they are not diagnostic. What they do is they pick up people with signs and symptoms of these disorders, and all three of these disorders have a large range of symptoms from subsyndromal illness, minor presentations, from transient symptoms to severe symptoms, and the screening tools will pick up everybody across that spectrum. Both of our screening tools also had diagnostic algorithms developed by the Harvard Trauma Group based on the actual symptoms and item responses. When we ran these diagnostic algorithms on our data, we found that 10% were classified with severe depression, meeting all the DSM-4 criteria for diagnosis of major depression, and 6% met all the diagnostic criteria for post-traumatic stress disorder. This is a distribution across the districts of the valley. You can see that Baramulla and Budgam had the highest prevalence rates, and the lowest were found in the mid and western districts. You can see a common pattern across all three disorders, and this is largely due to the comorbidity. A lot of people that scored high on PTSD also scored high on depression, so there's a lot of crossover of morbidity of these three. We look at trauma. On average, an adult living in the Kashmir Valley has witnessed or experienced 7.7 traumatic events during their lifetime. 73% of men and 52% of women had experienced or witnessed greater than 6 traumatic events during their lifetime. Consistent with the literature, we found a dose-response relationship with the number of traumatic events experienced or witnessed and the prevalence of mental distress. Here we have in the bars the number of proportion of people in each of the districts that had experienced or witnessed greater than 6 traumatic events. The little shapes represent the prevalence rates in those districts for depression, anxiety and PTSD, and the linear line shows that there is a steady increase with the number of traumatic events. With the increase of number of traumatic events, so the prevalence rates also increase. The main problems of daily life were financial, poor health of self and unemployment, and the main coping mechanisms include prayer, talking to a friend or family member and trying to keep busy. Now, we recognised that substance use is a very difficult thing to measure in a cross-sectional survey, but an effort was made to assess substance use in the valley with the reporting that by practitioners that it is increasing across the valley. However, due to the cultural stigma associated with these substances, we do feel our data is underreported. However, we did find that 11.5% of Kashmiri adults are taking benzodiazepines, 45% of which have been taking them for more than 1 year, and this was distributed across all age groups. We also found a very high prevalence of tobacco use. Tobacco use was also reported as one of the main coping mechanisms by 1 in 5 men. When we look at the predictive factors, we find that being female, aged over the age of 55, having poor education outcomes and a greater exposure to trauma was a predictive factor for symptoms of depression. For anxiety, it was a similar picture, with being female, poor education outcomes, having a higher exposure to trauma and living in a rural area being predictive for symptoms of anxiety. We also found that education was also a protective factor. Those reporting secondary or tertiary education actually had a less likelihood of developing symptoms. Post-traumatic stress disorder was a slightly different picture. Females, those aged over 55, those widowed, divorced or separated, living in a rural area and having increased exposure to trauma had a higher likelihood of showing symptoms of post-traumatic stress disorder. Now, the limitations of our survey is that it was restricted to only 3 mental health disorders. The survey only collected data on adults, adolescents and children were not included. Data on ethnicity was not included. And due to the length of the survey questionnaire, a screening tool for general health was not included. As mentioned, the Harvard Trauma Questionnaire, although it had been culturally adapted and translated, was not validated for the Kashmiri population. The public health action that has come from this, with the evident high prevalence of mental distress in the population, particularly in rural areas, the stakeholders working in mental health across the valley met for a round-table conference on the 11th of May, at which time recommendations for public health action were formulated. There is a long list of recommendations, the basis of which is around the decentralisation of mental health services and capacity building at village level for early detection, intervention and referral. A working group has been established with the stakeholders to follow up these recommendations. I would like to acknowledge the team from MSF, from the University of Kashmir, Institute of Mental Health and Neurosciences, and a colleague from the Australian National University. But most of all, I'd like to acknowledge the people of Kashmir who gave of their time, their personal information, and shared with the team fantastic hospitality throughout the survey process. Thank you.
Thank you very much, Tambri. I think these findings very much confirm the sorts of results that you might see, for example, from similar surveys in other conflict-affected areas like Afghanistan. I have lots of questions, but I'll restrict myself to a couple and give a chance also to those of you in the audience who want to ask. The first question was, were you able to compare these results with those from 10 years before? And if so, did you notice any differences in the patterns? And the second one was to do with, I know that you explicitly did not include children, and I'm increasingly interested and convinced actually that perhaps the greatest impact of trauma and conflict is on the developing brain of the young child and how it leads to increased aggression in adulthood and in fact then fuels an intergenerational transmission of violence. I know the research doesn't include that, but I just wondered whether you had any observations about the impact of living in a conflict-affected area on children's mental health.
Okay, I'll answer the second one first and then the first one. So the second question, we did not assess children and adolescents. It's more complex with regards to screening tool and assessment. Also ethically, we didn't touch that topic. But it is recognised in Kashmir as an area that really requires further research, particularly being that a lot of people are reporting increased substance use among adolescents in the valley. And the stakeholders we've spoken with have said that in schools it is quite prolific now, substance use, and there is a requirement definitely for further research in this area. So, and in answer to your first question, the survey that was conducted in the districts of Budgam and Kupwara in 2005, it did use a different screening tool and slightly different methodology. We are looking now if there's some way of modelling, we're discussing with statistician, there's some way of modelling where we can compare the results of the two.
All right, so we now can throw it open to the floor for questions. I've got one question out there, the lady in the front, and then the gentleman with the cap to follow on. If you could just introduce yourself.
Hi, my name is Kritika. I work at MSF. There's a question from the online audience. So you said that on an average, an adult living in Kashmir has witnessed or experienced 7.7 traumatic events. The question is how this compares to other areas within India and countries with similar situations.
Okay, just one clarity on the traumatic event too. We included trauma from all aspects of life. So it's conflict related, it's natural disaster, it's life trauma, it's terminal illness, it's accidents. It covers everything, physical violence. So our traumatic experience cover a wide spectrum. And I think in the literature, it has really focused on conflict related traumatic events that I've read. So I haven't seen a lot of literature which has really covered a wide spectrum of traumatic events, so I can't answer that one, I'm sorry.
I just want to say one thing about this issue of traumatic events as well, is that there's also a growing body of evidence that suggests it's not specific events, but living within a climate of fear for extended periods of time that actually is potentially even more damaging to your mental health within a conflict situation. For example, being constantly under curfew or being constantly confronted by armed men on the road. This is an unnatural environment for most people, and that is potentially even more damaging to your mental health than, say, for example, a very acute traumatic event. We've got a question from the gentleman there.
First of all, thanks for the wonderful presentation. My question is that most prevalent rate was found for depression, and we know that depression is a risk factor for suicide. Was there any grading done for depression, like mild depression called dysthymia depression to the severe depression called melancholia?
Okay, we couldn't do that using a screening tool. That requires a clinical assessment. But what we did find in our screening tool, we do ask about suicidality. In the last 4 weeks, have you thought of killing yourself? And 12% of our respondents said yes at some level, and 90% of those who said yes also scored high on the screening tools. 96%, sorry.
My next question is that
we've got a number of other hands. Maybe you can ask the next question during the panel. We've got this gentleman at the back with specs there, and I think we'll have to then see. There will be a panel though.
Thank you, sir. So I am Dr. Maji from West Bengal State Health Department. My question is how you relate this depression and anxiety in Kashmir Valley with trauma? Because I ask this question because this type of depression and anxiety are very common in other parts of the country also, and our people, care providers at rural levels in all areas, they also speak of the similar situations. So how do you relate these with trauma?
Yeah, I agree. Mental illness is multifactorial. There's poverty, there's livelihood issues, there's a lot of other issues that have an impact on mental illness. What we didn't relate to specific traumatic events, but what we found is the people that had experienced multiple traumatic events, had experienced or witnessed, they had a higher likelihood of having symptoms. So that's the only association we can take from the survey, is people that experience multiple trauma have a higher likelihood of developing symptoms. But definitely there's lots of other factors that affect mental health as well.
Okay, well, thank you very much.
Thank you.
So we'll move on to the third presentation for this session. I'd like to invite Nasreen Aizadiyar, who is the head of social work and family counseling at the Royan Institute in Tehran. And Nasreen is going to talk to us about a survey that was carried out in metropolitan Tehran with people aged 15 to 49 years to explore their knowledge and attitudes around sexual and reproductive health.
Thank you for attending this session. I'm glad to be here to present kind of sociological study with the permission of chair of the session. The author of this study couldn't be here, and I'm here today to present on her behalf. I'm here to present about the attitudes and awareness towards sexual reproductive health in Iran and in the city of Tehran, the capital of Iran. Even talking about sexual matters in Iran is considered as taboos. And the previous studies in Iran show that sexual health programs is bounded for married people and limited to contraceptive, prenatal care, pregnancy, childbirth, and breastfeeding. And the previous studies shows that educational services in the field of sexual health are not provided in government centers and in private sectors in low percentage. And is provided for married people. And how about the single people maybe they don't have sex, I don't know. But this is why we are observing Iranians are getting married later and later. There are, of course, premarital sex happening with high-risk behaviors, and condom usage is neglected. So we have few studies in this field in Iran, and available studies have focused on adolescents and young people. There is a very little information about adults in Iran. And a vacuum exists in terms of work done on sexual and reproductive health in Iran. Filling such a gap in this field, the researchers decided to conduct two studies. One is published in Journal of Sex Research recently, and these studies dedicated to assess sexual and reproductive health knowledge among men and women in Tehran, and explore potential association between classification of sexual and reproductive health knowledge and sexual attitudes with age, gender, education, religiosity, and marital status. The method of this study is a cross-sectional descriptive study of 755 participants between the age of 15 to 49 years. All of them are residents of Tehran. The average age is 29.4. The data were collecting using multi-stage cluster random sampling, and the researchers used WHO questionnaire adopted in June 2014. The researchers obtained the ethic committee of the University of Tehran and the University of Isfahan clearance. And in the left map, Tehran is the capital of the most populous is the capital and the most populous city in Iran, with over than 12 million residents. Pointed with stars on map in the left map, and Tehran is the economy heart of Iran, and recently many people had migrated to Tehran in recent years for better life. According to municipality of Tehran, Tehran is divided to 22 regions, and the researchers used multi-stage cluster random sampling from different regions of Tehran. The measures of knowledge was 2-point scale for each question in 4 domains: physiology, contraceptive, HIV, sexual transmitted infections, condom usage. And measures of attitude of sexual permissiveness was 3-point Likert scale. The higher score showed liberal attitudes, and lower scores shows conservative attitudes. In results, women, older people, and ever married people had more sexual reproductive health knowledge. Levels of education had no impact on sexual reproductive health knowledge, surprisingly. Older, ever married, and more religious responded were less accepting of sexual or non-sexual interaction and had more conditions for any such interactions. Men and women were supported of dating before marriage with no gender differences, it's surprisingly. Males were open to non-sexual tactile interaction than female, as we accepted. And as we see in chart, in the relationship between attitudes towards sexual permissiveness between age and gender, male and female is the same. And about age, as age increases, attitudes towards sexual permissiveness decreases. And about the relation between attitudes towards sexual permissiveness and marital status and religiosity, the people who never married show more permissiveness, and their attitude is conservative. And as we accepted people who were very religious are more conservative. And finally, about the relationship between knowledge and gender and age, both gender have most equal in knowledge, and even ages is increasing, the knowledge increases. And the people who experience marriage have more knowledge in our study. Conclusion. Despite good knowledge among the people, there are misperceptions of different aspects of attitudes about sexual reproductive health among people in Iran. Men need to receive more educational about the sexual reproductive health. And I want to talk about the changes in recent years, and we are seeing changes in attitudes, and it seems to need to both method studies and qualitative studies as well, as it showed the need for providing sexual reproductive health training to both gender within the educational curriculum. I want to thank Dr. Safiye Shah for helping me to present this study. Thank you very much. This is the picture of my city at night.
Which is presumably a very good way to end a talk on sex. We need to particularly thank Nasreen, because she's really stepping in for a colleague of hers who couldn't be here. Actually, I found this topic very interesting also from the perspective of India, where I think I'll be provocative here. I think more young people were having sex 50 years ago than they are now, because of course they were married. And as we've enhanced the age of marriage, which is a very good thing, we haven't, alongside that increased age of marriage, recognized that young people are sexual beings, and social norms around sexuality haven't changed. So I find these figures of 15 to 20% of young people not having premarital sex are abysmally low, actually. But it would not be out of sync with India as well. I think we'd see the same thing in India. So I wanted to ask you, my question to you really is, do you see this age difference, which your study also reports, in attitudes towards sexuality in terms of progressive and use the word permissive? I just think they're progressive, actually. Do you think that this is creating a culture clash within your country between the older generation that probably got married when they were 15 or 16 and the younger generation who will only get married when they're maybe 25?
Actually, there is not many findings in Iran about the sensitivity of these issue, but in the internal studying, such in the University of Tehran, we have studying that they show in decades, in recent 3 decades, women postponed marriage, and this matter causes accepting and engaging in premarital sex. And we see the pattern of the sex is changed in recent years. For example, the importance of preserving virginity in Iran has changed, but the preserving virginity is still the driver of contraceptiveness attitude before marriage in Iranian culture. So they prefer, they prefer anal sex or conditional sex before marriage, and this changes, but we have no educational programs in clinics about them.
Okay, I think we can throw open for some questions. Yes, the lady there.
Thank you. I'm Carolyn. I'm Deputy Medco at the MSF Delhi office. It's really not a question for you, but more a comment on what Dr. Vikram Patel said about adolescents or young people in India and whether the percentages will be similar. So I don't have studies, but with personal experience in a small research that we did in rural West Bengal, I'd gone with this similar idea of adolescents not engaging in sex before marriage, or not, or a much lesser percentage. But due to the access to internet, on the phones, on mobiles, we see more and more young adults in cities, and also I was surprised in rural West Bengal, who engaged in premarital sex, but it's obviously underreported. It's shameful to the society, it's not a norm, and so they will not accept it. It's a taboo, yes sir. So that pattern has been changing, so there are a good number of adolescents that do engage in premarital sex, do not let anyone know. If they get pregnant, they're either forced to get married at the age of 14, as young as 14, or then taken to a quack for an abortion. So I think that it would be, it's something that would be good to document in form of a research, but I still, that would also be difficult to get numbers then for India as well. Thank you.
Thank you. Can I say something? We have this this matter in Iran too, and the important thing that the young women are under the pressure for marriage, and they sometimes they had premarital intercourse, and they are under the pressure to some surgical operation before marriage, to I don't know what's the name in English, to the operation for the preserving virginity, and it's very much too much in Iran.
Okay, thank you. Yes, the gentleman at the back.
I'm Dr. Chanjeev. I'm a plastic surgeon. I agree with Caroline's comments that premarital sex is underreported. But in the last 10 years, we have seen a spurt of patients coming to us for virginity restoration before marriage. So that is some indicator.
I think I'm not at all surprised that adolescents are having premarital sex, but it does worry me when we treat premarital sex as an adverse health outcome in surveys. I think the problem for me when that is done is that it denies the idea of premarital sex in a society where marriage is becoming delayed, rightly so, as being some kind of disorder. And I think it creates the circumstances for secret sex, for high-risk sex, for dangerous sex, and all the consequences that go with it. And we're seeing a lot of that. In fact, the example you just gave is a good example. Women having to do these sorts of operations is really a result of this kind of lack of change in social norms. Okay, last question. Please take the microphone.
I'm an independent journalist. I just want to know one thing. You said that your study was approved by the ethics committee. Did you share the findings? One. If so, what was their reaction?
The ethics committee reaction? They don't know about the findings. I know.
Okay. Well, thank you very much, Nasreen. On that note, we'll move on to the last presenter. Thank you.
Yeah, I want to.
Oh, you, sorry.
Yes. I'm social worker and I work in the infertility field. And I'm so glad to be here in a medical meetings. And I think social studies can help the medical practitioner to work better. And how much we know about the people how they behave, help us to work them better. Thank you very much.
So I'm delighted to invite our last speaker for this session, Petros Isakidis, who works with the MSF Luxembourg Operational Research Unit but is based in Mumbai. And he's going to be talking to us about a condition which I think is probably one of the most neglected causes of death, particularly in childhood in India, although he will be really referring to a study from the south of Sudan to illustrate how important it is also in that part of the world.
So, good evening. This is the last presentation. So, I just want to start with two disclaimers. One is that I know nothing about snakes and South Sudan, and I've never been to South Sudan. My only knowledge about snake bites was the last week where I was briefed through Skype with a team that did this fantastic study, and I read some literature. The second disclaimer is that I would like to share with you that when, as a member of the scientific committee, we decided to accept this presentation for several reasons. One is that this is actually neglected, we realize that this is a neglected condition. Second, this study, as you will see, is very well done, is methodologically well done. And third, the findings are striking. And fourth, it coincides with a global advenom crisis that is happening this time. So I can only share with you some excitement of discovering a new field, and I hope that I will do justice to the people who did the study. So our colleagues are in this little town in the north of South Sudan called Agok. And they run a hospital of almost 200 beds, and they do almost everything from emergencies to maternal health. And they have a lot of snake bites, snake victims. And one of these victims is this little cute fella who was bitten by a snake on his face. So the team there decided to study this, the snake bites in their area. And they actually realized that this is a worldwide neglected condition with quite a significant burden, but also quite underestimated. I mean, if you see the numbers of bites, 5.5 million, 1 million envenomed, and the deaths vary between 94 to 150,000. Just to give you a little bit of data about India that I discovered recently, the estimates were something between 1,500 deaths due to snake bites to 50,000. And there was a survey done which called 1 million deaths, and the one part looked also at snake bite deaths, and they found approximately 46,000. So actually it was closer to the higher estimate. So back to Sudan, our colleagues there, they had in the month of May 2014, 90 cases, so three snake bites a day, and they had 3 deaths in 2014. So this, I think, kind of triggered this study. And this is what I said about the methodologically well-done study. I'm surprised as an epidemiologist that they used 3 sources of data. So one was the hospital registers. Some teams will just stop there, will not go further, even we know that hospital data usually don't give a lot of information. They did one survey using a kind of a snowballing thing. They found some high figures, 409 bites. They thought that maybe something was wrong with their survey, so they did another one with randomly selected, more well done. So actually they have 3 sources of information. And what is surprising is that what made them And this is a picture from the survey in the field. So what actually they thought that it was too high, what was the survey number 1 with an incidence of 1688 per 100,000 bytes, 1,688 bytes per 100,000 population per year. Actually, it was an underestimate because the second survey were more well done, showed much higher at 3,596 per 100,000. This is extremely high numbers, 100,000 per year. Extremely high numbers of snake bites and a quite high case fatality ratio. The first survey 4.4 and the second survey 2.3%. And they looked also at the distribution, the demographics of the snake bite victims, and you can see here that they looked at the gender and age groups. There is a bit of discrepancy between the three sources of data. The hospital data shows more male victims, while the community surveys show more female victims. I think this is an interesting finding. Maybe the team wants to explore more. There was not much difference between the age distribution. I will skip this table because it's actually identical to this one, and this shows pictures of 7 species of snakes. To be honest, I only know the cobra because it looks like the cartoons of the snake charmers also in India. But I have to tell you that there is, for the ones who find this fascinating, and actually it's quite useful, not just fascinating, there is a database. And there is an Indian database, which I think, and I am sure that there are some other South Asian. The Indian one is www.indiansnakes.org. It's very easy to remember. And I will ask you to consult it. It's interesting. So, describing the epidemic in time and place, location of snake bites, 37% in the house. I think this is very interesting. Activity, while most of the people were out in the bush, 20% of the people who were bitten while they were sleeping. I think this is quite scary. Biting sites, mostly the legs, but as you saw from the previous picture, any part of the body can be bitten. This little fellow was bitten on his face. And timing of the bites, evening and late night, up to midnight. Apparently the snakes are. Looking at seasonality. If you see these are the 3 graphs from the 3 different sources of data. Similar pattern, small differences. I don't think I want to go through this, but again, what it shows here is that you have a season in India and in Southeast Asia is the monsoon season. I guess this is also the rainy season in Sudan, where most of the snakes are at their nastiest when they go out and looking at the clinical now characteristics of the people who get envenomed. First of all, 65% almost of the people who were bitten by snakes had an envenoming syndrome. And the 3 most common syndromes are the cytotoxic one, which is like swelling and up to necrosis of the area, of the affected area. You have hemototoxic syndrome, where you have clotting disorders. That's like the blood clotting disorders, and neurotoxic syndrome. And there are some other syndromes like cardiotoxic and etc. But I think these are the 3 most common. And according to the literature, this is not only in Sudan or in India or in Southeast Asia, it happens worldwide. In this particular study, they found that 55% of the patients had cytotoxic, 26 hemotoxic, and 4% almost neurotoxic syndrome. These are some pictures just to show that how it looks when you have some of these syndromes, and also this little bottle there. It's just a simple test to see clotting, and it doesn't require sophisticated machinery or devices, just a bottle and some time waiting to see. So our team there has this syndromic approach, and they have this nice algorithm. I don't know if it's really visible just there, but actually what it shows that based on the history of snake bite, you look at different syndromes, what I described before, cytotoxic, neurotoxic, hemotoxic, and then based on that, you can see what are the snakes and what are the snakes most likely. And if you add this algorithm, this is the adivinum algorithm, where based on the snakes or based on the syndrome, you can administer the appropriate one. To be honest, for me, that I don't know so much snakes, I say, why we don't have a polyvalent adivinum that we can give with no-brainers? Why we need algorithms? We just have to have a bottle and just give it to everybody who has a syndrome, whatever is the syndrome, whatever is the snake bite, etc. I guess these are also, our colleagues from Sudan are more affected than me asking this silly question. Then, looking at risk factors for death. I think if you see this analysis shows that age was children and adolescents 0 to 15 were the most affected. Syndrome, the progressive cytotoxic symptom has the odds to die from after a snake bite was almost 31. And if you haven't, I think this is important, if you haven't been given an adenovirus, your odds of death were 25. I think this is quite high. It shows the confidence intervals are quite wide, but it's because the number of deaths it's quite small in this analysis. A difference between access to adenovirus in this particular setting, and you see that in the health facility it was 27% that people that got the adenovirus, while in MSF hospital it was 81. And also, if you see the last line there, I think it's interesting to mention about the communities that traditional practices still were used, and 67% of them got about this thing that it's kind of tradition in many cultures and communities, cut and suck, incision and suction. 46 were using a black stone to treat snake bites and tourniquets. A very nice mapping. I think this could help also to identify some interventions. If there are some, you just plot the people who the snake bites, the locations of snake bites in a GPS system. This, I don't think you can see the green are the snake bites, and the red points there are the snake bites deaths. So this was the first snake bite survey in South Sudan. I think it was the team has to be commended for this great job that they done there. They have some limitations. Maybe snakes were misclassified, and maybe they have, since they asked the people, recall bias is always a problem with this kind of surveys. However, they found quite high incidence compared to African literature, and a very high community case fatality ratio in the community, 2.3 to 4.4%. You notice the large variety, at least 7 pictures there, large variety of snakes species, which actually highlights what I said, why we don't have a polyvalent antivenom instead of having several little bottles and trying to find which one is to use. Highly seasonal monsoon period, and the high odds of death if you were not given the antivenom. And this is the conclusion. That this study reports maybe the highest documented incidence of snake bites, a very high mortality among patients who don't get treatment. They used a quite nice study methodology using 3 sources of data, and they addressed a quite neglected tropical disease issue in a neglected area. So the team there, and I think most of us will echo their call, ask for positioning of the adivenoms to the places that are needed. Is like finding the hot spots where the snake bites happen, and make sure that the venom is there, not in state capitals or in the country capitals or in hospitals, tertiary hospitals, and make sure that you train the communities and the staff how to handle the snake bites. And just to finish with this, venom, I said there is a global crisis right now. I think I was briefed that just this month, next month, the last batch produced by a company is about to expire. There is no new production. There are several companies who produce antivenom, including some Indian manufacturers. However, there is no much published data on their efficacy and safety. And I hope that I did, at least I didn't share knowledge, but I hope I shared the enthusiasm, excitement that this was a very good study, and I'm very happy that I was given the opportunity to present it on their behalf. Thank you very much.
I mean, I'm sure you'll all agree with me that it's hard to believe that you're just stepping in for the team. It sounds like you were out there in Sudan counting each of those snakes personally. I have to say, I think it's quite interesting, that the conclusions of this team, and obviously from an epidemiological point of view, I'd like to just ask a question, not just to you, because you probably may not have a direct answer for this, but while I completely agree that it's extremely worrying that the polyvalent vaccine isn't available, and we should, anti-venom is not available, and that is something that we should be really addressing with a matter of urgency, I thought there are certain distributional characteristics of these data, which I think are fascinating. And I was wondering whether they might point to some preventative interventions. For example, I noticed that the peaks happen in the rainy season, they happen in the evening hours, the children were the most vulnerable to dying, and there was a clear spatial distribution. And I'm wondering whether, for example, the equivalent of insecticide-treated bed net, is there some thinking in this field about how you can use these distributional aspects to design a preventative intervention?
Well, I will answer based on this 1 week of experience in taking snake bites. So if our colleagues from Sudan are online, please help me to answer this. What I read, and actually I was very interested, is that there is some studies or some community work in India. There is one in Andhra Pradesh, in Chhattisgarh, who are doing a project for prevention of snake bites. So educating the communities how not to sleep on the floor or how to not to store seeds so they can avoid rodents and therefore can avoid snakes, etc. And there was some study from Nepal which also worked at the community. So they map the area. So I think what our colleagues in Sudan did, mapping the problem, finding the factors locally, so doing local surveys, and then they used similar methods, and they use also a very nice method for early, let's say, referral by using motorbikes run by volunteers in communities. So actually there is work done, and yeah.
I'm going to ask for those questions specifically. Yeah, please pass the microphone to the lady. Okay, first the gentleman at the back and then the lady. And can I ask the other presenters for the session to please join us in the panel then? And Dr. Hilal Shah, I'm told, will also join us. I don't know whether he's... he is. He's carrying his own nameplate as well, which is very handy. So please join us here.
My question is, not all snakes are poisonous. So how many of those bites which were counted were of non-poisonous snakes? Because in India, mostly what we do in worked in rural areas, there are snake bites for poisonous and non-poisonous. So what I used to do, or we used to do in my tribal PHC area, we used to educate people. There were a concept called as Sarpa Mitra, which is a snake friend. People by these were recruited from the local community. They were taught how to catch a snake, and they used to go into the communities and tell them that all snakes are not poisonous. Educational material was developed, and this was circulated in the tribal area so that they don't get panic. What I had experienced was a snake bite patient came to me. She was a young female, and what the relatives did was they brought the snake in the bag and they put it on my table. This is the snake, you kill it, or you just test it, what poison would have been there. So to convince them, we have only one vial which will take care of every snake bite, but that snake was non-poisonous. But people insist that this medicine or this IV should be given to the patient. So if this vial or this medicine, anti-venom is so precious or production is so less, so we should communicate educate the community so that there won't be a usage or wastage of this anti-venom.
Thank you.
I don't want to answer this because I don't know really. But I just want to share this that I missed to present. In the green frame, our colleagues from Sudan said snakes are endangered species, protect us from rats and that carry many diseases. Do not kill snakes. So this, I think, answers partly that not all snakes have to...
Hi, I'm Kirti from Manipal. So basically, I saw an inverse relation between number of snake bites reported and CFR. Can you explain that phenomenon? Like, incidence rate was 1688 per 1 lakh per year, CFR was 4.4, and 3596 bites, CFR was 2.3. Is there any, why is it like that? Like, there is an inverse relationship, and does it have to do something to do with the source of data that you've taken?
Well, I'm not really sure I understood very well this question, but I think what the survey measured both the incidence of snake bites, any snake bites, and also how many people died after a snake bite in the community. So I don't know if we have to now to study the correlation between the two. It's a survey which collected this data, asking the people during the last year, was some of your household being bitten by by a snake, and or do you know of somebody in your household or who died after a snake bite? So I don't know if there is a relation.
Because what I asked this question because sometimes in the survey it can be misreported. A scorpion bite or a spider bite or any bite, insect bite can be thought of as a snake bite. It's possible.
Okay, sorry. You can have a misclassification of bites. Okay. Okay, so let's.
Sorry. So I have the
one more question.
The author on Skype right now. So he's actually
excellent.
About to answer it. Just hold on 1 second. Oh, he's not. Oh, he says no is the answer.
Okay, the answer is no. Douglas Adams said 42. Our colleague from Sudan says no. I think one word answer for that very complex question. We are now open for questions to any member of the panel for the next 10 minutes. As usual, please just show your hand and direct your question to any specific member on the panel, and just briefly introduce yourself as well when you ask the question. The gentleman in the blue.
My name is Parth, and I'm a professional consultant with a background in research. My question is regarding the study in Tehran. The topic which you referred is pretty sensitive to the society. Okay, now how the data was collected, because the data would be stated level, how you actually asked the question, whether directly asked, how it was collected from the respondents.
The familiar ethics committee didn't let the researchers to data collection door to door. And so the researchers selected randomly one public park and one neighborhood community center in every regions in different section of the city, and the people who were there encouraging to answer the question with the WHO questionnaire, and a skilled interviewer were used for this study.
Yeah, I got your point. What you referred is that it was a CLT-based study, central location test, and the respondents were asked the question. What I'm trying to come to point is, even we had conducted some studies which were very sensitive of this nature. Even in India also, if we are actually conducting such a study among adolescent students, we have to take certain measures. So one thought, it's a thought I think, and it works across, it can be self-administered questionnaire, which can be ballot box oriented. So anonymity would be there. And we can state that please be as transparent as possible. Your profile won't be revealed. It's just for the sake of a study. We want to understand the patterns, and that's why. So anonymity would be there, self-administered questionnaire that which will be within an envelope, and that can be put in a ballot box. There, the level of accuracy increases rather than getting biasness or might be underreporting.
Okay, thank you very much. I think we'll move on.
Okay, I want to explain about descriptive and about the qualitative methods can be better in these topics, but I'm not the researcher. I'm the researcher of this study, and I think nowadays Iranian people wants to talk more and more about the sexual, because of they have problems in sexual relations. They want to talk and they want solution in this topic.
Okay, I know that we're joined by another gentleman on this dais, Dr. Hilal Shah, who I understand has been a counselor with MSF in Kashmir for 12 years or so. So maybe I would like to just take the opportunity to ask you, first of all, welcome you to the dais, and to ask you, as a counselor, what has been the most dominant kind of narratives that you've heard to try and make some sense of these numbers that were presented in the survey in terms of the relationship between people's mental health distress and the kinds of lives that they lead?
Since we have, recently come up with these results, we're still looking forward, sir. So we didn't hear anything from the, people or from the, so it's too early to say, sir.
I mean, as your role as I understand you're a counselor,
yeah.
So I'm assuming you're also counseling people.
Yeah.
So leave aside the research,
okay.
Just to share from with us your actual first-hand experience as a counselor.
See, usually we see people with the depression, anxiety, and PTSD. Definitely, what we have, what research has seen, showed also, and. Unfortunately, people always come up with the physical complaints. They go to the doctors and they go to the psychiatrists, and they later refer to us. And when they find out that this person is going through the trauma, this person is going through the stress, then they refer later to us, and then we do the counseling to them. Yeah.
Okay, thank you.
Okay, I now have the response to the original question on snakebite. So it was to remind everyone, it was why is there a difference in case fatality rate? So I understand. So what the author has written, Mohammed Haider, is so the methodological implications in active case finding is that people tend to remember the dead cases first, while in exhaustive surveys it's easy to miss out on the dead case if the household was empty or if people left the household. I hope that's a little clearer than just no. Okay.
More questions for our panel?
Okay, for Kanika I have questions. So,
could you introduce yourself?
Yeah, my name is Yogesh. I'm an epidemiologist from Manipur. Sorry, I asked lots of questions. If panel got bored, yeah, I got lot of questions. Yeah, because leishmaniasis, because you selected two places. One place is border to India, it's Bihar, and we know Bihar is more prevalent for leishmaniasis, and it like disease don't know any border, it just cross. So you have in your analysis, have you like find any immigrants in there? My first question. You find any seasonal variations? The second one, and any trend in the epidemiological trend, because in 1970s when malaria in India, when malaria was more like in the verge of eradication, government implementing on malaria program, and that time leishmaniasis also came down with similarly in the 1960s to 70s. So if any national programs influencing on this leishmaniasis, because even during collection of data, if some goes well with the government and you may miss some data. So these are my questions. Thank you.
Thank you, Yogesh, for the questions. These questions actually I was supposed to be saying in the presentation, but then we had very short time. So for your first question, because one of the region is near to India, yes, we had some Indian patients too, and I would still include those patients in the analysis because the center that we saw the patients at is a referral center for the region, and we on day-to-day basis also treat Indian patients, and so we do not exclude them from the analysis because they do affect the prevalence of the disease in Nepal too, because visceral leishmaniasis is known to have a carrier state, and because of which, because if the person is a carrier, it's possible that if the person is bit by a sandfly, it can transmit the disease to another person. So we do not exclude those Indian patients. The other thing, seasonal variation, yes, we saw many cases in the rainy seasons, not only for visceral leishmaniasis, But even for the overall pattern, we had more patients enrolled during the rainy seasons. So we had just more of fever during the rainy seasons. And for the epidemiological trend, you mentioned malaria as the prevention against malaria was, it was evident that the measures taken for prevention against malaria that helped in reducing the visual leishmaniasis. If you see in the slides that I presented, we expected, as malaria was one of the target diseases, we expected to see a lot of malaria cases, but surprisingly we did not see any. So I could say that that's a change in trend, because generally we would treat the patient for malaria and we think it's still prevalent in the region, but a study that the one that we did was over 1.5 years and we did not see a malaria case, so which is surprising and which is good. It's a good result that we saw. And another thing for the trends, visual leishmaniasis is mainly known to be endemic in the plains of Nepal and near the border area of India. But nowadays we see many cases of visual leishmaniasis reported from the hilly regions too. And because the center is a referral center for visual leishmaniasis, so the patients that were referred from the hilly regions are also included in the analysis for the BPK IHS data for the ones from Dharan, which is closer to India. So there is a change in the trends in epidemiology, and we are seeing many cases of visual leishmaniasis now in the hilly regions too. And for malaria, there are not so many. And national programs, Nepal is heading towards the elimination of visual leishmaniasis, but the program is going on for a very long time, so I cannot say that the program has influenced the data, because it's gradually happening and it's not all of a sudden. And the study was not a very long study to actually say that the program has actually influenced a lot of the data. So it's a gradual thing that's happening in Nepal, that visual leishmaniasis is coming towards elimination. But yes, it is due to the program, but it's not drastically influenced our data.
Okay, well, thank you very much. I think we're quite, we'll take a last question, and then after that I'm gonna hand over to the organizers. There is a reception after this, and you'll have a chance also to ask questions personally to the panelists afterwards.
My name is Chanjeev. I'm working with MSF also. I have a question for Hilal. Hilal, seeing the presentation today and the scale, we realize what a big problem this is, and you have been working on this project for a very long time. Do you think there needs to be a bigger intervention for this problem?
Definitely yes. When we did this survey, and people have a lot of expectations from this, and for last 20-25 years, people are suffering from these issues, and there's except MSF, there is no one on the field for work mental health. So people have definitely lot many expectations, so that government should do something, and there should be some new clinics open for this. And we're even looking forward, even MSF is doing for longer time advocacy part also, so that government should start something. Yeah, I think during our recommendations also, when we did that round table, and so many recommendations came up that we should do further more researches, and we should start something. Yeah.
Thank you. I'm sure you'll join me in thanking this wonderful panel for this last session.
Yeah.
I think we can all agree this was a very interesting, enriching a day of presentations and discussions. It's very hard to summarize the scientific content, and I'm not even going to try and attempt to do that, but I do have a few observations. So MSF, as you know, is a humanitarian organization that provides free medical and health care to people affected by conflict, by natural disasters, by epidemics, and very often by neglect, right? Because MSF is a humanitarian organization, there's a perception that humanitarian medicine is very often charity medicine or second-hand medicine. I think we can very confidently say, given today's presentations, that is definitely not the case. The challenge, of course, is for us to simplify and field adapt what is very often very resource intensive Western medicine without sacrificing quality or sacrificing rigor, right? That's almost always the challenge that we face. And very often what we learn in medical colleges and what we learn in schools of public health is just a starting point, because very often we are going into uncharted territories. We have to learn a lot before we get it right. And so this culture of culture of carrying out research, whether it's a clinical trial like what is being done in Uzbekistan and what's being done in Mumbai, or it is operational research to improve the delivery of care, I think it is absolutely essential for an organization that claims humanity as one of its principles. I think it is important. Quality of care is, for me at least, the best expression of treating people with respect and treating people with dignity. Now, whenever I give talks, students and others stand up and criticize humanitarian action for not being sustainable. Right? So there's always this concern about sustainability. The assistance is not sustainable, it's band-aid, etc. My argument to that is always that sustainability does not always depend on the usual tried and tested capacity building big structures or training a whole bunch of people, does not always result in sustainable action. It is very often models of care that have been developed after rigorous research and rigorous practice and rigorous delivery that actually results in sustainable action. If you look at our history, HIV/AIDS, malaria, malnutrition, sleeping sickness, there are many instances that I can tell you that the models of care that we've developed in the field have been adopted, adapted, and scaled up by other agencies. They could be NGOs, they could be governmental agencies, and have reached many more patients than we have been able to do as an organization alone. And I think that is true sustainability, because as a small private medical humanitarian organization, I think it is impossible for us to reach all of the people who need care, all of the snake bite victims in South Sudan, all of the Hep C, people with Hep C. What we can hope to achieve is to be a catalyst for change. And in order to be a catalyst for change, I think it's important to do several things. First is innovation. I think it is clear from several of the presentations today that innovation is still important. Innovation in diagnosis, if we want to start diagnosing disease in children. Innovation in treatment, pediatric treatments, new drugs for TB, antivenom for patients, victims of snake bites. So innovation is absolutely important in diagnosis, treatments, antivenoms, vaccines, etc. The second is, of course, research. MSF used to shy away from clinical trials, but increasingly they are carrying out clinical trials, and it is absolutely important. I think the presentations on TB and the discussions we've had on MDR-TB in the morning is proof enough. I think there is much excitement in the field of TB now, just with 2 new drugs in the field, and I think we need more of that. We need more drugs. And this is, again, as the first panel stressed it very clearly, that these new drugs need to be made available to physicians and patients, hassle-free and much sooner than they are being made now. So I think that is important, the clinical trials that we do, but also more importantly, operational research. We know that early initiation is still a problem in HIV/AIDS, early initiation of treatment. We still are not able to reach certain high-risk groups. So these are all, I think, it's only through operation, it's only through actually providing treatment that we find out what the problems are, and then we can set out to address it. Then operations, I think, and also research on vulnerable populations, but also stigma. I think this came up a couple of times in several of the presentations. So I think this is also something that we need to pay attention to. And then lastly, advocacy. I think humanitarian medicine is ultimately political medicine. I mean, if we want to catalyze change, we have to take on the power structures, we have to take on the status quo, and we have to and we don't advocate for the sake of advocating, but we advocate because we see the need for a change in the environment. We need to fight for it for the patients. And I think that's what we try to do for MDR-TB, for hepatitis C. I thought was a very good session where you had one presentation talked about the science, Simon's presentation talked about operations, and then we had Lena talk about advocacy. And these are the three elements that we need to bring together in all of the work we do, all of the diseases that we do, all of the work that we do in the field, because very often we are working for populations that their voice is very often not heard, and we are, by virtue of being there, we are often the voice that articulates some of the problems they face. So I think this session was, I think today was a great illustration of the breadth of work we do, but also the quality of work. I think even compared to just last year, I think the quality of presentations have vastly improved. The posters and the discussion as well, and I'm sure that it's only our second year. I'm sure it's going to improve, vastly in the coming years. I just want to, Dr. Swaminathan said something that it's important for NGOs to work with, governmental agencies, governments, and other NGOs to sort of make sure that there's no duplication, make sure that we're doing the right sort of research and the right kind of work. And I think that is important as well, to build alliances, to build partnerships. And I hope that in the coming years that there will be more medical students, there will be more doctors, there will be more scientists, there will be more public health professionals attending these discussions. And it shouldn't be just about MSF research. It should be over the coming years, we should be able to have more and more people wanting to present at these meetings, and there will be a true exchange of ideas between us and between other institutions and agencies doing very good work as well. So thank you all. Congratulations for a very good day of discussions, and I hope to see you all again next year. Thank you.
Okay, Uni, thank you very much. I'll add a few more minutes to your time. Basically by saying that I think it was a very successful day, and that's mainly basically because of you. There was a lot of participation and active participation. Obviously that makes a conference, a day like this, successful. I just got some numbers just for your information. I think it's interesting that we reached quite a lot of people via our tweets. There have been people tweeting around, so to speak. Over 360,000 was the reach, as I understand. with about over 600 posts. So what that exactly means, I don't know, but I'm sure some of you know. I want to thank a lot of people, because a lot of people have worked very hard to make this day successful. I start, which I did already with the day chair, Uni. Thank you very much again, like last year, to be our day chair. Obviously, I like to thank all the presenters who came from far away or from closer by to present their scientific work. That's obviously the core of the day, so thank you very much. Presenters, thank you very much, the chairs of the day, and thank you for our keynote speaker who had to leave before the end of the day. And I also like to thank obviously our sponsors and our media partner, which is Healthcare Executive. Last but not least, I think I need to, and I want to, thank all the volunteers who have worked very hard, not only today, but much longer to make this day successful. And of course, the team of MSF India. There are many people involved in the different departments who were working to make this day come to a good end. And last but not least, I want to give a special thanks to Victoria. Right. Obviously, to Petros, to Safia and Zakib, who unfortunately could not be here, but he has also worked very hard, especially online, to make this day successful. Thank you very much. Again, I hope I can welcome you again next year. We will organize again Scientific Day next year. I also hope that we are able then to report back or to give you some more information on what happened actually with the outcomes of these studies, which we have discussed today. And also, which Uni has said this morning, it's interesting to know what you in the audience thought about today. So again, there is an evaluation form in your booklets, and it would be really very helpful if you give your honest feedback about what happened today. It will help us, as Uni said, to further improve the day, but also to broaden it to more organizations than the ones we met today. I think that's it. There is a tea and coffee outside, so you're very welcome to join. And only as of 7 o'clock, I understand there is some drinks. Before that, it's not allowed to being served, but after 7 it's being served. And people who would like to join us with those drinks, then you have to keep your badge on, apparently. If not, then you please leave your badge at the reception. Okay, thank you very much and have a nice evening.